Morning, everyone. Once again, it's a pleasure to welcome you all for this fifth masterclass in lung cancer. And it's a pleasure to welcome the organizing secretary, Dr. Taranjan Basu, senior consultant in radiation oncologist from the prestigious SCG Cancer Center, Mumbai. Can we request Dr. Taranjan to please setting the context and start the meeting, please, with his welcome note. Over to you, sir.
Good morning, everyone. At the outset, I must thank CRSF for this opportunity. It was last December a very casual discussion with Dr. Kumar, and which led to this workshop, first of its kind, and we'll have several repetitions now on. So the basic aim of this workshop is to highlight a few basic aspects of lung SBRT and brain metastasis from lung, few lectures, two panels, and one or two separate special lectures. We have couple of people online, about 4 or 5 of them. As we proceed, we will get to know. For few housekeeping announcements, you all can check out once the program is done. Please try and stick to time. We are already a bit late. So I have the pleasure to invite Dr. S.K. Srivastav. Sir, as we all know, has been ex-head of the department in Tata Memorial, and sir is now in my organization only, Director Radiation Oncologist in HCG Kolaba, and Dr. Sumit Basu, Senior Consultant and Head Radiation Oncology Department in Kokilaven. So please can start the session. Only one announcement, just one change in the program since Dr. Tanveer has his flight. So the whole program remains same, except we'll start with Dr. Tanveer's lecture. Sir, you can invite Dr. Tanveer. Thank you.
That's okay. Thank you, Taranjan. And again, we are also thankful to this really wonderful the master class in lung cancer and the entire team who have really done a very good program. And me and Sumit Basu, thank the organizer. And we are around 10 minutes late. So we will start very quickly on our session. The first lecture, as Taranjan has mentioned, will be by Dr. Tanveer Syed, who is the head of the department of in Apollo Multi-Specialty Hospital, Kolkata, and he is also the head of the academic and the research department. He is going to speak on the plan evaluation in stereotactic radiosurgery and FSRS. Dr. Tanveer, please.
So a very warm good morning to all of you. At the onset, I'd like to thank my teacher, my mentors, chairpersons, and Dr. Taranjan for giving me this opportunity to speak on this topic of concept of plan evaluation. To begin with, we all know regarding the characteristic of SRS, it's a highly conformal and highly precise plan with a high positional accuracy. It's focal with an ablative doses with a rapid dose fall off at the edge of the target. Now, when we plan, when we sit down to evaluate a plan for SRS, ideally, we all, what we do is that we review the target volume again. We also just see that all the OAS are contoured accurately, and we haven't missed or forgotten any particular structure to contour. And also you have to review the accuracy of expansion. That means many times it happens like while submitting the plan in the last moment, we tend to just tweak the GTV here and there, but accordingly, we don't re-expand the corresponding PTV. So that has to be taken care. Regarding the delivery technique, you can use any technique which you and your physicists are comfortable. It can be MLC based using VMAT or a 3D conformal or a IMRT, or it can be cone based. But basic rules remains the same. That is, the dose has to be sharp fall off with an inhomogeneous dose inside the PTV. Now, how to choose the technique? Again, what I said, what the clinicians and physicists are comfortable. VMAT, as we know, it's easy and it's a fast delivery, so your treatment time is less. If it's a 3D conformal plan or IMRT, multiple beams are used and it usually has a longer delivery time. You also have to keep the ease and comfort of the patient, because many a time it takes almost 45 to 50 minutes to complete the entire treatment, and that itself makes the patient very uncomfortable. So your treatment time somehow, if it make it faster, it's easier. CBCT, if cannot be done in the non-coplanar beam, so that has to be kept in mind. Regarding the dose coverage, adequate dose coverage, max, Dmax should be inside the GTV, and your prescription isodose should be 50 to 90%. What does it mean? I'll let you know in my subsequent slide. Now, normally in the Linac-based stereotaxy, you prescribe at 80% isodose covers the tumor with a 100% hotspot in between. And what does it mean? Like this is a tumor. You put multiple beams. After putting multiple beams, you get an isodose coverage, which is usually 93 to 95%. Then you again renormalize this to 80%. Now the tumor is covered with 80% isodose, and the hotspot or the 100% spot comes in between the tumor, and the periphery, that is the peripheral isodose which covers the tumor, is basically 80%. So inside the tumor, you're getting a higher dose, whereas the periphery gets a lesser dose. So this exactly means that 80% isodose covers the tumor with 100% hotspot. Now, what kind of a plan you want, whether it's a uniform plan or hot plan, it depends upon what is the clinical scenario and how is the target in vicinity to your OARs. That is important. So uniform doses usually means that entire PTV is getting a uniform dose, whereas core hot means the center of the PTV gets a relatively more dose as compared to the periphery. So can we always get a good dose distribution? Yes, it's possible if the tumor is isolated or away from the elegant areas. But if the planning target volume or the tumor is encroaching upon the OARs, then it might not be possible. Like here, the tumor is encroaching upon to the brainstem, so you'll not be able to get your desired distribution. So you have to compromise. So in these particular situations, what do you do? With the PTVs abetting the OAR, example, the brainstem, the first option is that you can compromise the PTV, or it's also called as cheating of the PTV, which is usually not recommended. The second option could be you don't compromise upon your PTV expansion, rather the parts which is overlapping with the OARs, you can just give a lesser dose to that or underdose it. And this is most commonly opted for. Now, concept of plan evaluation, if you see, usually we evaluate the plan by seeing the DVH, and it gives a 3D dose distribution, max dose, minimum dose, and the mean dose. But the disadvantage of the normal DVH, what we use is that it will not give you a spatial information. So what do you want? You want, if you want to really see the quality of the plan and also compare with the other set of plans and all these things, you are doing it for minimizing the normal tissue toxicity, as well as you want to get a maximum tumor control. So the ideal SRS plan is that your target should receive the prescription dose, whereas the edge of the target should ideally get 0 dose. That's the ideal SRS plan. And SRS plans are evaluated by visual inspection of the entire plan slice by slice, that is the dose distribution, also to see the DVH. In addition to that, what makes SRS plan separate is that you also use plan quality metrics, which can be used for comparing with other set of plans. Now, coming on to the plan quality metrics, if you see the first metric, what everybody uses is conformity index, and conformity index is the most simplest, and RTOG conformity is the simplest one. It is just defined as the ratio, that is volume of the tissue receiving the prescription isodose volume. Like here we can see the target volume, and target volume is encroached upon by the prescription isodose volume. So prescription isodose volume divided by target volume is giving me the conformity index, and it's usually 1. And if you are seeing the ICRE conformity index, it's just the reverse, that is target volume divided by prescription isodose volume. So what do we want? Target volume should adequately be covered by the prescription isodose volume. Now, let us see the ideal plan. Ideal plan means the target volume is being adequately covered by prescription isodose volume, and this is the ideal plan. And the next set, if we see the target volume is not able to cover, is not being covered by the prescription isodose volume, and here conformity index is less than 1. So this is under treatment. And the final one, if we see the prescription isodose is crossing and it's encroaching into the normal tissues. So here the conformity index is more than 1, but you are irradiating so it's an over treatment. But there is a disadvantage of the RTOG conformity index because it's based on the volume. If the target volume and the prescription isodose volume matches, the conformity index is 1. That's fine, the left one which you could see. But if you look at the next set, all the sets, if you see, the volumes are matching and conformity index is 1. And the worst part is this one, where the volumes are same, but it's not even matching, but still the conformity index is 1. So this is the flaw of the RTOG conformity index. So in order to get away with this flaw, we have to take some other metrics into account, and that is radiation conformity index or under treatment ratio. Now, what do you mean by under treatment ratio? It means that target volume covered by the prescription isodose. So we can see the target volume and we can see the dotted line as the prescription isodose. And so this is the target volume which is being covered by the prescription isodose, but the base of the target is not being covered. So this is the under treatment ratio. Now, if you look at the next metrics, that is over treatment ratio, that means the target volume, which is covered by the prescription isodose volume. Again, this, what you can see, this is the target volume, which is covered by the prescription isodose volume. But again, the dotted line is going into the normal sets of tissue, that is normal tissues, that is over treatment ratio. So this is an under treatment ratio and there is an over treatment ratio. Now, if you look into the next metrics, which we all bank upon, is Paddy conformity index. Now, Paddy conformity index is exactly the multiplication of under treatment ratio and the over treatment ratio. If you multiply these two entities, you'll be getting the Paddy conformity index. Paddy conformity index, ideally it should be 1, but it's more or less, it's always is less than 1. It gives you an information about your target over coverage, under coverage, and if there is any misalignment. Now, if there is any misalignment, you might not exactly immediately attribute it from where the misalignment is coming, but you'll be having an idea that there is a misalignment. And if the Paddy conformity index is usually from 0 to 100, and if a plan has 0.95 of a conformity index, means it is 95% conformal plan. Now coming on to the gradient index. Gradient index is just an English word. Gradient means how the dose is being fall off at the edge of the target, how the dose is following. And it's specifically steepness between the prescription isodose and the 50% isodose. So this purple dotted line is the 50% isodose line, and this is the prescription isodose volume. Now, Paddick gradient index means prescription isodose 50% divided by prescription isodose volume. Now, why this is important? Because gradient index, it gives you a measurement of the compactness of your isodose volume, like how is your dose fall off, how sharp is the dose fall off. As I said, in SRS, the dose fall off has to be very sharp. So that is the ideal SRS plan. So ideal value of a gradient index is around 3. So the coming on to the next, when you are evaluating the dose distribution of your SRS plan, you set your eye on the dose distribution, you are owning your color wash, you are seeing it in absolute volume, you are thoroughly passing slice by slice, and you are evaluating the desired isodose curve, like 98%, 100% or more, whatever you want. You can go slice by slice, look for the hotspot location. At the same time, just check that where is the hotspot and how far away is from the OARs. And if it is well apart, fine. If it is encroaching and not acceptable, you have to go for a re-optimize. After this is over, you also will have to look for the low dose, because that will be giving your gradient index. So just see where is your 50% or whatever you want to see, 20% or 5%, that you have to see. And according to that, you have to document and then evaluate the plan. Now, this is the Fliginger table, which we all know, and why it is important, because it gives you the V12 gray, and V12 gray is a surrogate marker of radionecrosis. Now, V12 is usually it is used for single METs. If it's for multiple METs, then V12 is ideally it is not. It should not be used. For multiple METs, ideally V18 has to be used, and V12 for single fraction SRS plan, it has to be 5 to 10 cc. And if V12 is more than 10 cc, you have to basically reevaluate your plan. So this is a
2 minutes.
Yes, I'll complete that. So coming on to the case capsule, so let's give an example. This is a lady who presented with neurological symptoms, excellent general condition, and MRI was done, and it showed an 1.8 centimeter ring enhancing lesions in the pontomedullary junction. CT scan of the chest showed the breast lesion. Metastatic workup was done. It was diagnosed as a CA breast with a solitary brain mets, no other mets elsewhere. Biopsy was positive, and it was a TNBC. Now the patient was taken upfront because of the management of the brain SOL. How to manage this brain SOL? That's the question. Patient was started on steroids. The lesion is non-operable because of the pontomedullary junction location. Given the size, both the option was possible to give single fraction radiation or give a fractionated radiation. We were more conservative and we planned for fractionated SRS was planned. Dose was 25 gray in 5 fractions and 100% of the prescription dose was covering to the 99% of the volume. Now, other fractionations for single fractions, depending upon the volume, it could be 15 to 18 gray or even 20 gray, or in a fractionated form, it could be something else. Multiple non-coplanar beams were used in planning. As the lesion was encompassing the brainstem, again, the dose distribution was taken into account so that the brainstem gets the dose which is acceptable. V12 gray, as I told, is a surrogate marker, but in this we use for the V18 gray. These were the parameters what we got from the target volume, the PIV and all those things. So this is what the center line is the prescription isodose volume, and the 50% isodose prescription isodose is the green line, and the brainstem received 25.5, that is D1 cc, 0.1 cc was 25 gray because the prescription dose was 25 gray. The V18 was 2.6 cc. So if you tabulate everything, this is what comes as a A, because everything is given by the system. You have to just tabulate it and document it. So to conclude, conformity index varies by target volume. Conformity index for small tumors are higher than for the larger tumor. It is well accepted. And if it is a larger tumor and still you have an excellent conformity index, then you are definitely bound to have V12 gray as high. So you'll have to be careful in that. On conversely, if conformity index is even more than 2, but the size of the SOL, size of the tumor is very small, still it's an acceptable. We should always first visually assess the plan isodose curves slice by slice, and then go for just to check that prescription dose and the target, how the dose is being fall off, what is the dose to the OARs, and finally the low dose pill. Following metrics should be evaluated, that is RTOG conformity index, your gradient index, your fall-off index, your Paddock's index. V12 gray should be used for single fractions. V12 of more than 10 cc, consider for a fractionated SRS rather than single. Mean dose to the healthy brain, always have to follow the principles of ELARA. And finally, homogeneity of the plan is not considered beneficial because many of the times your plan itself is inhomogeneous. With this, I conclude. Thanks a lot.
Thank you, Dr. Tanvir. And I think we have time only for one question if anybody has. Actually, this lecture was supposed to be later. Plan evaluation doesn't come in the beginning. But then because Dr. Tanvir has to urgently leave, therefore we took this lecture. So somebody, if anybody has any question, please ask. So any question? Thanks, Tanvir. Only my small question is that still, I mean, with different types of CIs you explained, finally we calculate RTOG CI also, we also calculate only for documentation sake. Ultimately, it is going to be how we perceive the plan actually.
Correct.
Based on our experience, now we are converting it. And all that basically, isn't it?
You want to add anything, ma'am? Thank you, ma'am.
So I think the gradient index varies according to the volume of the lesion. That is one thing which has to be kept in mind. Rest everything was very well said. Thank you.
Thank you, Tanvir. Thanks a lot. And yeah, so now we go on to the as per our plan. So I invite Dr. C. Anand Narayanan. Is he there physically present? Yeah. Okay. So Dr. Anand Narayan is the Chief of Radiation Oncology at the G. Kuppuswamy Naidu Memorial Hospital, Coimbatore, and he is going to start with lung SBRT. We are going to start the session actually lung SBRT basic aspects and practical considerations. So his lecture talk will be on simulation, including motion management in lung SBRT.
Good morning, everyone. I thank the organizers for the opportunity and thank for the kind introduction. So today's workshop was supposed to start with this. So again, we are starting with the simulation of lung SBRT. So as far as the SBRT of lung goes, we can do it for primary early stage lung tumors or for lung metastasis. It is the standard of care for a early stage non-small cell lung cancer, which is deemed inoperable. Having said that, there is no strict criteria for inoperability, and it has to be taken through a multidisciplinary discussion. And for the operable patients, we are yet to have a successfully completed randomized control trial or a head-on comparison with lobectomy. But single-arm trials and observational studies have shown that the local control rates and overall survival can match up to 90% over 5 years, which is as similar to patients who are undergoing lobectomy. So we will not be addressing the lung metastasis part this time. So as far as the patient selection goes, the recommendation says that the patient's performance status has to be at least 3 or better with a life expectancy of more than 1 year. And we have to anticipate a higher lung toxicity if the patient has got an interstitial lung disease. And the age, comorbidity index, presence or absence of COPD, obstructive pulmonary disease, and the pulmonary function test has no bearing in patient selection as long as your dosimetry is achieved. Tumor selection goes preferably less than 5 centimeters. More than 5 centimeters have also been successfully treated with SBRT. N0 disease and peripheral location versus a central location has its bearing on dose prescription as well as dose per fraction, which will be dealt subsequently. And as far as the technical factor goes, we need a linear accelerator with in-room volumetric imaging and a 4D CT. We should have some motion management strategy, which we'll be dealing, which will come in the subsequent in this presentation. And the presence of a dedicated linear accelerator with a robotic arm or a triple F beam or a 6D couch, it adds value or adds dosimetric advantage to your planning, but it is not necessary to start your SBRT program. What is absolutely necessary is to have a written protocol and proper quality assurance protocol as per task group 101. Planning imaging has to be taken in the treatment position. I mean, there's no doubt about it. We have to cover the entire lung from the cricoid to L2, and a slice thickness should be preferably thin slice 2 to 3 millimeter for an accurate delineation as well as an accurate DRR reconstruction. And a plain CT is adequate. Sometimes we might need a contrast enhanced CT or a PET CT to delineate the tumor accurately if they are centrally located. I mean, they are merging with the mediastinal structures or they are infiltrating the chest wall. So if we are doing a PET CT planning, then we have to, it has to be taken in the treatment position. And we also have to account for the missed registration that can happen due to the respiratory motion if the PET and the CT are not acquired simultaneously. And a 4D CT is recommended to quantify the tumor motion. Positioning, as for any other simulation, it has to be a stable position, reproducible and comfortable position. Lung SBRT goes usually a supine position with arms above the head is recommended because that gives you the maximum freedom for selecting your beams. The presence of a knee support and knee rest and arm support can help in immobilization. Whether to use a thermoplastic mask or a vacuum bag is again one's own preference, but there is some data to say that the cast have a better technologist comfort. They are easy to set up using a cast than a vacuum bag. Having said that, SBRT has been delivered without any cast or vacuum bag as well successfully using image guided setups. So immobilization devices that we use in our clinical practice, we have to set in our institute, it has to be tested for interfraction variations. And the tumors can shift up to a centimeter with respect to the bone. So setting up only on the external fiducial markers or the bone-based setup is not adequate. So we need some amount of in-room volumetric imaging, CBCT preferably, before any SBRT treatment is started. As far as the intrafraction motion goes, the motion that happens during the treatment is usually less. Average around 2 millimeter, but it also depends, varies according to the immobilization device that you use. And the intrafraction movement increases with the higher the treatment time, the higher is the movement, and higher the respiratory excursions, higher could be the movement. But what we are more concerned about is what happens during the respiration, because that's very highly variable, and it varies between patients, varies between the location of the tumor, and varies between the size of the tumor. And this is the data. So, the famous picture which shows that the upper lobe tumors move lesser than the lower lobe tumors. But this also we have to take into account that the smaller tumors can move more than the larger tumors. It has been shown that the movement can be as high as 5 centimeters in the lower lobe tumors. So as we take for any other site, a population-based ITV or a PTV margin is completely inadequate. So the margin has to be patient specific and the tumors, for that patient. So we need to have a patient specific motion assessment and an appropriate motion management strategy to do this. Can we play the video? Sorry, again, an Apple versus Windows conflict. Yeah. So this is a 4D CT. Thanks, Dr. Moses, for the last minute video. So this 4D CT is nothing but a CT scan that is taken at different phases of respiration. So CT scan, the patient undergoes CT scan multiple times. CTs are taken at different phases of respiration, and then the computer bins or sorts the CT sets as per the. So in the end, you will get something like 10 sets of CT, and each CT will represent that patient's position in that particular phase of respiration. For example, if we start the respiration, so if we start at the top, the inspiration, the deep inspiration, and we go to the end expiration, again deep inspiration, that is, this is one cycle. So we get 10 sets of CTs, one here, one here, one here, one here, and this is 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. So this is what we are going to get. So again, based on that, we are going to decide on what kind of motion management we are going to adopt for the patient. So there can be motion management strategies can be two types. One is a passive strategy, which is very simple. So we find what is the total motion, and we can give a MIP, that is maximum intensity projection. That will give you a single shot picture of what are all the position the tumor can be throughout the respiration. So you just treat all those areas. So it makes sure that you don't miss the tumor. But the problem is, at any single point of time, you will not be treating only the tumor, you will be treating a good bit of normal tissue as well. So that is an ITV concept that works better if your tumor motion is very less than 5 millimeter motion. So you'll be radiating very less of normal lung. Or other strategy is it has been used as a mid position approach, which is nothing but a time average position. So it's again a voxel by voxel reconstruction of a tumor at different phases, and it will tell you a time average position where the tumors are. So we take an ITV, and that motion is just taken as a random error. So that is another approach, and we don't have a direct comparison of any of these two between these two strategies. But what is common to this passive strategy, it always results in a larger PTV than an active strategy, and it results in a higher doses to OAR. But the advantage is it results in we can give the treatment faster, and both approaches have shown to give a good control. As far as the active management strategy goes, we have multiple strategies. Again, there are no head-on comparisons. This is vendor specific. Each institute have one of them, and people are comfortable with a particular strategy. So we can either use a breath hold technique, which can be a voluntary breath hold where the patient holds their breath themselves, or it could be an active breath hold where we use a spirometer or a valve to control the breath. And the breath hold can happen either in an deep inspiration or in an end expiration. A deep inspiration is a little bit difficult in lung cancer patients because of the associated lung problems. So maybe we might use a moderate inspiration. The advantage of end expiration is it is supposed to be the most stable phase. So because we are going to use an external marker over the skin, and that is going to be used as a surrogate to determine how the tumor moves inside. So this is supposed to be the most stable phase, the end expiratory phase. The advantage of breath hold technique is it's fairly faster. You can complete the treatment fairly faster. Or you can go for a spontaneous breathing where the patient breathes normally, and we decide on where to treat that, which phase of the breathing cycle we are going to treat it. So again, we can use either an external marker, which is commonly used. I will show the picture. Or we can use an internal marker that is implanted using invasive techniques. So the your machine, there are vendors who provide, planar X-rays are taken during radiation, and it gives you a accurate position. So, or we can use something called as a respiratory tracking, where there is a robotic, gantry, which moves according to your respiratory movement, based on prediction algorithms and intermittent X-rays. Or you can use the MLC, where the MLC moves according to the respiratory motion. So the advantage is the choice. The choice of this, it depends upon whatever is available in your institute. Not everyone has got all of this. So technical availability, one's physician preference and experience. But what is common to all this is it results in a smaller PTV compared to the passive strategy, but it results in a longer treatment time. It also requires robust quality assurances and a good patient cooperation to successfully treat this using these techniques. So this is an example of a deep inspiratory technique where the patient breathes normally and then pulls up his breath, and you treat between this. Once your excursions go between this orange and the blue line, and the patient starts getting treated. So this is actually a breast treatment that I have used here, not for the lung. It's very hard to achieve this kind of excursion in lung cancer patient anyway. So this is a gated technique, which is where the patient breathes normally, and we decide on which phase of breathing cycle to treat in. So here we have chosen an end expiratory technique. The problem with an end expiratory technique is your lung volume is smaller. So probably you are achieving your proper dosimetry is difficult. Whereas in an inspiratory technique, because your lung expands and the target moves away from the mediastinal structure, so achieving your target becomes easy. But expiration is fairly stable phase. If you can see, the inspiration can go up. One inspiration can go a little bit up, and another inspiration can be shorter. I will show one video of that also. So this is a treatment that was done in an expiratory phase. So,
2 minutes are left.
yes, sir, I finish. So this is again video of yeah. So this is again expiratory treatment. You can see that the inspiration is not equal. It's not at the same level, whereas an expiration is fairly stable to treat. So this is what we use. It's again I've taken example of breast patient. So this is a marker on the chest wall with an infrared camera monitoring its movement, and the movement of the marker gives you that graph that we saw in the last slide. And this is something we use. This is an in-room monitor. It's just a simple monitor that we use a VGA cable to connect from our console to this screen. And whatever the respiratory tracing that comes in your console is just reproduced in the screen inside the room. So the patient can actually watch their breathing, and they can they can modulate their breathing accordingly. So this we have been adopting. This we have been using for the last 5 years, mostly for the breast. Almost 100% of my patients are breast patients, and this considerably reduces our training time, considerably reduces the error or the variations in your respiratory movement, because the patient actually sees what they are breathing. And this is what happens inside the treatment console. This is just a picture taken from the couch. It's a ceiling mounted monitor that again gives you that reading. Whatever happens in the console, the patient can actually see what is happening. And that disadvantage of this method, with advantages, it's fairly cheap. We took this monitor from the laparoscopy, which was lying idle, and then we connected a VGA cable, no cost involved. The disadvantage is this is fixed, and when the gantry, this is we have kept it a little bit to the right side because we use most for the left breast patients. So the patient is going to turn their head to the right, so it will be a little bit on the right side of the right side in the ceiling, and the patient will not be able to see the monitor somewhere around 320 degree gantry to around 20 to 30 degree gantry. So that's a big disadvantage. But anyway, 99.9% of my patients are on anyway. The gating patients are breast, so you're not going to use that gantry anyway. This is your 4D. This is your 4D CT movement. This is the tumor, and this is movement. This. I want to show this video because this is a patient where it was deadline. The patient was the tumor was hardly moving, so we used an ITV concept for this patient. So in summary, it starts with breathing training, which is very important. Without training, you can't do gated treatment. So there are multiple vendor softwares available. But I found it, the Caucasian accent was very difficult for our patients. So we used our own audio recording to use this breathing training for the patient. And the immobilization has to be chosen, and we take an 4D CT and or a fluoroscopy to quantify movement. If your movement is not so high, then you can use an ITV concept or any other passive motion strategy. And if you want other motion strategy, you take another CT scan with an appropriate motion strategy, either in a deep inspiration or an expiration, or with a free breathing and a gated technique, and then go for delineation planning, which will be dealt in the next talk. Thank you.
Thank you, Anand. Since we are running a little late and there are 6 lectures in this, I think we'll have the question answered at the end. Since this is the same topic of lung SBRT, from the various aspects on the basic and the practical consideration, we'll go ahead, keep your questions ready. And now I think we'd like to invite Dr. Shikha Goyal. She is the assistant professor in PGI Chandigarh. She is going to speak on contouring of the primary and OARs. And I request everybody to stick to the time. You have given 15 minutes. Thank you.
So Dr. Anand has already dealt with the patient selection as well as target selection, so I will not deal with these. For simulation, the only tip is that when you are simulating, the FOV should include the entire chest, skin to skin. So that is one thing that has to be kept in mind, especially for bulky patients. And the patient's position should be very comfortable because these treatments are typically long. So the patient should be able to lie down in the planned position for nearly 20 to 30 minutes. So these are the steps in delineation. Every time when we are seeing any phase, any step in SBRT, we should review the diagnostic imaging, the simulation imaging, compare them for any changes in the interim period, look at the number of lesions as well as the tumor location. I'll deal with the target delineation and the OAR delineation in this order. So for gross tumor volume, we know that the lung tumors are mobile tumors. So the true GTV estimation can be done only when the lesion is relatively stable, as in a breath hold scan, or if it's a 4D CT, a single phase of 4D CT. So that gives the true estimate of the volume of the lesion, because motion will create blurring artifacts and there will be larger inter-observer variation if we do not account for single phase treatments. So for delineation of gross tumor volume in lesions which are surrounded by the lung parenchyma on all sides, typically a pulmonary window is used with a window width of 1600 and a window level of -600, and include all the tumor speculations. Always look at the tumor in all the projections, because something that looks like a speculation in one of the projections may actually be a vessel which is touching the tumor. So that vessel does not need to be included per se. And lesions which have an interface with the mediastinum or the chest wall, typically a mediastinal window is used to correct the GTV in that area with a window width of 400 and a window level of -20. We can also see that when we compare the lung window and the mediastinal window, we will look at the discrepancy in the volumes. So the volume within the lung parenchyma should correspond with the lung window. The volume at the interfaces should correspond with the mediastinal window. And one should avoid inclusion of any adjacent vessels, atelectasis, or mediastinal or chest wall structures. If there are any suspicious pleural tags, typically type 2 tags where there's a soft tissue component at the pleural end, these tags should also be included as part of GTV. If the lesion is closer to the chest wall or close to the mediastinum, IV contrast may help delineate the lesion from these, also identify the vessels which are organs at risk. And also there may be sometimes For central tumors, there may be peribronchial tumors where atelectasis may also be present. So it is important to distinguish this atelectasis from the gross tumor volume. Sometimes PET may help. PET is usually not used for SBRT because we typically select smaller lesions. We typically select lesions which are very well defined, but in certain situations, it may be useful. We don't have a CTV concept in SBRT. Typically, the CTV is equal to GTV, and we assume that the microscopic disease would be taken care of with the intermediate doses. There is a concept of IGTV akin to the ITV in the conventional planning, where we look at the motion of the GTV in all dimensions and encompass all that motion and call it IGTV. So even if we are using DIBH, where we assume that the tumor is stable, there will be some residual motion. So that residual motion should also be encompassed while delineating or while generating the IGTV. Once the tumor size changes, on the right-hand panel, we can see that the IGTV volume also increases. So if you're using MIP projections or we are using multiple phased scans in target delineation, we have to take into account that we'll be treating more and more of normal tissue as we use the IGTV concept when we're using MIP projections. Usually, MIP projections are not good for lesions which are close to diaphragm or which are close to the mediastinum because the interfaces will change. The relationship of the tumor with that interface will keep on changing with the different phases of respiration. The spine movement also is different when you're using MIP. So in those situations for planning purposes, it is recommended that we use the average intensity projection. We mark the tumor on MIP, but we use the AIP for the rest of the planning process. Depending on the treatment planning technique or the motion management technique, the IGTV may vary. I've already talked about the IGTV using 4D CT as well as using breath hold. But even when we are using tracking or gating, additional 2 to 5 millimeter margin may be given to account for the uncertainties in reproducibility of breath pattern or any other position or any other uncertainties. So this is a delineation of the image where I have used two extreme phases. We can see that the tumor is moving more medial lateral and not towards the chest wall, although this is not an ideal scan for MIP kind of treatments, but here the chest wall movement was not as much as the tumor movement. So we have to make sure that if you are estimating the tumor on all of the respiratory phases, the MIP images corresponds to that, at least when we are starting out with the SBRT program. And for patients with lower lobe tumors where the lesion is closer to the diaphragm, abdominal compression and DIBH may help to reduce this IGTV compared to the MIP projections. PTV typically will encompass this IGTV and also give an additional margin for setup errors. This should be determined by an institutional workflow and the setup conditions in that institution. Conventionally, 5 millimeter in all directions is recommended over IGTV, but this is, as I said, it is variable. If our institution does not have a lot of equipment where, or we are not certain of the treatment situations, a higher PTV margin may need to be given. In protons, usually PTV margin is not used for planning, but may be used to evaluate conformity. The organs at risk should always be drawn in axial planes of the primary planning data set. All the serial OARs within 5 centimeters craniocaudal extent of the PTV should be taken. But if you're using non-axial beams, even distant OARs may need to be delineated. All the parallel organs like lungs, liver, kidneys must be contoured in their entirety, even if the relative part of the OAR is close to the tumor is smaller, and nomenclature should be standardized. This is a standardization on the right-hand panel given by the Global Harmonization Group consensus published a couple of years back. So trachea is simple. Only take care that you also include the tracheal wall and the adventitia. And typically when you're contouring only trachea, we take the segment of trachea till 2 centimeters above the carina. The proximal bronchial tree is a very important structure in lung SBRT. It includes the distal 2 centimeters of trachea, carina, as well as the main stem and lobar bronchi. On the right side, first it is the right main stem bronchus. It gives the upper lobe bronchus and then continues as the intermediate bronchus. And this intermediate bronchus also gives rise to the middle lobe and lower lobe bronchi. On the left side, the main bronchus gives off the upper lobe bronchus, and then also the lingular and lower lobe bronchi. So till the lobar bronchi, we have to delineate. But further segmental bronchi do not need to be delineated when we are drawing the proximal bronchial tree. We give, these are the delineations on one of our patient. And we give a 2 centimeter margin to this outline. And this is what is used to determine the definition of peripheral versus central tumors. All tumors which are outside this 2 centimeter envelope are called peripheral tumors. Those within, inside this envelope, but still 1 centimeter from this tracheobronchial tree are considered central. And those which are inside that 1 centimeter are called ultracentral tumors. I'll spend a minute on the brachial plexus. Although the delineation is best on an MRI, that too on a coronal projection, but we have to make do, we can at least be 3 to 5 millimeters certain regards its position on a proper CT scan with contrast. So usually it is used only for tumors of upper lobes, and only the ipsilateral brachial plexus will receive a significant dose enough to be spared. So it includes the spinal nerves exiting the neural foramina from the C4, C5 junction till T1, T2 junction. So it has 5 roots, and even if the entire brachial plexus is not drawn, at least what lies within 3 centimeter vicinity of the PTV should be drawn. So we know that from anterior to posterior, if we look at the axial projection, it is vein anteriorly, then artery, then nerve. Veins and arteries will pick up contrast, nerves will not. So for a contrast scan, whatever is lying posteriorly and superiorly to the vein artery complex will be the brachial plexus nerve complex. So here we can see on the coronal projection that this vessels and nerve complex will go over the first rib and under the clavicle, and we can easily distinguish this with practice. So roughly we can contour these positions on a coronal projection and then look at the vein artery nerve relationship on an axial projection to identify the brachial plexus. IV contrast is highly useful in this delineation. And for contouring the upper part, we know that it has 5 roots, as I said just now. So wherever there are neural foramina for the corresponding vertebrae, the part which is exiting the neural foramina and it is passing through the anterior and the middle scalene muscles, that is to be delineated. And wherever the neural foramina is not present, only the part between the scalene muscles is included. So you can start at the top for the first root, then go to the bottom for the second root, and use the intermediate 3 neural foramina for the rest of the contouring. So esophagus and spinal cord are fairly simple, but we should try to include the entire length, esophagus from the cricoid till GE junction. And for spinal cord, it is typically recommended that we delineate the spinal canal and not just the cord, because we are not usually using the MRI for spinal cord delineation. The lungs should be contoured separately as well as combined. Use lung windows, include all the inflated and collapsed lung, all the emphysematous area, but also include the small vessels which are extending beyond the hyla, but typically lung, hyla, GTV, and trachea main bronchi are not included. Heart and pericardium also have to be included mostly for central tumors or ultracentral tumors. And this is given in the guidelines by RTOG as well. So this can be taken. The entire pericardium as well as the pericardial recesses should be included. Chest wall, ribs, and skin are simple, but all of these should be drawn. Chest wall, a 2 centimeter thickness around the lung is recommended to be included. Ribs only for Dmax, and a 3 to 5 millimeter in just inside the body structure will help reduce the skin doses for exit and entry of the beams. Some work in progress that the Medanta group and we are doing for delineation of phrenic nerve and recurrent laryngeal nerves as well. That's all. Thank you.
Thank you, Dr. Shekhar, for an excellent presentation and very, very useful. Especially, I mean, all of us are learning, of course. SBRT is still, it's an evolving thing. So excellent. Thank you so much. And we'll take the questions at the end as decided by sir. So the next, I think, is online. Is it, Dr. Niranjan? Arun is present? Oh, hi. Hi. So Dr. Moses Arun Singh is going to talk about dose prescription. And Dr. Moses is a consultant clinical oncologist at the Tata Medical Center in Kolkata.
Yeah, thank you, organizers, for inviting me. So my talk is on dose prescription in lung SBRT. To my knowledge, there are 4 components as to what makes a dose prescription in lung SBRT. First up is the total dose, which is a function of the dose per fraction that we want to deliver and the number of fractions that we want to deliver the total dose in. And second will be how we prescribe these doses to the target volume. And third will be the timing of delivery of each of these fractions and the total fractions delivered. And the dose constraints that we assign to the organ at risks and the normal tissues. So first let's look at dose fractionation. There are 2 factors which influence total dose and the dose per fraction. First is the biological effective dose that is needed for achieving an acceptable local control rate within the tumor and also the location of the tumor within the lung. There have been several reports which have suggested that a BED of at least 100 gray or more is needed for achieving an acceptable local control rate, which is accepted to be around 90%. And this has been shown that if you deliver less than this, you have worse local control rates. There are fundamental differences in how various people have assessed this dose delivered. The Japanese group has, for example, looked at the isocenter BED, and others have looked at the BED that is delivered at the periphery of the target volume. But regardless of that, it is generally accepted that BED of 100 gray or more is needed for good local control. The second factor that influences dose fractionation is the location of the lesion in the lung. For a tumor that is situated in the periphery, these lesions are surrounded by entirely by lung alone, which is a well-known parallel organ, and it makes it relatively easier to deliver high doses of radiation per fraction. Whereas when we come to tumors which are situated more towards the mediastinum, we have to contend with serial organs like the proximal trachea, the proximal airways, the blood vessels, and the esophagus, and that has an impact on the fraction dose. First, let's look at peripherally located tumors. We have look at several guidelines. We have the ESTRO guidelines. They follow a 3 fraction and a 4 fraction regimen, depending on whether the lesion is away from the chest wall or in contact with chest wall. And these are all regimens which have a BED more than 100 gray and has been chosen to achieve a control rates of at least 90%. And these regimens have been validated in phase 2 trials as well and achieved the control rates of 90%. Then comes the UK SABRE consortium guidelines. They again follow a similar principle with 3 fractions and 5 fractions, differentiating based on the involvement of the chest wall or abutment of chest wall. The only difference from the ESTRO guidelines is that the total dose is slightly higher compared to the ESTRO guidelines. Apart from these guidelines, there are several dose fractionation regimens that are published in literature with good local controls and safety features. And these range from a single fraction regimen to an 8 fraction regimen. And you can choose any one of these for a peripherally located lesion. Coming next to centrally located tumors, this has been a more complicated pathway. From doing basically what we were doing for peripherally located tumors, we have become more cautious, and that is based on several high-profile publications. The first one was from the Timmerman group, which showed that if you deliver SBRT for a centrally located tumor, you have 11-fold increased risk of severe toxicities. And subsequent to this, you have several other high-profile publications as well. But there are several criticisms of these publications too. These were basically case reports and not prospectively designed trials to look at specifically these things. And the Timmerman paper, for example, when they did an updated analysis based on reclassification of the tumor location, the increased risk came down to just threefold higher compared to peripheral lesions. And also, the NEGM paper, for instance, did not mention the fact that this airway necrosis was possibly triggered by a biopsy being done for ruling out recurrence in that situation. So these were some of the criticisms of these papers, but regardless of that, it led to the definition of a no-fly zone, which was defined as a 2 centimeter margin around the proximal bronchial tree. But over the years, with the evolution of understanding of central structures, the definitions have evolved to include more and more centrally located structures, and also classification to central and ultracentral disease, depending on whether the target volumes are abutting or involving the central structures. Subsequent to those reports, there have been several retrospective data which have shown that it is possibly still safe to do SBRT for centrally located tumors. We have a meta-analysis which looked at nearly 600 patients from 13 observational studies. They had a local control of about 72% in 3 years. With a acceptable grade 3 or more complication rate of around 12%. Subsequent to this, we also have 2 phase 2 prospective trials. The first one is the Nordic Hylas trial, which delivered an 8 fraction regimen and stratified the patients included in this arm to 2 arms. That is the arm A, which is more like an ultracentral tumor, and arm B, which is more like a central tumor. And this trial showed that the grade 3 to grade 5 side effects were very high at 34%, with grade 5 side effects, that is death, noted in 10 patients out of these 73 patients. The conclusion was that such a regimen of 8 fractions is acceptable for arm B tumors, that is the centrally located tumors, but it is very high risk for high-grade toxicities in more ultracentral tumors. And we also have the RTOG0813. This is a dose escalation trial of 120 patients. They escalated a 5 fraction schedule from starting from 10 gray and escalated it by steps of 0.5 gray per fraction. It looked at dose limiting toxicity, which was defined as any grade 3 or worse toxicity occurring within the first year. And the maximum tolerated dose was considered to be the dose at which the DLT was closest to 20% without exceeding it. What they saw was grade 3 or higher toxicity was 16% in the 11.5 gray per fraction group, and was 21% in the 12 gray per group. And also grade 5 pulmonary bleeding toxicities were noted in 4%, and 3 out of these 4 patients were treated in the highest dose fractionation group. And these were the data that we had from prospective studies, taking into account all the evidence that we had. The guidelines, what do they state? The UK SEBA guidelines state that for centrally located tumors, there is limited evidence to say that efficacy or the benefit outweighs the risk when you compare it with a more conventional fractionation. And if at all you are wanting to do SBRT for a centrally located tumor, you go with a more fractionated regimen, like a 7.5 gray into 8 fractions. And they outright state that it is not advisable to do SBRT for ultracentral tumors outside of a clinical trial. And what does the ASTRO guidelines say? They again advocate against using a 3 fraction regimen for a centrally located tumor. And they suggest a prescription of 45 to 55 gray in 4 to 5 fractions. And for tumors where we would consider it to be very high risk, when we do SBRT, they suggest a more hypofractionated radiation therapy using a 6 to 15 fraction regimen. So now we have a dose fractionation in our mind, and how do we go about prescribing into the target volume? Again, there are wide variations in the way people have described this in the published literature. Some have prescribed it as a PTV encompassing isodose, and some have prescribed it as a volume-based prescription. Some have even specified it as a dose prescribed to the GTV. So different guidelines again have similar small differences. Estro goes with a volumetric prescription of the dose being prescribed to 95% or 99% of the PTV, with max doses to be kept below less than or equal to 125% to 150%. And UK SABR consortium guidelines, they're a little bit more descriptive. They want 100% to 95% of the PTV and 90% of a prescription dose to 99% of the PTV, with a max dose between 130 to 140%. And ICRU 91, which is for small field radiotherapy, they suggest prescribing to an isodose surface that covers the PTV to an optimal percentage of coverage. So the optimal percentage of coverage is up to us to choose depending on the clinical scenario that we are facing. What happens in real life usually is that you normalize to the maximum dose to be the 100%, and this maximum dose is ideally should be within the PTV. And then you prescribe your prescription dose to the 60% to the 90% of this maximum dose, and make sure that you have a coverage of 95% prescription dose to 100% of prescription dose to at least 95% of the PTV, and then 90% of the prescription dose to at least 99% of the prescription dose to 90% of the PTV. Timing of delivery. Most of the guidelines and publications, they have used an alternate day delivery, but you can range between 24 hours from a minimum of 24 hours gap to a maximum of not exceeding 4 hours. Some people have looked at if there could be any difference when we deliver it differently. There was no difference in terms of toxicity or in terms of survival.
2 minutes are left.
Yeah. Coming last to the dose constraints to the OARs, there have been several publications which guide us in this regard. First one was possibly the AAPM TG101 report. These were mostly unvalidated data, and which was based on educated guesses, theory, and some toxicity observation. 5 years later, we had the UK consensus guidelines, which was updated in 2017, which was largely based on the AAPM 101 report, and they have updated it recently in this year with inclusion of more clinical data that has been available since then. And we also have the high-tech paper, which have papers which have been summarized over the last decade, and they have tended to favor more of the clinical data that has been that are published, and also have based their suggestions on model-based data when clinical data is not available. So with that, we have prescribed our dose to the volume in SBRT.
Thank you, Arun. Very nice presentation, and I think as we discussed, we'll have the questions at the end. So we'll call next Dr. Anil Tibdewal. He's Assistant Professor in Radiation Oncology at Tata Memorial Center. He's going to speak on planned evaluation in lung SBRT. Anil.
Hello, hi, good morning, everyone. It is very good to see a house full of radiation oncologists, because since last 2 days I was just so within medical oncology and surgical oncology field, and it's very nice to see Dr. Shivasa and Dr. Sumit Basu also. So half of my work has been done by Dr. Moses, and I would like to thank him for that, because I will not have to make so much of a presentation here. So as we have learned about the OAR doses and the target delineation and the motion management, and so what are the doses that we need to deliver for lung SBRT depending on the location, I would like to say that for the plan evaluation in SBRT, there are some factors that we need to consider before we start the plan evaluation. So first one is the total dose. What is the total dose that you want to deliver in lung SBRT? What is the dose per fraction that you have chosen for the total dose, and the number of fraction that you are going to deliver, as well as the calculation algorithm in your treatment planning system. So that is also important, because it will have an impact on the local control as well as your dose coverage. And especially the number of beams or arc angle, if you're planning for IMRT or 3D CRT or the VMAT, then you need to consider the number of beams and the arc angle also. So first thing is I'll come directly to the point and not Matabush around here. Plan evaluation for the coverage. So for the target coverage parameter, we need to consider the V95 of the prescription dose, V99 and the D max as already elucidated. High dose spillage and the intermediate dose spillage that the R50 and D2 centimeter and the critical organ at risk doses. Here the critical organs as has already been mentioned is the lung, the cord, the esophagus, the bronchus, the chest wall, or the brachial plexus. Now, so when we want to evaluate the plan, there are two methods to do that. One is the slice by slice dose evaluation and the other is the dose volumetric histogram analysis. So, so when you are treating the lung SBRT, it is preferable to do both of them. So one by one, so first one is the slice by slice dose evaluation and also by the deviation analysis. It is not going to take so much of a time because we are treating a smaller tumor less than 5 centimeters. So hardly there will be 15 to 20 slices. We need to have a good look at each axial slice because there might be dose compromise at the craniocaudal target. And if we go by the RTOG 0236, so because the radiation therapy oncology group was the first one to do the prospective study in the lung SBRT, what they have defined in their first paper or in the first protocol, that the prescription isodose surface should be chosen such that 95% of the target volume is conformably covered by the prescription isodose surface. For example, RTOG 0236 has delivered 20 gray in 3 fraction to a total dose of the 60 gray for T1 tumors, and for T2 they have delivered 22 gray into 3 fraction. So V 100% of the prescription dose should be the 95%. So that means the 60 gray iso dose should be covered by the 95% of the target volume. And then 99% of the PTV should receive a minimum of 90% of the prescription dose. That means your target volume, that the PTV, 99% of the target volume should be covering a 90% of the prescription dose. So that is the 54 gray. So these two parameters, if we go by the RTOG 0236, should be achieved. And the iso dose should be chosen by more than 60% but less than 90%. So this was the iso dose-based prescription. We are choosing the prescription iso dose surface to be covered by the PTV volume. Now, so this is the dose volume histogram analysis. As you can see here, the 60 gray is being covered by the 95% of the prescription volume. So target volume is 95% and you are covering the 60 gray for that. And this is the 19% of the prescription iso dose, that is the 54 gray, and it is being covered by 100% of the volume, and it should be covered by more than 99%. So we are achieving this particular the criteria set up by the RTOG 0236. Now, what do you mean by high dose spillage? High dose spillage, there are 2 or 3 criteria for that. Any dose of more than 105% of the prescription dose. So for example, 21 gray per fraction. So that means the 63 gray in 3 fraction should be within the PTV. It should not go beyond the PTV. It should remain inside the PTV and not go beyond the PTV. So we need to take into that also in consideration. And the conformity, we have heard Dr. Tanvi Shahid's presentation in the morning. The conformity, there are various methods to do that. But here in the RTOG 0236, they have defined that the ratio of the volume of the prescription isodose to the volume of the PTV should be ideally less than 1.2. That means if your prescription isodose is of the 60 gray, then it should, and divided by the volume of the PTV should be ideally less than 1.2. For example, here the PTV volume is approximately 30 cc and your V100 is 34 cc. So if you divide by 34 divided by 30, it should be, and here it is coming out to be 1.1. So we are okay with that. It is less than 1.2. Now, so what is the volume should be when it is going outside the PTV? It will not be there that there will be no dose outside the PTV. There can be some dose outside the PTV of the prescription isodose. So any volume, so that is going outside the PTV, receiving more than 105% of the prescription dose, should be less than 15% of the PTV volume. Here, for example, the PTV volume is same as that of the 30 cc, and the 15% of 30 cc is 4.5 cc. So our volume of 105% of the prescription dose, that is the 63 gray, is only 2.4 cc. So 2.4 cc is less than 4.5 cc. So it is also reaching our objective of more than 105% of the prescription dose should be less than 15% of your PTV volume. Now coming to the low dose spillage in the lung SBRT, there are 2 methods to do that. First one is the location and the second one is the volume. When we talk about the location, we have to draw a 2 centimeter shell around the PTV. So that is the D2 centimeter. So it is the maximum total dose to any point 2 centimeter or greater away from PTV in any direction, be it the lung parenchyma, be it the chest wall, or be it the mediastinum, any direction. So for example, here the 28 gray ISO dose is covering the PTV of 2 centimeter. So this is the 28 gray here, the D2 centimeter. So what about the volume? The volume is given by R50%. R50% is defined by the ratio of the volume of the 50% of the prescribed dose. That means the 30 gray volume dose to the PTV volume. Here PTV is of the 30 cc, and for example, if the V50% volume is 110 cc, then the R and then the ratio of this would come to be 3.6. So where are these values have been written? So RTOG 0236 has given this value. Here the V20 is also less than 10%. I'll see to that. So this is the table that has been provided by the RTOG 0236. Here the ratio of the 30 gray, that is the R30 gray, is the R50. So minor deviation is 3.9 to 4.1 is the ratio, and the maximum dose is approximately 28.1. So this has been both given. So by the maximum PTV dimension as far as the tumor size is concerned on the left hand side, as well as the volume of the PTV. So these are the OAR dose constant that has been given by RTOG 0236. That was the 20 gray in 3 fraction, and RTOG 0915, which was a randomized control trial between 12 gray into 4 fraction versus 34 gray in single fraction. So this is the right hand side is the RTOG 0915. You do not need to remember all of this table. You can just take the snapshot of on your mobile and please check. So whenever you are evaluating the RTOG or the lung SBRT plan. But there was a fallacy in the RTOG 0236. So because it was started in the year of 2002, so many of the treatment planning system and the institute did not have the tissue heterogeneity correction in the treatment planning system or in the dose calculation algorithm. So when they retracted the plan from different institute whom they did not have the tissue heterogeneity correction and they applied the tissue heterogeneity correction, you can see the red line, the inside line is of the 100% prescription ISO dose, and the dashed line is the PTV 2 centimeter, and the solid green line is the 50% ISO dose. So if you apply the heterogeneity correction, the 100% prescription ISO dose do contract, and the 50% ISO dose expand due to the lung tissue heterogeneity. And what they have concluded that with heterogeneity correction applied, the volume of PTV receiving 60 gray or more was on an average, they decreased by 10% from 95%. So here they have taken the largest tumor size example. Here they have shown that the PTV was decreasing. Sorry. So here they have shown, if you can see my arrow here, here the volume of the 60 gray was covered by the 95% of the planning target volume. But here, if you apply for the tissue heterogeneity correction, it was only being covered by the 60% of the planning target volume. So the tissue heterogeneity correction is very much important in lung SBRT. So they revised their table. If you can remember, so this is the volume on the right hand side and the left hand side is the tumor size. Now, if you compare this, so for the 1.8 PTV volume in CC, previously the minor deviation was only 3.9 to 4.1. So anything which is more than 4.1 will be considered as the major deviation. But in an updated table, so because the R50 will expand, so they have revised their ratio up to 7. Okay, so this has changed from 4.1 to 7 because of the lung tissue heterogeneity correction. So this is the importance of dose calculation algorithm that you need to take into account. Now, so this is the prime example of the comparison between the equivalent path length versus the Monte Carlo system. Here you can see that if you use the equivalent path length, you are overestimating the dose that is being delivered in the lung. But in reality, if you calculate by Monte Carlo, it is actually lesser in lung tissue, and it is much more when you have, so when you are calculating at the edge of the PTV. If you see the center, that is the A type, here the equivalent path length is slightly overestimating the dose, but at the border of the PTV, because there is a tissue heterogeneity at the border of the PTV, the difference so between the reality and the overestimation by the equivalent path length is much more larger. Now, the dose calculation algorithm also impacts the local control. Has already been mentioned by Dr. Moses that we need to achieve a BED of 100 gray, but there are reports that the BED, if it is more than 130 or 150 gray, the local control can be more, so much more better. Now, it does not mean that we should not achieve the 100 gray, but if you are achieving the 90 or 96 gray, the local control will also be good, but we need to achieve a BED of 100 gray at least to have a good local control rate. Now, this is the RTOG 0813. So this is for the centrally located lung SBRT patient. Here, the ratio of 50% prescription ISO dose volume has slightly increased from 7.1 to 7.5 for the same tumor volume. So you do not need to remember all of this. You can just refer whenever you are doing a lung SBRT plan evaluation. So this is the dose constant that they have given for the central lung SBRT, because for many of the times, if you are treating a central lung SBRT, there will be organoids, so which are very close in contact with your planning target volume. So for the organoid risk, they have said that no hotspot should be within that organ. And if it is going, even if that organ is a part of the PTV, then OAR should receive more, no part of the OAR should receive more than 105% of the prescription dose. And they have given for the spinal cord, ipsilateral, brachial plexus, lung, esophagus, heart and pericardium, all the dose per fraction and the maximum dose that should be achieved, or it should be less than that, that you can consider this table. Now there is, and so there is a concept of the ultra central tumor, because if you are going to do so, because in RTOG 0236, which was published afterward in the year of 2014, so before that, Timmerman et al. Has already said that there is a no-fly zone, that the proximal bronchial tree and 2 centimeters around it. But so with time, we have changed our dose per fractionation for the central and the ultracentral tumor. Here you can say that the ultracentral tumor are any tumors where your IGTV or ITV is either overlapping or abutting the critical OR structure. So this is a sunset study which is being ongoing in Canada. They are evaluating the dose per fraction. It's a dose escalation study from 5 gray to upward of 5.5 to 6 or the 6.5. So here are the dose constraint. So this is an example of ultracentral lung SBRT where your PTV is directly touching the right main bronchus. Now, these are the two ISO dose based prescription. First one is the ISO center, which is commonly practiced in the Japan. It is a homogeneous dose prescription, and ISO dose based prescription, which is commonly used by the RTOG to improve the dose fall off and increase the dose heterogeneity inside the target. Now, this is an ongoing Japanese trial because they have used 48 gray in 4 fraction, and the current experimental arm is the 55 gray in 4 fraction for the dose escalation. So I will conclude that the careful plan evaluation in lung SBRT is very essential, because there are obviously critical structure, and this patient already have a poor pulmonary compromise. Smaller miss can cause greater harm to the patient. So we need to be very, very careful and look at each slice in all the 3 planes, like the axial, coronal, and the sagittal, and the risk adapted strategy based on the tumor location will help us in not doing a greater harm to the patient.
Thank you, Dr. Anil, for presenting and concluding well within time. And as decided, we'll take the questions at the end. So we move on to the next talk, which is going to be Dr. Shyam Bist. Dr. Shyam Bist is a senior consultant radiation oncology at the Medanta Cancer Institute, Medanta, the Medicity, Gurgaon. And he's going to speak on treatment delivery of SBRT, different platforms.
Good morning, Chairperson Srivastava sir and Basu sir, and good morning, everybody. Greetings from Medanta. I'd like to thank my friend Dr. Basu for the kind invitation. I will be discussing on algorithms, motion management, collimators, imaging workflow, because nothing was there for the platform, but still I will try to cover. Whenever we talk about the lung SBRT, the first trial which comes to the mind is RTOD 0236, which did not use heterogeneity corrections as illustrated by Dr. Anil. So Zayo et al. Did a dosimetric evaluation of this trial, and they found that the mean dose to the PTB was 55 gray, not 60 gray. And they also found, I think this is cutting, the non-heterogeneity correction algorithm, they underestimate, they overestimate the dose to the target and underestimate the dose to the OARs. So that is very important. Overestimation of dose to the target, underestimation of the dose to the critical structures. So similar observations were made in this paper which compared pencil beam versus Monte Carlo, and they found that pencil beam algorithm overestimate the dose. So that means actually the dose delivered is lesser in the target, and they overestimate the dose to the OARs, underestimate the dose to OARs, overestimate to targets. So conformity index, RTOG conformity index have a lot of fallacies I discussed, but still it is PIB upon PTV. Gradient index is 50% dose upon the target volume. From RTOG 0813, all further trials, they have necessary to use the heterogeneity correction. And this was reflected in the dosimetric criteria, as you can see. So they have relaxed these because the previous non-heterogeneity correction algorithm were underestimating the target. So actually in practical, they have taken this in practical consideration. So they have relaxed these criteria, as you can see in these boxes. And about the algorithms in different platform, the CyberKnife is using the TPS of precision, which has two algorithms. One is ray tracing, other is Monte Carlo. The Electra setups, they are using Monaco, which is using the Monte Carlo. The variant setups, the Eclipse is using two algorithms, AAA and across. Type A algorithms, Type B and Type C. Type A algorithms, they are mainly example like Pelson beam, TAR, Batho. They overestimate the target dose, as we have seen in RTOG 0236. Then is Type B is convolution superposition, collapse cone, AAA. They have improved accuracy, but still many studies have shown there is a 3% difference with the gold standard, that is Monte Carlo. But some authors, they have also reported that the difference might be up to 10% also. And Type C algorithm, one is across used by the variant systems. This is based on the Boltzmann linear coefficient transport. And the other is Monte Carlo, which is the standard. Monte Carlo is a full-fledged Monte Carlo, is very slow, very lengthy. So the commercial systems, they have made it faster by using up to 4 decimal places. So that is faster. So the Monte Carlo, commercial Monte Carlo means a shortened Monte Carlo as in contrast to the full-fledged Monte Carlo. So this is a very nice article which tells about for the physicians using different algorithms. You can go through this. So the Type B algorithm, superposition algorithm, was compared with Monte Carlo in this article using the criteria of 0813. They have found that the Type B algorithms, they underestimate the intermediate dose, as we have seen in Type A also, but to a lesser extent. So in this same study, the Monte Carlo recalculated plans, they could not meet the criteria, as you can see in the yellow boxes. So that means more relaxation was required for the Monte Carlo. So, and this was also taken into account the Rosal trial. So that means the superposition or Type B algorithm were underestimating the intermediate dose and overestimating the dose. This is the comparison between Type B and Type C algorithms, as you can see, and they concluded that the Type B algorithms, which was better than Type A, but still they underestimate the target dose, overestimate the intermediate dose. These two studies, they compare, and there are many other studies also, they are comparing different algorithms. Type A, Type B, Type C, Type C, Monte Carlo, and across also, which is very close to Monte Carlo in accuracy. So they have concluded that Type C algorithm should be used in lung SBRT planning. And all these studies were regarding the lung SBRT. But across was faster as compared to Monte Carlo. The SABR consortium, they advocate, which is a very recent one, at least Type B algorithm for lung SBRT, or preferably a Monte Carlo or across. And this paper compares two algorithms used in CyberKnife. One is the ray tracing, other is the Monte Carlo. So you just focus on the red box. You can see with ray tracing, there is a 20% overestimation of the dose, 20%. That means for prescription of 16.5, there is a 10 gray overestimation. That means actually the 10 gray less dose is delivered with the ray tracing as compared to Monte Carlo. So the authors, they recommended that ray tracing should not be used in CyberKnife for lung SBRT planning, and especially in the peripheral tumors. Now coming on to the collimators from different vendors, the CyberKnife is using cones from 5 millimeter to 60 millimeters and iris. The 5 millimeter cone at the 80 centimeter is 3.85, but mind it, that is used only for a trigeminal path. Otherwise, in all other paths, you use 1 meter or 100 centimeters. The MLC thickness of Versa is 5 millimeters, 2 beam and edges from high definition MLC from 2.5 millimeters to 5 millimeters. They are Millennium and SD. I will not go into detail of these collimators, but we all know thinner collimators or finer collimators increase the conformality of a plan. That means micro MLC, they increase the conformality, but that is important in less than 1, the target volume is less than 1 cc. So this is more applicable in case of cranial SRS, but what about in case of extracranial SBRT, lung SBRT, where we have the target volumes more than 20-30 cc's. So practically implications are lesser. So there is an Indian article which compared 5 mm MLC versus 2.5 mm this high density SD MLCs. They found that both these were able to satisfy the dosimetry criteria. So not much of practical implication for the lung SBRT, the final. So even a 5 MLC is okay, 5 millimeter MLC is okay for lung SBRT. In fact, improvement in the conformity, which we are talking with the final MLCs, they may actually be a detrimental. A conformity index of less than 1 might be detrimental. Why? There are 2 articles. You can see the first one has shown that if the conformity is more than 1.1 as compared to less than 1.1, there is an improvement in the local control, metastatic control, overall control survival. With the higher conformity, that may sound slightly that poor conformity is having improved control. In the second trial published in the Green Journal, the authors, they have shown that if there is a very tight conformity of the plan, the 2-year distance metastatic rate was 60% versus a very lesser conformal plan having a 5%. So they suggested a caution for the radiotherapy planning with steep dose gradient. So the reason is when we are using a slightly less conformal plan, there is a like in this red circle, the grays, the mark zone that is going to eradicate the micrometastasis. So a very tight conformal plan might be detrimental. And now comparing about the this is the triple F beams. All systems as 2 beam Versa SD, they are using, and CyberKnife, they are using a triple F beam with a dose rate of 1400 for the Elekta and Varian at 6 MV, and for CyberKnife 1000 centigrade per minute. So triple F beams, they improve the dose distribution. Not improve, it is comparable with the flattened beams, but the time duration is shortened, which might have implication on comfortability of the patient. But it is a double-edged sword because the patient might move that have a more dosimetric implication. And 6 MV improve conformity as the shallow depth only. And the 10F, they have slight improvement in screen doses, but of irrelevant clinical implication. But the control rates of triple F versus flattened beams are equal. SABR recommends, the consortium recommends triple F beam preferably. And what about the couch rotational errors? All these as 2 beam Versa SD CyberKnife, they are using 6D correction, tomotherapy, and the Radixact, they are using a 4D correction. Does it have an impact on lung SBRT? Yes, in case of brain SRS, because a minimum safety margin of 2 to 3 millimeters should be taken if no rotational error is being corrected. And there would be a lack of coverage of those almost to the tune of 3%. But does it have an impact on lung SBRT? Let's see. These papers, they evaluate the different degree of rotational errors versus the dosimetric effect. They found that up to 5 degrees of rotational errors, which is not being corrected, they can be only less than 3% of dosimetric difference. So practically, for a peripheral lung tumors, not much important, but in case of central lung tumors, yes, if we have correction, 6D correction, that would be preferred. And now about the NC beams, non-cochlear beams, there would be a definite dosimetric advantage, but it won't be translated in the clinical outcome in terms of using a non-cochlear beams. But sometimes, yes, in case of central lung lesions, ultracentral. And all these systems as TrueBeam, Versa SD, and CyberKnife, they have the possibility of using a NC beams. What about the intrafractional imaging in different setups? Real-time imaging with fluoro is yes in all those systems, comparing as TrueBeam, Versa, CyberKnife. CBCT, yes in all except CyberKnife and tomotherapy and Radixact. We cannot do intrafractional imaging, yes in all. 4D CBCT, yes in all except CyberKnife, whereas the 2D imaging are there on orthogonal planes. Real-time tracking, yes in all. Clarity in Versa SD is used for the prostate motion, but not for the lung. Deformable registration present in all. And this slide shows the dose delivered in these intrafractional imaging. This is a survey of NRG oncology survey in which 36% of the users, they were using only the ITV strategy for lung SBRT, and around 25% were using either gating, breath hold, or tracking. And this lower down article, NRG, this is an NRG review on SBRT. Important take homes are residual motion should be included in the ITV, even if you are using a lung respiratory management. Coaching is very important. It improves the correlation between the internal anatomy, that means tumor, versus the external surrogate. Treatment on end expiration is more reproducible, but patients are less compliant, and better sparing of structures in end inspiration scans. This breath abdominal compression can be used in any of these except CyberKnife. And the RPM Exatrack is used in Varian system, which uses, discussed previously, uses the 4D CT, and there is an administration of radiation within a particular phase that is called gate. I will not be going in detail in this. So there is one problem with this is there is a phase shift. Phase shift is when there is a dysynchronization between the tumor motion and marker motion. The surrogate markers. So that means beam is delivered at a different phase. So out of sync treatment, you can see. So there are ways how to check this. And other is the interplay between the MLC motions and the respiratory movement of the tumor and OARs. This can lead to a gradient effect and the interplay effect, which is very beautifully described in this AAPM articles. This gradient effect is more detrimental in SBRT. On the right side, you can see this is the static image, and the right side is the motion images. They can be at missing of target with the gradient effect.
2 minutes are left.
In the Elekta setup, we have got the DIBH with ABC, where the spirometer is attached. Patient is trained in 2 or 3 days to take a definite amount of volume in the air, depending upon his comfortability, and to hold it amount of duration where he can be comfortable and we can deliver treatment. This is a very robust system. And if your training is not accurate, there can be a mismatch between 2 inspiratory breath hold images. So training is very important. As you can see in the lower panel, 2 images are matching perfectly. Even the cavities, they are matching perfectly. This is because of good training. But 15% of the patients, they are non-compliant for the ABC. They can be tracheostomy patient, that is the issue, cannot be done. COPD patient, edentulous patient, anxious patient, they can be done. They cannot all do the ABC. But we have reported a case where we did a tracheostomy patient ABC, and then we subsequently, we have done 2 or 3 more cases with this ABC. And target tumor tracking is 1 minute. Tumor tracking with synchronous system. In this, there is surrogate marker kept over the abdomen, which is going to form the respiratory model. And at the same time, 2 X-rays, orthogonal X-rays, they are going to track the tumor. And at different point of respiratory cycle, the tumor is imaged. And then a correlation model is formed. First, it will tell whether both the cameras can see. Like in this image, both the cameras can see the tumor. It's called the X-side lung 2 view. If one camera cannot see because of the scapula or vertebra, then it's called 1 view. So we have to give a ITV in the perpendicular direction to the camera, which we cannot see 1 view. And so this model, so a correlation model is created where the respiratory cycle is correlated with the location of tumor in 2 view,
and then radiation is delivered. So this model predicts the position of the tumor at different phases of respiration, and the radiation is delivered. So that was the last slide. So this is our team. Thank you so much.
Thank you, Dr. Sham. It's nice presentation covering all the machines. I think as we said that we'll have the question at the end. Keep your questions ready. The last in this session is lecture by Dr. Sayan Das. He's a consultant and radiation oncology NIRS Super Specialty Hospital in Kolkata. He's going to speak on follow-up imaging and toxicity. Sayan, please.
Very good morning to all of you. Thank you, my teachers and Dr. Basu. Before I begin, I would like to thank Dr. Triranjan Basu as well for this invitation. Now that we have done some motion management strategies, contoured, approved the plan, and the treatment delivery is over, now it's time for your follow-up evaluation after delivering SBRT. So I'll be tackling both follow-up imaging as well as post-SBRT toxicity. Let's begin with follow-up imaging. So in the next, say, 10 odd minutes, I would like to address these questions. Why do you need imaging? What do we usually come across when we look at the follow-up imagings? What do we expect? Which imaging modality would we prefer? When to do the imaging, and how to interpret the imaging, and how to differentiate between a post-RT change vis-a-vis your local recurrence. So why is pretty obvious. You need to assess the tumor response after you deliver treatment. You may detect local, regional, or distant recurrences, and occasionally you may come across a second primary. Now, you've seen in the previous lectures that with SBRT, you achieve excellent local controls in the region of 90%. But still, 1 out of 10 patients will have a local failure. Now, local recurrence in an SBRT setting is defined as within the target volume, which is infield recurrence, adjacent to the target volume, which is a marginal recurrence, or within the involved lobe of the lung. Now, there are a few factors which we must keep in mind, which are associated with a higher risk of local recurrence. Some clinical factors like larger tumors, squamous carcinomas, higher pretreatment SUV max values. As Moses has already previously mentioned, that a lower BD less than 100 tend to have increased risk of local failure. So while you're interpreting your follow-up imaging, keep these in mind. And majority recurrences occur in the first 2 years, but late recurrences do happen, which will have a bearing on your surveillance strategy. Now, what happens when you deliver such high doses in such small number of fractions? There's a spectrum of post-treatment changes to the lung parenchyma. Now, the nomenclature is mostly dependent on the time. So what you see within the first 6 months, that is the acute phase, we call it radiation pneumonitis. Beyond 6 months, we call it a radiation fibrosis, the late changes. The median time to appearance of these, if you see, is around 17 weeks. Compare this with your conventional fractionation, it is around 4 to 5 weeks only. Pneumonitis can be either a subclinical, which is mostly radiological changes, or it can be clinical. I'll come to it later on. Diagnosing clinical pneumonitis is very challenging. There are a number of differential diagnoses which may confuse, like an acute exacerbation of COPD or interstitial lung disease. You can have pneumonia, or you can have a disease progression which may appear like pneumonitic changes. The incidence of symptomatic pneumonitis after SBRT is around, say, 9 to 10% based on the existing literature. Some studies do report higher toxicities depending on the location and the doses prescribed. However, if you look at this risk of severe radiation pneumonitis, which is grade 3 or more, is pretty low. Based on this paper by Ikezo et al., acute lung changes are, there's a 4 CT patterns of early radiation pneumonitis, grossly 2 types, a consolidation or a ground glass opacity, and each can again be divided into either a patchy or a diffuse. Now, what's the difference between a ground glass opacity and a consolidation? So both are opacifications of the lung parenchyma, but in ground glass opacity, you can still make out the bronchovascular markings, which will be obliterated in a consolidation. And patchy means it is the diameter is around less than 5 centimeters. Anything more than 5 is considered as diffuse, or if the changes cover more than 50% of your radiation field. In addition, you may come across pleural thickenings or reactive effusions, but usually they are very small. They remain stable for a very long period, usually don't decrease, and they resolve spontaneously. Patients having underlying pulmonary disease can have extensive pneumonitic changes going beyond your the radiation fields or your high dose regions. Let's have a look at these images to have some idea. So on the left side, the image is just follow the red marks, which I've highlighted for a better understanding. So this was a tumor post SBRT. What you find is these haziness around this high dose volume, but you can still make out the bronchovascular markings. So this is a typical diffuse ground glass opacity. Compare this with this, where there is a complete obliteration in some areas, which is considered as a diffuse consolidation, because a large part of my field is now obliterated. However, smaller area of haziness will be considered as a patchy ground glass opacity. Again, in this case, on the right hand side, if you see the right side, the red arrow marks the area of patchy consolidation, whereas the orange arrow marks area of patchy ground glass opacity. Now, these are the acute changes. What about the late changes is what is called the radiation fibrosis patterns. Again, Koenig et al. Again, these changes are mostly coming from the conventional fractionation, but they're still used for SBRT setting with respect to the radiological appearance. Mostly 3 patterns of fibrosis that we see. One is the modified conventional fibrosis. The other is a scar-like fibrosis. The third is the mass-like fibrosis, which is the most confusing when you're trying to find out whether it is a local recurrence or only a benign fibrosis. Let's have a look at each one of them. So on the left-hand side, again, you see there was a tumor with the red arrow, red line is the high dose isolose lines. So when you have your consolidation in and around the high dose region, which is associated with a well-defined consolidation with volume loss, and you may have a traction bronchiectasis. That is this dilatation of the bronchioles. That is called as traction bronchiectasis. These changes are associated with the modified conventional fibrosis. This is the most common pattern that we come across almost in 50 to 60% of the cases. Another picture showing the same thing, the tumor which was treated with SBRT. First 3-month scan showing both your ground glass opacity as well as consolidation. However, a longer follow-up, so post SBRT scan done after 1 year, this shows this modified conventional fibrosis with your dilated bronchioles. What is a scar-like fibrosis? Is your linear opacity in the region of the tumor. So in the high dose region, on the right hand side, you see, follow those red arrows, you see those scar-like bands. This is again seen in around 50 to 20% of the cases. This is what is really important, is the mass-like fibrosis. This is defined as a well-defined fibrotic pattern around your target volume. So it kind of conforms to the target volume. Just imagine a tumor, imagine a 2 centimeter circumferential margin around the tumor. So when you see fibrotic changes in and around that region, conforming to that shape, conforming to that high dose isolose volume, is where you find your mass-like fibrotic patterns. And to add on to this confusion, what you have is the evolution of your post-SBRT fibrosis. So a patient, after having treated with SBRT, 6 months down the line, you take a scan, or say 12 months down the line, you take a scan and you find a modified conventional fibrosis. Keep the patient under follow-up, repeat a scan. After 2 years, you may find that conventional fibrosis converting into a mass-like fibrosis. That does not necessarily mean that the patient is having a local recurrence. Again, similar changes on the left-hand side. This was modified conventional fibrosis, longer follow-up, looks like a mass-like fibrosis. A similar PET CT done in the same setting shows there is no focal uptake. How to distinguish between a lung injury versus a local recurrence? See, misclassification of a lung injury vis-a-vis a local recurrence is a double-edged sword. You misclassify a recurrence, you miss a chance of a potential salvage. And if you brand something as a local recurrence while it was a fibrosis, you end up doing futile investigations, futile surgeries. Commonly for solid tumors, we use RECIST 1.1 for response assessment, but unfortunately, response assessment RECIST 1.1 is not really very useful. Why? I'll just give you an example. Tumor here in the right upper lobe, the red line is the higher isodose lines, the prescription dose isodose, the yellow and the orange are the 50%, 25% isodose lines. At 3 months, you see a large in area of volume higher or larger than the tumor is now showing some opacity. Longer follow-up changes into a scar-like fibrosis. So your RECIST would have branded this as a progressive disease. However, it was only post-RT changes. So how to deal with that? Well, the Huang et al. He came up with a systematic review of post-RT radiological appearances, and they came up with this list of 7 features which are suggestive of a high risk of recurrence, which includes enlarging opacity of the tumor size on serial follow-up. There's loss of linear margin, convex bulging margins. I'll come to each and one of them. I'll show you, give you examples to have a better understanding. Loss of air bronchograms, what it actually means. Enlarging opacity after 1 year of treatment. And very important, this was one of the most important indicators of local recurrence, was a craniocaudal growth, more than 5 millimeters or more than 20% of your baseline tumor size. In 2018, the who's who of lung SBRT met together. We did a consensus statement, the International Delphi Consensus, which said that you suspect a local recurrence if you have these features. So if there's an infiltration into the adjacent organs or structures, a sustained growth over serial scans, you have a bulging margin, a mass-like growth, or a predominantly spherical growth, increase in the craniocaudal dimension, or the loss of air bronchograms. This is pretty self-explanatory, serially enlarging opacity. Loss of the linear margin. You see this linear margin, just follow the red arrow, and you see this bulging margin there. You suspect a local recurrence there. Again, look at this area just adjacent to the trachea. You now see there is this predominantly spherical growth with a bulging convex margin. Again, suspect a local recurrence. So loss of air bronchograms. So normally these air-filled spaces, if they get obliterated or a longer or a further scans, that should be suspected as one of the higher risk predictors of local recurrence.
Again, 2 minutes.
Okay, sir. So again, this typical example of a craniocaudal growth, and you can see the bulging convex margins, the orange arrow. Just one example. So look like a fibrosis followed up. You see increase in opacity serially with convex bulging margins. Corresponding PET CT showed presence of a local recurrence. What about the role of functional imaging? PET gives you added information. It can help you guide in biopsies, pick up regional or distant mets. But it is useful in patients where you are suspected recurrence on a CT. The problem is the risk of false positive. You have a better specificity when you do it beyond 6 months. However, what is the usefulness is a high negative predictive value. Functional MRIs are now being tried. Just give one example where PET CT is useful. Is this, those look like a fibrotic pattern. With a PET CT, this can now guide you to take a biopsy to prove local recurrence. Well, I'll not go into radiomics. There's a separate session for that. Radiomics is coming up in a big way to pick up early recurrences than what the human eye can comprehend. So what Delphi consensus said that you do your imaging routinely with CT scans at 3 months and not at 6 weeks. Follow it up at 6 and 12 months in the first year, followed by 18 and 24 months in the second year. From there on, annually scans. They even suggested doing surveillance even after 5 years. There was no consensus regarding the frequency, and a judicious use of PET is recommended. Do it only when you suspect a local recurrence. There's an algorithm there available on when to do further studies. So my take, so why is quite obvious. For what, get acquainted with the acute and late changes. Preferably get a CT scan done, PET CT only when you suspect recurrences. When to do at 3 months, and how to is look for the high risk features. So do I have a minute for toxicity or no?
Organizer, we still have questions. So can we take the questions now, or with the panel discussion do we go? So give him 1 more minute. Okay.
I'll just quickly run through the toxicities. Again, most of it is already discussed. So the important OARs you have is lung, chest wall, the heart, the airways. With respect to lung, radiation pneumonitis, one of the most common. Be very, very careful. Few biomarkers are available, but they're not validated for clinical use. Factors predicting pneumonitis, these older patients, those having underlying lung disease, large tumors, central tumors, mid and lower lobe tumors, they tend to have higher risk, and your treatment related, some dosimetric parameters can predict higher risk of local recurrences. Heart toxicity is not very well understood as is available for conventional fractionation, but there are some parameters people looking into the substructure doses which may give you a better prediction. Major vessels, which include pulmonary vessels, the aorta, the superior vena cava. So again, high dose per fraction, higher risk of toxicity. Central airways, very, very important when you're treating your central and alpha-central tumors. The risk is higher in the lower and the segmental bronchi and less in the mid and the mainstem bronchi. Esophagus ranges from mild esophagitis to life-threatening strictures, perforations, and fistulas. Again, higher risk with higher dose per fraction. Rib fracture, again, very, very careful for peripheral tumors which are closer to the chest wall. Again, higher risk when you are delivering. The max doses are very high for your ribs. Brachial plexus, madam has very well delineated how to delineate your brachial plexus. Again, increases when your Dmax is higher. Be very careful when you're treating tumors in the apex for avoiding brachial plexopathy. My take, higher risk with high dose per fraction, especially for central tumors. In challenging cases, when you're not able to meet your dose constraints, use protracted regimens and reduce your dose per fraction. We have existing trial protocols. The several activity protocols will guide you about your dose constraints, and we need studies in biomarkers to better tailor your SBRT treatment. Thank you.
Thank you. Thank you, Sayan. It was a nice lecture. Now we are almost half an hour late. So we'll have the question, as Taranjan has told, that during the panel discussion, we'll have the question. Keep your questions ready. And we invite Dr. Naveen Mahmoodi. He's Associate Professor in Radiation Oncology and also the Secretary of the Thoracic DMG at Tata Memorial Center. And Naveen, you will invite all your panelists. Yeah.
And I'll also request all the speakers also to be around. Please don't leave the hall, because questions can be directed to you as well. Thank you.
Thank you so much for the introduction, Dr. Srivastava. Thank you, chairpersons. Thank you, organizers, for having me here. My job today is to have a panel discussion about lung SBRT and focus on the practical aspects. We had an excellent session in the past 1 hour where we have had in-depth discussion about each of these individual steps involved in lung SBRT. But we will have a quick recap in the next 30 minutes about the essentials of lung SBRT. I have a stellar cast here as my panelist. I am most of my friends. I'm happy to invite all my panelists. Dr. Vaibhav Sonwani from Nagpur. Dr. Anil, unfortunately, is not here. I request Dr. Arun Moses to step in for him. Dr. Madhu Sairam from Coimbatore, Dr. Suman Malik, and Dr. Shikha Goel. I would also like to invite Dr. Sayan Paul, who's kindly agreed to join us virtually. And special thanks to Dr. Anupam Rishi Anupama, you there? Thanks so much for joining us from all the way from Florida. I know it must be pretty late in the night for you, but thanks for hanging around here.
My pleasure.
Okay, so what I'm going to do in the next 20-25 minutes is, as I said, we'll just go through a couple of cases, not too many, just representative patients, so that the important aspects come out and we can have a more elaborate discussion on these. So this is a typical patient that we see in our OPD. There's a 73-year-old man with a good performance status. He has multiple comorbidities. He's a hypertensive, diabetic, and he has a previous history of extrapulmonary tuberculosis and also pulmonary tuberculosis, because of which he had a left hip surgery. So he presented to us with a history of cough and expectoration for 3 months, and his effort tolerance was 1 flight, possibly limited because of this surgery that he had had for the left femur. So he was evaluated with a CT scan, and this is what we see. This is what we typically, this is what a typical patient who gets referred for our treatment looks like. So I would want to begin with Dr. Shika. Can you just quickly tell us what you see in this?
The lung does show a lot of fibrosis, especially in the right side. There's pleural fibrosis as well. I can see a mass lesion with speculations in the right upper lobe, which is abutting the chest wall as well.
Yeah, and there's also some minimal pleural effusion also. So it looks like much of this is because of the post-TB sequelae, but there is clearly a right upper lobe mass. So this patient did undergo a biopsy, and it was shown as adenocarcinoma. My questions to Dr. Suman Malik is, what typically how would you proceed with this patient? So this is a patient who has upper lobe lung carcinoma and with a lot of pulmonary TB sequelae in the lungs. How would you proceed with this patient? What kind of a metastatic workup would you do for this patient?
So basically, this patient had history of pulmonary tuberculosis as well, and he's having one lung as well in right upper lobe along with small pleural effusion. So if we look at the lung mass, it's kind of infiltrating mass. So it may be a infective focus or it may be a tumor. So this kind of cases, usually we advise for biopsy in these cases. And if biopsy comes positive, then we need to do the staging workup like whole body PET-CT. And even if whole body PET-CT does not show any uptake in the effusion, but probably it's better to do a diagnostic aspirate from the effusion to see whether that effusion is positive or not.
Excellent. So you would do a PET-CT scan, and you would also do a pleural tap for this patient. Let me bring Anupam here. Anupam, I don't know if this is the kind of patient that you would see in your current setup, but do you think PET-CT scan is a necessity for these patients, or are there any patients in whom you would not do PET-CT scan, just go by imaging finding itself?
Thanks, Naveen. First, thank you everyone for. Can you guys hear me? Can you guys hear me?
Yeah, Anupam, go on.
Okay, so so typically in this situation, I would agree with the panelist. We would also get a PET-CT in most situations, regardless of the comorbidities. Of course, we don't see tuberculosis in the US as commonly as we would see in US, but I don't think so that should change our workup. And if the patient has effusion, definitely we will need to get a cytology to rule out malignant effusion as well.
Do we have consensus amongst the panelists? Do we all agree that we will get PET-CT scan in most of our patients? Great, all right. So this patient did get a PET-CT scan that did not show any other metastatic disease. He also had a pleural effusion. I'll come back to that later. So another thing that we need to discuss here is about the mediastinal nodal evaluation. So we did say that we will do a biopsy to prove the primary disease diagnosis, and we said we will do a PET-CT scan to look for distant metastasis. And what about lymph nodal disease? I mean, is it a usual practice to do mediastinal nodal evaluation? Because if this patient were to be operated upon, the surgeon is for sure going to do some mediastinal nodal imaging. So what's the take on it? Arun, can you
Yeah, for this patient who has a fairly peripheral lesion, and if the PET-CT is not showing up any enlarged nodes, I would forego doing a mediastinal staging with EBUS. And only if there is something shown on the PET-CT, possibly I would subject them to a EBUS.
Okay, so let's presume for a minute that this patient had some mediastinal lymph nodes and with a lot of lung changes, which could or could not be because of the infective etiology. So would you still do in those patients?
Yes, in that situation, because of the infective etiology, there comes a diagnostic dilemma. So in that case, I would definitely subject them to an EBUS before taking them up for the
Correct.
SBRT.
Yeah. Madhu, any difference of opinion, or do you agree with Moses?
Yeah, I'm sure a patient with the tuberculosis would certainly show some nodes at least. So we would definitely go ahead with EBUS prior to going ahead and also add up an MRI brain to this patient.
Correct. Yeah, sure. Anupam, I again have a question for you. So here in India, at least the kind of patients that who get referred for SBRT for lung lesions are those who aren't fit even for a haircut. So we don't really do any invasive mediastinal staging. So is it any different in your setup, or is it the same?
It's similar. So we don't do invasive procedure unless the patient is going to get a surgery. But of course, if there's any lymph node on a PET-CT, we would get a EUS or bronch, depending on the location, and get a tissue diagnosis from that.
Sure. Yeah. So we agree that this standard treatment is probably not to do a routine mediastinal imaging, but we will come back to the issue because we do see patients presenting later with nodal failures and consequently distant failures, and how to go about these patients. Okay. So we did a biopsy, and is there anything else apart from the oncological assessment? Because as I said, this patient has multiple comorbidities. So do you, Vaibhav, would you do any other medical evaluation for this patient before you go on with SBRT?
So as a radiation oncologist, yes, a medical fitness is going to deem this person inoperable. However, the cardiac status or the pulmonary function status is not a contraindication for SBRT. A baseline workup would be nice, but it wouldn't make any difference in proceeding further with radiation. One more thing that we would want to do is to do the further evaluation of the tissue to run further mutation analysis. That is also part that we need to.
Okay, would it really change your management?
No, not really.
So, so let's just keep that for a later discussion, but point well taken. So we would do a physiological evaluation of patients' pulmonary and cardiac function, because this patient having multiple comorbidities, we would want to know what kind of a prognosis otherwise he is medically. Dr. Sayan, who has again joined us online, would you agree with this, or is there anything else you would do?
Yes, absolutely agree. Pulmonary function test I like to offer to this patient, because we need to discuss with the surgeon in a multidisciplinary tumor board also. So other feasibilities like surgical options also we need to give to the patient. So we'll do a pulmonary function test to discuss the case in multidisciplinary tumor board and other fitness tests like the cardiac evaluation.
Absolutely. Absolutely. So we agree. So we need to have a multidisciplinary approach for this patient. So this patient did have a PET-CT scan which did not show any lymph nodes, and this patient also had a tapping of the pleural fluid which was negative. MRI brain did not show any metastasis. Echo was showing adequate cardiac function, but there was mildly elevated pulmonary artery pressure, and this pulmonary function tests are pretty borderline for this patient. So the current issues for this patient is that he is an advanced age, 76 years old. He's got multiple comorbidities. He has history of pulmonary tuberculosis, which has caused sequelae in the lung parenchyma. And there is some difficulty in assessing performance status because generally,
will we not do SBRT?
We will come back to that, Dr. Kundan, if you can just hold on for some time, please. Sure. Yeah. So this patient has some difficulty in assessing our performance status, because although PFT DLCO is what we generally do, a typical patient with some comorbidities would also undergo some extensive evaluation, like for example, a CPET, cardiopulmonary exercise testing, which might be difficult in this patient to really assess his surgical risk. And he also has borderline pulmonary function and pulmonary artery hypertension. So what are his treatment options? Let me come back to Arun again. So given that this patient with his
comorbidities and imaging finding, what are the treatment options? How would you go about this? Do you think that he's straight away not a surgical candidate, or would you still keep surgery as an option? Would you have your surgeon on board? And how would you counsel patients, importantly, saying what are the treatment options?
I wouldn't straight away rule out surgery. I will still want my surgeon to assess and say that I would want the surgeon to commit that it's not he's not fit for surgery. And stereotactic radiation is always an option if the surgeon doesn't agree for a surgery.
Yeah. Great. So I wish our surgeons were also as magnanimous as we radiation oncologists are. Do we agree on this, that this patient would be offered both lobectomy and SBRT as an option? Dr. Shika, I'm sorry I didn't bring you in earlier. What are your thoughts on this?
Poses entirely. It has to be an MDT discussion. It has to be a decision after that discussion.
So this we do generally say that we discuss with patients, but how do we actually go about? I mean, between surgery vis-a-vis SBRT, we know where we stand in terms of evidence. So how do you actually explain to patients that which is better and which is not better? How do you go about that?
Okay, so whatever little evidence that we have, even if those trials were not completed, we have evidence that these would stand equivalent. The risk, immediate risk with surgery is higher in this situation. One, the patient not recovering from the surgery immediately versus plus the risks in the 30-day period after that, including morbidity as well as mortality. So SBRT does not carry any immediate morbidity and mortality. So it's safer from that standpoint. And in the intermediate, short term or long term, the outcomes are likely to be equal.
Absolutely. So we do agree that there is paucity of level 1 evidence in this regard, but we know from a lot of large institutional data that there is equipoise between surgery and SBRT, even in medically operable patient. Medically inoperable patient, absolutely, we don't have any such debate. So yes, so this patient, thankfully, our surgeons backed out given his physical and physiological dysfunction, and we took him up for stereotactic body radiation. We counseled him and he was willing for it. Vaibhav, so the most important issue in executing SBRT is how will you immobilize this patient and simulate patient? Yeah.
So, see, medically operable patient, surgical patients, how many in MDT, how many times it has converted into SBRT? So anybody has, like, MDT is absolutely fine, but like patients, you are given the options and you are able to convert that patient for SBRT.
Yeah, so I understand your question, Dr. Sridhar. The answer to that, at least from my side, is that it cannot be a number. It's basically a choice that you're putting in front of your patient.
Very true. Very true.
So it is he who chooses, and there cannot be any number which you can quote and influence patients.
So a lot of times in our discussions, we start with, okay, one caveat we'll put it as probably is in a borderline operable case. So we should always go to the next level, telling that operable case, we have an equivocal response, and actually level 1 evidence, if it is not there, are we going to wait till that time? Because we're already there. We are already there in terms of SBRT is equivocal to the surgery.
Absolutely. So yeah. So I don't think you need to sell this to anybody because they're all radiation oncologists here. So let me just go on. So Vaibhav, I was asking you about the immobilization and simulation. So how do you go about this?
Right. So immobilization, the basis of all the immobilization is patient comfort first, because as ma'am has already mentioned, that these treatments are a little prolonged and patient needs to be absolute comfortable lying absolute still. That is one. We had one more.
So is there anything special you would do? I mean, is VAC is the only solution that you do, or is there anything else you would do?
So one of the speakers actually mentioned that the technologists are more comfortable with raycast. However, at my place, at my center, we prefer VAC plus raycast both to have the immobilization.
Do all the panelists agree on this, or do you do anything differently, Madhu?
We do a simple arm above head with just one pole and no shell on them. We are comfortable doing that.
Because you do everyday imaging anyway, and probably
everyday imaging.
So,
we don't do any mobilization.
Okay, Anupam, do you agree with that, Dr. Sayan? Is there anything else that you would do at your center, or is it the same?
Yeah, what I do here is, and I am very comfortable with this, is using an abdominal compression device for all lung and liver SBRT. So the device has been improvised by Dr. Kaushik Bhattacharya, and we have seen that if we use the device, the respiratory motion is really less. Like we can reduce it to less than 1 centimeter if we use the device. So what we do is we use the abdominal compression device that we have made indigenously and with a ORFID cast. So the device is inside beneath the ORFID cast and causes compression on the diaphragm, and the respiratory motion is less if you use that. And with that, we take a 4DCT.
Okay, excellent. All right. So regarding 4DCT, can I ask?
Naveen, can I ask, add some more?
Anupam, yeah.
So we do very similar to what you guys just mentioned, but some couple of things that extra that we do is when we do an abdominal compression, all patient, we do a with and without abdominal compression CT scan and see the movement of 4DCT. Movement is less of with abdominal compression, then we select those scans. If it is, sometimes some patients are very uncomfortable with compression and their movement is very irregular. So in those cases, we do not take abdominal compression. And we also use something called plastic vacuum sheet, which I've never seen when I was in India. So it's very unique patient. So we put a plastic sheet over the patient and connect to a vacuum pump. It kind of seals the patient to the backlog, which gives a really, really nice seal.
Thank you.
Yeah, completely agree. This we have used in my previous institution called BodyFix, a plastic vacuum shield, a sheet which if you suck the air, which snugly attaches with the body, and it also reduces the respiratory motion if you use that. And I'm absolutely agree with Dr. Anupam that we also do free breathing CT and with abdominal compression device to see how much movement is with respiration with this patient.
Great. Okay. So we are again in agreement there. So we do agree that some form of motion management needs to be done, and 4DCT or abdominal compression is the commonest thing that is done, although there are other available solutions in the market. But my question to the panel is that, is this what you would do generically for every single patient who comes in for an SBRT, or would you tailor your immobilization depending on the location or any other factors? Dr. Suman, do you want to take that?
Yeah, first deciding on motion management, we do assess the motion, whether there is any motion or
So
not.
how do you do that?
So we do it with the phased CT scan. So if there is no much motion in the lung tumor, primary lung tumor, usually we don't use any motion management protocol. So if there is significant motion, like if lower tumor, or if there is significant motion, the device we have is the ABC. So we first see whether patient is capable of doing breath hold technique. So if patient is capable of doing breath hold technique, we use ABC only because it's a very robust kind of system, and by which we can significantly reduce your irradiated lung volume.
Sure. If I can just interrupt you there. So you mean to say that you will do a CT scan to assess the motion before you take a call and as to how to go? So would everybody do the same, or would you do it differently? Anybody would do a fluoro X-ray, or do you still do a CT for all patients?
Right.
Because then this would mean that you are doing a scans double the time. I mean,
Right. So again, it depends on the site of the tumor. So if you think the tumor is towards the lower part, towards the diaphragm, yes, we would want to assess the movement and be a little more careful of acquiring the images.
Absolutely.
But if it is like towards a little more central, towards apical, I don't think that exercise is required.
Great point. So any tumor which is close to the diaphragm would definitely move. The movement magnitude is much more. So there you need to be even more careful. So come. So let's move on to the planning CT scan. So we said we are going to do some form of motion management, and so all of us, do we do IV contrast CT, or is there anything different? Your levels, this is what I have put up on the screen. This is what you would do, or feel free to differ on this. Yes. Sure, sir. We have half an hour, so I'm trying to finish as fast as possible so that we can take it at the end, if that's okay.
Agree with all of it except for the use of intravenous contrast.
So you don't use IV contrast at all in your patients because you think that the mass itself would give you a natural contrast from the lung parenchyma. But if the lesion is close to the central mediastinal structures, possibly in those patients, you would definitely do IV contrast, or even in those patients, would you just fuse your PET CT scan or
I
something
don't
else?
usually fuse it, but I just have it by my by the side to guide me in contouring, but I mean, I
Sure.
have never generally done intravenous contrast.
Sure. Madhu,
Earlier, we had our 4D system set on the PET scan. So we used to invariably get a planning sort of PET scan done for those patients with 4D imaging. So that used to be the trend. And naturally, we always gave IV contrast in those cases. Currently, we have it on our simulation CT only, where we certainly give an IV contrast for planning every time.
And your slice thickness is what I mean, as small as possible. So we do generally 2.5 millimeter. Probably for a smaller tumor, you might do a thinner slices also. So Anil, thanks for joining. So the question to you is about delineation. So we have covered the diagnosis and simulation so far. So you can tell us how we delineate the GTV in patients once they undergone simulation.
Yeah, so we use the 4-dimensional CT scan for assessing the motion, and as we all know that there are various post-processing tools that are available with the help of 4D CT scan, as can be seen on the slide. There are various options to delineate that. It's not so one option is better than the other. It is what we are comfortable with. If you have a smaller tumor volume, if you want to delineate in all the phases, it is much better as compared to the MIP. You can do it in the 2 phases also. For example, if you take the 0 phase or the 60% of the phase, then you can combine those and you can check on the other phases. So it's not that you will have to delineate on all the 10 phases. If you have time and resources, you can delineate on all the time and all the phases, and then you fuse and then you create the IGTV. Or if you have lesser time, for example, if you're in a busy setup, or if you don't want to delineate in all the 10 phases, you can delineate on 4 phases or 2 phases, or you can delineate on the MIP, the maximum intensity position. There is one small caveat that to have the, as you delineate in all the 10 phases versus the MIP, all 10 phases volume will be slightly higher as compared to maximum intensity position. But it is not going to affect your treatment volume. If you check after drawing on the MIP, if you check on each and every phases, then you might be able to delineate or expand the target volume if you are missing on any particular phase. So that's what we do generally.
Yeah, excellent point. So the important takeaway is that you have to manage your workload and also the absolute necessity for that patient, what kind of delineation you would do. And also another point is that when you're using MIP, especially for tumors which are close to the diaphragm or mediastinal structures, you might run into trouble. So in those patients, probably it might be a good idea to do it in all the phases and then run the cine images to see. So do we agree that this is what most of us would do, or is there any difference of opinion here in the panel? If not, then so also one of the important things is when you are contouring any lung patient, it is important to look at the different windows. Again, for the audience, these are the different parenchymal window levels and the mediastinal window levels. It's always a good idea to look at both the windows before you do it. So the next question is, again, I'll come to Dr. Suman, and possibly Vaibhav can also take this. So what do you give as a CTV? So we are discussing about patients who have primary lung tumors who are being planned for SBRT. Do you always give a CTV margin, or you don't do?
No, usually we don't give CTV as most of the people they practices, because invariably there is some low dose region surrounding the PTV that will take care of microscopy.
So the isodose fall off should take care of some micrometastasis around the tumor. Okay, all right. So we are all in agreement there. Anupam, is there anything else you would different you would do, or is this your practice too?
No, I agree. So we also don't do CTV, but I've seen people done CTV at different centers.
All right. Okay, great. So what about PTV? So what kind of a CTV to GTV to PTV margin would we do? Vaibhav and Madhu can take this.
We usually give a 5 mm PTV margin. And in certain sites where we are slightly unsure, where we haven't adequately covered on the MIP and all, 7 mm. And we sometimes also give a differential PTV margin where we have to, cut off from the OARs, like from the ribs or the chest wall. We give a little less on that side.
Okay. And this regardless of what kind of immobilization device that you do, or
yeah, again, it depends on the site of the tumor. Again, if it's towards the diaphragm, we will prefer to have craniocaudal margins little extra to about 7 mm, where the circumferential margins of about 5 mm. In the apical tumors, it will be just 5 mm.
Sure. All right. Okay. So Anil in his presentation elaborated on the dose per fractionation, what kind of doses that we would do. Dr. Shika, what is the commonest dose fractionation schedule that you would do for each of these setting, peripheral, central, and ultracentral tumors?
So for the peripheral tumors, we prefer a dose of 15 to 18 gray per fraction for 3 fractions. For the central tumors, a more protracted schedule of around 8 fractions, 7.5 gray per fraction as the UNC group follows.
Okay. All right. And Moses, do you do something similar or is
Peripheral, my usual dose is 54 grain, 3 fractions, and for central 7.5 to 8.
Yeah, so that's what Dr. Shika also said. She said 15 to 18, 3 fractions. All right, okay. So although in our setup, at least Anil can agree, we generally are little conservative. We do 60 grain, 5 fractions, but there is a lot of evidence to say for a peripheral tumor, you can do a slightly higher dose. What is important here is that the total dose is what we are looking at. We try to deliver as high a biological equivalent dose of at least 100 gray. We know that all these patients are not, a comparison between conventional RT, conventional fractionation versus SBRT is not really much because a lot of trials have shown that there is definite benefit, overall survival benefit by doing SBRT instead of doing conventional fractionation. So let me just move on a bit quickly here. So the treatment schedules, again, we had a discussion about how you treat this patient, whether daily or would you treat on alternate days? Vaibhav, how would you do if you're doing 3 fractions, 5 fractions, would you do daily or would you do on alternate days?
So there's no fixed format. If patient has not experienced any radiation therapy induced nausea, vomiting, we probably go ahead and give it daily.
Correct.
If he has just experienced some RA, and we would just alternate.
Sure.
It.
So there's not much of a scientific rationale, but more towards logistics we would manage it. So again, regarding dosimetry, so most of us would do IMRT or VMAT, is that right? Or would you still do 3D-CRT for any of your patients? VMAT for all patients. So we are again in agreement with that. And these are the usual type of beams that we arrangement for IMRT or VMAT that we do. And we also had a discussion about how important the heterogeneity corrections are while you're using your plan, actual planning. So again, Anil elaborated much on the, we had speakers elaborate on the plan evaluation as to how you look at the low dose and how you look at the high dose. I'm not going to go into that because we are running short of time. And this is the usual fractionation. This is the usual metrics that we use for evaluation of the organs, dose and to the PTV. So most of you would prescribe to the tumor volume, or do any of you prescribe to isocenters for SBRT lung? All of you do to dose volume. All right, okay, great. So what about treatment verification when this treatment is getting actually executed? So we all do some form of CBCT. So it's just that one CBCT that you do before treatment, or would you do multiple, halfway through the treatment, or you do at the end to look for residual errors?
We start off with the KV imaging, make sure the positioning is okay. Do a CBCT. Very rarely in between we do a CBCT. Otherwise, no end of treatment CBCT.
All right. Okay. So CBCT also serves us to tell us how the tumor is actually responding, not responding. Anil, what is your take on this? I mean, do you expect with such a short time, would you think that there is a scope for doing adaptive planning for patients with early lung cancer, or you don't think so?
I would say there is a scope, but there's not enough evidence to support that. So because we are treating a very smaller tumors, less than 5 centimeters in size, and there are certain changes that can happen. So within 1 to 5 fractions, for example, after 3 fractions, there can be some changes in the lung, and we should not jump the gun that there are some either progression or lung changes or a volume decrease. Yeah. So we generally don't do any adaptive SBRT planning.
Yeah, and even if we see something and we want to act upon it, by the time we actually get to do it, the treatment is over. So practically speaking, it doesn't really make great sense to do that. So there are certain special situations where we might be a little cautious with our dose and our planning and evaluation. So how large is large? Dr. Shika, can you take that? So do you do only for tumors that are textbook less than 5 centimeters, or would you still take tumors which are more than that?
Usually for patients with such lung volumes, I'm not comfortable taking large tumors, because then the lung receiving a high dose or intermediate dose would also compromise future morbidity.
Yeah.
But a tumor which a patient who has good expanded lungs, who does not have comorbidities or altered lung function, a large tumor which is well separated from the chest wall as well as mediastinum, as long as I'm able to meet the lung constraints.
Yeah.
I'm
So with our technical advancement, we are able to treat larger tumors, but also the downside is that many of these large tumors can have higher predisposition for nodal metastasis. So we'll have to be extra cautious in those patients. And coming back to Dr. Kundan's question, so do we say that patients who have severe COPD, who have got really poor pulmonary function test, so these are again some special situation because surgeon is not going to touch this patient with a 1-foot pole, and you have an option of doing SBRT for this patient. So do you practice any cutoff for these patients, or do you offer to all patients SBRT regardless of their pulmonary function?
I don't have a cutoff for saying I won't do an SBRT, sir. I mean, usually these are competing risks anyway. So I think we have to take care of the concerns. I don't have a cutoff.
Yeah. So the audience question was that what if the PFT showed FEV1 of 20%? So would you still do?
I would still offer.
Okay. Anupam, can I ask your take on that? So this is a patient who has got very poor pulmonary function test. I mean, not so bad. This patient of ours has 40%, but what if he had half of this? Would you still do SBRT, or would you look at other options of RFAs and cryoablations?
So that's a really good question. So we would get a baseline PFT, but that would not change the management. There's a really good subgroup analysis of RTOG 0236 by Stanek published 2013, which saw the results of a patient who had a poor PFT, who got SBRT. That didn't make any difference. So although we keep that as a baseline, but that doesn't make us choose whether we want to do SBRT, yes or no.
So Anil, do you? Yeah, Vaibhav, please.
So the QLQ, which was confined to the lung parameters, did not show any significant changes in the dyspnea for the patients with COPD. So I don't think it should matter.
So it is possibly safe to do even in these patients, but the only patient in whom I would be a little careful is patients with interstitial lung disease, because there you know that it might be difficult. So a word about pre-op SBRT, Anil, would you quickly say, is there any scope for this? I mean, patients pre-operatively undergoing SBRT, we know the results of the missile study. What's your take on that?
Preoperative SBRT has got a role, especially after the publication of the El-Torque et al. Paper that they have combined with the respect to durvalumab, in addition to durvalumab, and they have shown that out of 30 patients, I think approximately 17 patients has got what do we call it, as a major pathological response as compared to durvalumab alone. But also we can debate about that. There's no overall survival advantage to that. So in addition to one single modality, if you're adding 3 modality at the same time, I'm not very sure, are we adding anything better? As well as if you can see one of the paper by the David Palmer, where they have shown that the pathological complete response, because
so
we
this
don't
is a
know.
missile study that I mentioned. So it's not great, 60%.
60% pathological.
This is done at 6 weeks.
Yeah,
so
so
but
it
anyway,
just say,
you had brought up a good point about adding adjuvant therapy, either in the neoadjuvant or the adjuvant setting. This is because many of these patients who undergo SBRT have a significant risk of local regional failure and also distant metastasis. So how many of us actually would add adjuvant systemic therapy in our practice? I mean, this is not standard as of now, but would any of the panels differ in this, do it differently?
So may not be systemic chemotherapy, but as I said, it was adenocarcinoma mutant patients. Yes, you would ask them to visit your medical oncologist friend and see if there is any role for TKIs or any of the drug which is oral.
But there's a lot of interest now with combination of immunotherapy, as Anil was mentioning, along with SBRT. So I'm going to just come to the last part of this. So this is a patient, this is what Dr. Sayan was showing in his presentation, who had undergone SBRT, and this is the post-treatment change that we saw in this patient. So what is your post-treatment follow-up schedule? Dr. Sayan, if you can take that quickly.
Yeah, we usually do the scanning after 3 months, not before that. CT scan, not a PET CT scan, and maybe after 6 months we'll do a PET CT scan also.
Okay, so do the panelists, all of you agree that you would do imaging probably at 3 months, not necessarily a PET CT scan, because PET CT scan still shows some inflammatory changes, but that practice can change, because in some patients the PET CT would help you to at least rule out distant metastasis and regional failures also. So yeah, and we did see from Dr. Sayan's presentation about the various high-risk features that you would look at. So it is very important that you do monitor these patients serially to rule out, to differentiate between disease and disease recurrence and treatment related changes. So if there are any questions in the from the audience, I'll be glad to, our panelists can address.
So I have a comment. My comment is that for lung lesions, even the role of fluoro to assess the motion should not be underestimated. I think it has to be put to use more often. And sometimes fluoro not only can be done in a diagnostic radiology department, can also be done on a LINAC as a quick screening tool. It really helps.
Absolutely, I take your point. It's a underused modality in our setting. Yes.
And another point from my side is that for image verification, it has to be some respiratory correlated CBCT, either a 4D CBCT or a breath hold CBCT or a fluoro on machine to verify whether the breath holding process is correctly in place or not.
4D CBCT is not something that is widely available, at least. Do you have in your setting?
We do not have, but you can at least take a breath hold CBCT. If you're using DIPH or ABC, you can do that. And another challenge that I face is that suppose we put the abdominal compression in place, then how do you take the 4D CT scan? Because where do you put your infrared marker? How do you take care of that?
So anybody who does ABC can probably take that.
Anyone
for ABC,
abdominal
sorry,
compression.
abdominal compression.
For
Sorry, not
abdominal
ABC.
compression, we don't use.
So you don't use. Dr. Sayan, what is your?
Yeah, what we do is we have made an abdominal compression device which fits in the just at the edge of the edge of the ribs. So and above that we put the bellow for the 4D CBCT. Sometimes above it and sometimes, because this is a small, I could not show you. If I can show you, you will easily understand that both can be used together. It's not a big problem. In every patient we are using that and both can be used. So it's just a small device which fits in the sternal angle. I mean, not the, I mean the costal angle, and it compresses the diaphragm. So under the outfit, and both can be used together.
Ma'am,
So,
there's a pneumatic device also, which is like a strap. We can strap it around the patient. And
Yes, that's
use
what we use. Yeah, that's what we use.
That's a pneumatic. This
So,
one. The one
yes.
what is shown is a physical one.
We are using
Philips. Yeah, Philips.
we are using 4D cone beam CT in those patients when we are using MIP based or ITB based treatment, and for breath hold we are doing normal CBCT, and the symmetry we have with the Electa, that 4D cone beam CT, there is no need of putting any marker on the surface. It actually detects the tumor movement there.
So if you're a ABC user, you said that it is a very robust system, and I completely agree with you on that. Is there any possibility of generating the respiratory waveform using ABC and doing a phased based gating using ABC? Have you any experience on that?
No, so we are doing only breath hold. Yeah, but there is possible.
One small comment about the ultracental and cylindrical tumors. The isodose prescription, as we have learned from the I think Hylas trial, it should be more than 90%, because there were a lot of toxicity, because the high dose might land up somewhere in the vessel that can cause hemorrhage. We had one patient. So now we have started giving 90 and more than 90% isodose for the ultracentral and central.
So the dose that you give also is probably is what is important. So
around
we have been
8
doing
fractions,
7.5 gray, and in some patients with central tumors, Anil can again opine. So we do a little more conservative dose fraction in those patients, and we thankfully haven't had too many complications. Anil, yeah. Please.
So regarding the fluoro, Vinita, so very important to see the first PET CT. First PET CT, if your fusion is very good, the movements are probably low, because you are doing a PET in a very slow motion. It's like radiotherapy. CT breath hold is right. So that is so you should see that. So that will give a great idea. You did not do a fluoro. You can do a fluoro for matching your CBCT business, right? On a LINAC. But you know TMH, तो 1 minute होता है तो सर पीछे पढ़ते थे. मैं भी पढ़ता हूँ. So that is one business. Naveen said we are conservative. Naveen, I really want to say that I am a conservative guy, but our tumor size was really big to begin with. So that led to conservatism. So everybody says 18 in 3, I'm fine with that. You want to treat 18 in 3, one Chitku or 34 in 1, I'm the game. But be cautious on that.
Absolutely. So patient safety is.
And we started with conformal. Last point, want to say that definitely you don't prescribe at 67, right, %. Always be 90, 95. You'll be safe. Alternate day is important, especially for central and ultra central. Don't land up in a quick go and you say that you can go home. No point. Timmerman burnt his fingers. Even in re-radiation, everybody has burnt finger for acute toxicity in head neck also and in lung also. So alternate day is बुड्ढा बुड्ढा लोग होता है आराम से कर रहा है.
Thank you so much, sir. 10 fractions, yeah, 5 into 10 is what. All right, so I think we managed to cover most of the pertinent issues. We might have left few, but I think we covered all bases. I thank the panelists for their kind participation and also the audience for their active participation. Thanks again to Anupam and Sayan for joining us. And as we end, I request the chairpersons to also give an expert opinion, then we can end the session.
So I think we have had a wonderful session since morning. All the talks were very good, excellent. And of course, a superb panel discussion, which practically covered most of the practical aspects of lung SBRT. So I think, thank you very much, Naveen. And thank you all the panelists. And I think we'll move forward from here.
Yeah, thank you.
And yeah. So now this is a session called special lectures. So to begin with, I'll invite Dr. Kundan Singh Chofal, who is a senior consultant in radiation oncology and chief of breast and thoracic radiation services at the Rajiv Gandhi Cancer Institute and Research Center in Delhi. Dr. Kundan is going to speak on AI and radiomics in lung cancer, including SBRT.
So good morning. Good morning, everyone. So just waiting for the slides to load. So I have taken the liberty to slightly deviate from the topic to speak on AI and radiomics. I think first of all, we must be very comfortable with these terms actually to understand what actually we are talking about. And then the major portion of my talk is like 60–70% is basically the basic concepts of what artificial intelligence and radiomics is, and probably 2 or 3 studies which will actually explain you how it is being used in clinics. And the other aspect is whenever we talk about artificial intelligence or radiomics approaches, there are 2 aspects of it. One is a process-driven thing where we are using these technologies to make our processes more automated. And the other is a model development, predictive and prognostic modeling. So my main focus is basically towards the predictive and prognostic modeling in this particular talk, because I don't think in 15 minutes we can cover each and every aspect of it. So this is our AI lab, where we are working. We have 4 GPU-based computers on which we do all sort of calculations, and these are behind the scene codes, Python codes, which we use for our AI and predictive modeling. So the very basic question, how do we actually make a research question for any sort of an AI-based or a radiomic-based approach? Conventional teaching is we formulate a hypothesis and then we do a data collection and then we analyze and interpret it, and then probably we get some sort of a new candidate biomarker, and then we do a technical and clinical validation of it. But it has its own limitations, because when we are talking about clinical data as well as the imaging data, we are having a huge amount of data which we can generate from these medical images. And to follow this conventional approach is not the right approach in this particular scenario, because we can't actually do all kind of statistical analysis in these scenarios. So what we do is basically we do a data collection and then we do a technical validation and we try to find it's an exploratory phase. We have images of maybe 200 patients, and then we try to get as many features from these particular images, and then we try to find out something which is very interesting, and then we analyze and interpret it, and then we formulate a hypothesis on some particular potential candidate biomarkers, and then we actually do a clinical validation in this particular scenario. And this is basically the right way of approaching AI-based approaches for our clinical research. So what exactly is radiomics? Radiomics is basically an extraction of mathematically and statistically derived features from the medical images, which represents the distribution of pixels and voxels and their interrelationship with no a priori hypothesis, which is very important. We don't have any hypothesis prior to extracting these features. And then probably once we have these features, then we try to correlate it with our clinical outcome. The another aspect is radiogenomics. I don't think we can cover that in this particular talk. So the overall process is we collect the data. Data here we are talking about the images as well as the clinical data. And then we do some sort of feature extraction with the help of some softwares. What we are using is CERR, computational environment for radiation research, and PyRadiomics. And then we have multitude of features which we can extract from these images. Then we do a feature selection because not all features are important to us. There are special methods for those particular things. And then there is a discovery phase where we apply machine learning and deep learning approaches to make some sense of this particular data which we have generated from these medical images. And then we do a validation, preferably internal as well as external validation, which is very important when we are developing these models. And the AI and machine learning and deep learning things can be utilized in this whole process, which can make this process smooth. So the challenges is everything is fine when we are talking about radiomics. No, there are some imaging acquisition issues. The different parameters in the imaging acquisition issues can cause many problems. Image quality is an issue. Image labeling, because we have a lot of data. I was talking to Dr. Sridhar. Actually, we have so many images with us, but again, the problem is it is not a labeled data. It is not a processed data, and the segmentation issues are there because multiple segmentations can give you a multiple sort of a radiomics feature which are not in conjunction with each other. And then when we have a limited data, then there's issues of data augmentation which we should use or not use. Again, that is an issue. So data curation and data pre-processing is the most challenging and the major deterrent for any radiomics project. Otherwise, it looks very fancy. You can do so many things, but the major problem is with data curation and data pre-processing, and which takes 90% of your research time. 10% is only the model building. It will hardly take a couple of months to build a model, but the major problem is data curation and data pre-processing. Fortunately, we have some imaging biomarker standardization initiative where they have defined what should be your radiomics feature and how you should collect those radiomic features, what should be the property. And they have some family of features which they have defined in total. And I will very briefly discuss because I can't discuss everything here. And what they have done is where there are multiple institutions where they were actually collecting these features, and then there was a survey, and then they defined that these are the standard thing which you should do while you are collecting your radiomics feature from the images. What we are using is primarily we are using PyRadiomics and SIR here, and these are all I have highlighted in red. These are all the software which are freely available. They are not a paid software; they are freely available. So the shape, we all know that how compactly the pixels are being distributed over a tumor area. That is what the shape features tell us. And then we have a textural features which are very important. The basic philosophy behind this is basically they represent some sort of a biological process. For example, I'll just give you a very simple example. This is a gray level concurrence matrix. So we are seeing an I and J matrix, and this number which you can see here, this is basically an image with gray levels, and this is a matrix where we are collecting a data. So I is 1 gray level and 1. So pair of 1 and 1 we will see in a one particular direction, and then we see that it occurs on 0 times. Then there is a pair of 2 and 2, which we can see here that it occurs 1. So this way we collect the data and then we fill out these matrices, and then we go on other direction, we change the direction, and again we collect the data, and then we fill up this matrix, and then we do some sort of a statistical analysis on these and collect the features. This is the basic methodology. Same way, this is a gray level run length matrix. So I is basically, J is the gray, I is the gray level and J is the run length. So run length of 1, we have 4. 2, run length of 2, we have 1. So same way we actually go in X and Y direction, and then probably we get the matrix and we collect these data. And these are the texture level radiomics features which we collect in our patients. So finally, we have this all features, large number of features. The problem is the curse of dimensionality here, because we have so many features, because in one particular patient, we can get approximately 200 to 300 features. And then we have 100 or 200 patients. So this is basically becomes a curse of dimensionality. You have a wide table, which is very difficult to do a standard statistical analysis in these patients. So we do need to select these features, which are the good features, which like, for example, we have to test and reset. We have a rider data set where those authors have done a CT scan of a patient, and then they have waited 15 minutes, their coffee break, and then again repeated a CT scan, and then collected again the features. And if those two group of set of features, if they are coinciding with each other, then they are good features. Otherwise, if there is some change in those features, we don't need those features. So they are not reproducible. Similarly, there is segmentation, inter and intra-observer segmentation issues. If with two segmentation structures, we have a different features, and again, we avoid those features. So there are methods to select these features, and we select the most stable and reproducible features, remove highly correlated features, and then we get the true radiomics feature, which actually we can work on that. Finally, we do a model building, and we can have a very beautiful models with us. But the problem is, again, as I was telling you, that majority of the studies which we can see, the radiomics based approaches, they actually don't have a basic thing which every predictive modeling should do. They should have a training, test, and hold out set data. And majority of these studies, they don't have this sort of study. And this is a very good systematic review here. Actually, we can see only 10 to 20% conformity was there, where they were actually following all sort of methodologies which should be done in this predictive and prognostic modeling. So very briefly touching upon the artificial intelligence and radiomics part. So this was the radiomics, where we collect a lot of data, and then we utilize these deep learning approaches to make sense of this particular data. And first of all, we must understand what is not an artificial intelligence when we are talking about artificial intelligence. So anything which is explicitly programmed, like we have a data, and then we define some sort of a rules, and then we get an answer. This is not an AI. This is basically a automation. You have a data, you have defined some rule, and then you are getting some answers. And this is basically a explicit programming. The AI and machine learning, in a very crude way, in a very higher level overview of AI, is basically you have a data, you provide answer to an algorithm, and then the algorithm figures out what are the rules, how we are getting these answers. And then when you give them the new data, then probably on the basis of the old data, it try to give you an answer. So it is learning from the old data. So you are giving a data and answer to the algorithm, and it gives you the rules. So a very cartoon overview of what is an artificial intelligence. This is an artificial neural network where we have extracted, we are presuming that we have extracted all the features from our images. These are the 5 features we have selected. And then all the features are being subjected to all these nodes. These are known as neuronal nodes. So they are nothing. They are the mathematical formulations where we actually put all these features into this algorithm, and from one particular mathematical node, it goes to other nodes, and this goes on. And finally, we get a probability that this lesion will be a malignant or a benign. So what our question is, what is our outcome of this particular lesion? Whether we want to predict that this lesion is malignant or benign. So as it has predicted that this malignant has a 80% probability of benign, but we know, because as I have told you, algorithm knows the answer. It knows that this is not a benign, this is a malignant. It goes back and repropagate, and then try to find out, try to adjust the weights of these nodes,
and accordingly change the nodes and then again come back. And this is a repetitive procedure until it gets a better answer or a better probability of what actually the answer is. And this is how the whole neural network works. This is a very basic concept how this neural network works. What is the difference between machine learning and deep learning? We always use these terms interchangeably. So machine learning is where we are extracting features manually, as we are doing in radiomics process. We are extracting features manually and then putting these features into an artificial neural network or any form of algorithm, deep learning, machine learning algorithm. And in deep learning, what we do is this is all automated. We don't have to manually extract the features. These are being extracted by the algorithm by itself. The drawback of this is basically it is a black box kind of a thing. We don't know what actually it is doing. Actually, we just subject the image to the deep learning algorithm. It extracts the features and it goes into the machine. So this is very briefly. I will. This is a paper from University of Pennsylvania, Philadelphia, where they have extracted radiomic features and then they have tried to correlate it with the outcome. I know it's only 2 minutes, so I'm just trying to finish it off. So what they found was actually they could actually divide these patients into a high risk and a low risk patients, and it was correlating with the radiomics features. And this is one study, and the very interesting study is this. I would like to just focus a few emphasis on this particular study. So we all know UNet, where we do automatic segmentation. These are algorithms which are being used for segmentation purposes. The authors very cleverly tried to find out these are the features. What they do is they convolute the features from an image and then they regenerate the contours. So in this particular area, they have so many features, which is like 55,000 features. And from the CT and 55,000 features from the PET. And with these features, rather than trying to do a tumor segmentation, they actually try to do a model building. They try to build a model to get a sense of what actually is happening. And it was basically put into a survival classifier. And there was a difference in survival. The very interesting is, if you look at this image, which is like the pre-treatment images, at a different slices level, this was the primary tumor here, and there was something here, but it was not found to be significant. And once this patient recurred, but the AI algorithm could identify this area, which is highlighted here. So they backpropagated the weights on the basis of which it predicted that there will be a recurrence. And it could actually identify prior to the treatment that there are some areas in the scan which are high risk, and actually the recurrences were happening in those areas. So this is again a very interesting study, and this is a newer approach, which is a dosiomic rather than radiomic. It was a dosiomic where actually they subjected the dose profile of that particular patients and extracted feature from there, and they tried to predict the radiation pneumonitis part. So, and this is what we have been doing. We have many publications with regard to deep learning and AI. We have been publishing these features, though we haven't done anything regarding the SBRT part, but we are doing for esophagus. This is basically a quantitative imaging, artificial intelligence, radiomics combined clinical data. We have a collaboration with an Australian institute and Keele's University from UK. And we have already, this is being registered in clinicaltrials.gov. This is basically the last two slides. The patients who achieve pathological CR after concurrent chemoradiotherapy, they fare better. So can we predict the probability of achieving pathological CR based on pre-CCRT imaging characteristic? And then probably we try to do the radiomics approach as well as a deep learning approach, and we are trying to compare those results. And a very preliminary results, which we published in ESTRO also. So here actually this is, you can see that we have a tumor area which is being segmented. This was automatic cropping was done by a software, and then this was the tumor which was being subjected to AI algorithm. And interestingly, we could have a very good model which can predict the pathological CR. But very interesting was when we back projected the weights onto this particular image, what was the criteria, how the AI algorithm was predicting. So it was actually not doing some sort of a rough thing. The whole weights were concentrated on the esophagus as well as the periesophageal area, and which actually gave us a confidence, actually we are going in a right direction. So this was again a very novel approach where we try to predict the suitability for DIBH using an AI algorithm, and we just subjected the X-ray images to an algorithm, and again we back projected the weight which could define the suitability for DIBH, and it was actually addressing the adequate area. It was not going in any area and defining that whether patient will be suitable for DIBH or not. It has a training accuracy of 93% and validation accuracy of 80%. So it always seems impossible until it's done. And I would like to block your dates for our national conference. We have a dedicated session on half-day session on artificial intelligence, and we will be discussing many aspects of it. Mainly, the major focus would be how to go from theory to clinics. That is the main emphasis of this particular conference. Thank you. Thank you, sir.
Thank you, Dr. Kundan. It was very complicated to begin with, as artificial intelligence is always
Yeah, it's
there.
very difficult to explain everything in 15 minutes.
But I think we made it very easy to at least understand. So thank you very much. I think we are running quite late. So maybe one question, if anybody has got, then we can ask.
Yeah, Anil. No, we haven't done anything. But again, there is a study where what they have done a very interesting thing in terms of SBRT. So in CBCT, they were trying to predict an ITV. And when they projected that ITV to what actually we do on MIP images, and then we generate ITV, and there was a dice similarity of more than 86. So which is very interesting actually. You don't need to do a 4D CT scans and draw the tumors. You can actually do it on a CBCT itself. That is what they showed. So I haven't shown because of paucity of time. So yeah.
Thank you. Thank you, Dr. Kundan. I think we'll go ahead with these special lectures. There are 3 different aspects, and now both are online. So next lecture is by Dr. Srinivas Chilkuri. He is a senior consultant at the Apollo Proton Center in Chennai. I'm sure Srinivas is
Good afternoon, Good afternoon, everyone. Can you hear us? Can you hear me?
Yeah.
Can you hear me?
Yeah, we can hear you. Srinivas, carry on.
Thank you. Thank you very much for the organizers for allowing me to present online today. I'm in Bangalore, so thank you for that. Of course, I think I have been given a very challenging topic because proton therapy is not very well established in this context of stereotactic body radiation therapy. And I will try to do justice to this topic as much as possible. The reason why it is not established is because of inherent limitations of the proton therapy technology available so far. As we know that for extreme hypofractionation, which I like calling it as extreme hypofractionation rather than SBRT, but nevertheless, that is a more popular term. But the requirements for a conventional photon-based SBRT techniques is effective patient immobilization, precise target localization, treatment plan to ensure steep dose gradient, minimize uncertainties due to tumor motion and interplay effects, image guidance to ensure accurate treatment delivery, and motion management are very well established with conventional photon-based image-guided radiation therapy approaches. But they were not with proton beam therapy. First of all, the image guidance was not robust. Very recently, about 5 to 7 years back, image guidance is available as a routine on most proton therapy machines. There was a major issue with the treatment delivery without image guidance. Motion management technologies itself were not very well established. The algorithms which we have been using for last 10, 12 years, Monte Carlo step 3, type 3 algorithms, which are much more advanced for especially in lung cancer SBRT situation, were not very well established with proton therapy. And the interplay effects, especially the tumor motion, especially in the context of tissue motion, transient deformation, and density variation, resulted in major issues in proton therapy when we especially do extreme hypofractionation. With fractionation, it is probably the best dose blurring thing which you can do, that is with fractionation. But when you have lesser number of fractions, these uncertainties get amplified. And this is just an example to show that this is a nominal based situation where if it is a static target, immobile target, then the coverage is like this. And when we give internal margins, which is what we give for conventional SBRTs, we generate, we do a 4D-CT, we generate an ITV, and based on ITV, usually it's very well established. But if you see with protons, ITV as a solution does not cover the problem of motion in protons, especially in pencil beam scanning proton beam therapy. And now we have situations where we are able to use tracking, either surface tracking or tumor tracking, or gating, which is essentially volume repainting, rescanning techniques, which are enabled now to address the motion in proton beam therapy. So there are several motion mitigation strategies available for spot scanning. As you can see, there is significant, if you do not apply these motion mitigation strategies, there is significant underdosage of the tumor. And there are, you can see that with several, I will not go into details, but I think the best type of motion mitigation strategy one could use is regating or rescanning, and is usually sufficient to achieve acceptable 4D plan quality close to static doses. We also had a limitation as far as the technology itself is concerned, the passive scattering. Although this was not in the context of SBRT, we can see that there is a significant benefit with intensity modulated proton therapy compared to passive scattering, and majority of the literature which is coming from lung for both SBRT as well as in stage 3 lung cancers is on passive scattering proton therapy. And this study actually elegantly showed that grade 3 cardiac toxicity and grade 3 pulmonary toxicities were significantly lower with intensity modulated radiotherapy. If you're not using IMPT, you're not strictly deriving the full potential of proton beam therapy for lung cancers. Also, analytical algorithms and Monte Carlo algorithms have been compared for protons, and specifically in the context of lung cancers, analytical algorithms tend to overestimate the dose in target by as much as 10 to 40% and underestimate the doses to 10 gray. So essentially the double trouble. So you are, it should be opposite. It should be, if we have to be more cautious, we want a system which can accurately estimate or even slightly overestimate the OR so that we are conservative. And in fact, underestimate the doses to target so that we are again conservative on that aspect. But this is an article which was published in 2017, and which elegantly mentions that most proton therapy centers in the United States use treatment planning systems that employ a simple analytical algorithm for dose calculation. And this will make all the previous literature not very reliable and not very robust, especially in the context of today. And thereby you can see that now with modern or current generation proton therapy, you can see that there are ways to minimize uncertainties due to tumor motion. There is in fact ways to estimate the interplay effect as well on the modern treatment planning systems. Image guidance is now available as a standard. Motion management techniques are available and can be integrated with pencil beam scanning therapy techniques. This is our protocol as far as motion mitigation is concerned. We do a 4D CT. If motion is less than 5 millimeters, we go for free breathing treatment on protons. If the motion is more than 5 millimeters, we try for a deep inspiratory breath hold or a compression belt. If breath hold is reproducible and for more than 20 seconds at least, if not more, then the patient goes for the breath hold technique, irradiation, the breath hold technique. If not, the compression belt is used. And if with compression belt, if it is close to 8 millimeters, we can treat this patient on protons. Otherwise, we use conventional techniques. So to essentially conclude my first few slides, it is now feasible to deliver spot scanning protons for early stage lung cancers with extreme hypofractionation, the kind of fractionations which we have been routinely using for a long time. But essentially with SBRT, the morning half also showed that the results are excellent for even majority of the tumors. So in that context, why and when should a proton SBRT be used? One thing which comes to our mind clearly is in certain challenging areas, certain challenging patients, where patients could have central or ultracentral tumors, where it could become challenging with conventional SBRTs. We know that several studies have shown reasonably high rates of grade 3 and grade 5 toxicities in these group of patients. Of course, we've learned to fractionate them, lower the doses, but if you strictly want to see in these patients, there is a definite amount of toxicity. Another challenging situation is when we have multiple tumors. When we have multiple tumors, again, this is the constraint for 5 fractions, 1500 cc or 1.5 liters with 12.5 gray or less, spared lung. And this is a constraint from RTOG trials. And sometimes this could also be a challenge when we are treating multiple tumors. And these are situations when we want some other technique to ensure that we are able to restrict our doses to the normal healthy structures. This is a Particle Therapy Cooperative Oncology Group consensus statement on proton therapy for early stage lung cancers. And the committee clearly recommends that for small peripheral tumors, there is absolutely no benefit using proton SBRT, and there is no benefit over photon SBRT and should not be used except in certain exceptional situations, such as in interstitial lung disease or in patients with prior RT. Large peripheral tumors could derive some clinical benefit. Select patients may benefit, dosimetric comparisons may help. But in patients who have central, ultracentral tumors, where challenging to limit to the doses to the constraints, tumors near brachial plexus, when we have multiple tumors, recurrent re-radiation setting, these are the patients where one could benefit. There are now multiple dosimetric studies which have shown that there could be sparing of aorta, brachial plexus, bronchial tree, esophagus, pulmonary vessels, heart could be spared better with proton beam therapy. Of course, this is from the era of the passive scattering proton therapy, not the full potential of proton beam therapy. Also, chest wall, there have been 2-3 studies at least showing significant dosimetric benefit as far as chest wall is concerned in patients receiving proton beam therapy. Similarly, there was a multicentric in silico clinical trial which also compared conventional SBRT versus passive scattering proton therapy. Again, there is some benefit, but very modest benefit. As I said, this is not the true potential of what proton beam therapy plan can generate. There is a large retrospective nationwide study which actually included 669 patients with 682 patients, all treated with stereotactic body proton therapy. T1, T1B, T2A, the doses were very comparable to what we usually use for photons. Median follow-up of 38.2 months, and they showed very comparable results with what we usually see with the photon SBRT, with much less toxicity. And this is the table they compared between conventional SBRTs in Japan and other multi-institutional series, compared them to proton beam therapy, and you see the local progression-free survival and overall survival was are quite good, and the rates of pneumonitis was quite low in this group of patients. This is a national cancer. Thank you, sir. National Cancer Database analysis also showed that there could be some benefit with protons as far as overall survival as well as progression-free survival was concerned, as well as toxicity was lower compared to grade 3 to grade 5 toxicity were lower in patients with SBPT compared to SBRT, of course, with all the limitations of National Cancer Database analysis. This is a phase 2 randomized trial between SBRT versus SBPT, but this was a passive scattering proton therapy. Unfortunately, the trial was prematurely closed, showed that limitations of doing a randomized trial in situations such as these. This is our experience so far. This is one of 73-year-old reformed smoker with solitary pulmonary nodule, right lower lobe lesion, underwent lobectomy, poorly differentiated adenocarcinoma, then had a mediastinal recurrence, subcarinal recurrence, received chemo-RT for the same, and then had another right paratracheal nodal recurrence for which surgery was done. EGFR, ALK, ROS, PD-L1 were all negative. Right hilar recurrence after a particular time, and then this was our first patient of re-radiation of central tumor, where we used proton therapy, and we used, of course, because it was the first patient, we were cautious and we used 16-15. and we could achieve excellent conformality, and we could spare the proximal bronchial tree to all the constraints. This is another patient who had extensive ILD. You can see on the PET, and there was a tumor, and there were a few nodes as well, and then all the nodes were negative, reactive, and we took this up for protons, and this is the patient, and this was a patient who was on 5 liters per minute oxygen while the continuously. The patient continues to be on 2 liters per minute. The oxygen requirement slightly come down. There is a complete response, and you can see that there is hardly any reaction around the tumor after proton beam therapy. Similarly, we have treated multiple tumors. You can see the multiple tumors here, and we have been able to treat these patients with SBRT. Of course, some of them are been also oligometastatic, where we had to treat for oligoprogression. And this is my conclusion slide, that small peripheral tumors, absolutely there is no indication for protons. In challenging situations, when we have large peripheral tumors or ultracentral tumors where achieving those constraints is very difficult, or tumors near brachial plexus, multiple tumors, recurrent re-radiation, in these situations, proton therapy could be utilized to deliver extremely hypofractionated radiation. Thank you so much.
Okay, thank you very much, Srinivas. Excellent talk, and of course, not much is known about protons' role in SBRT. Maybe just one quick question due to the paucity of time, or any comment from the audience. If none, then we move on to the next talk. Thank you very much, Srinivas, once again. Dr. Anupam Rishi from Florida, Moffitt Cancer Center, he'll join us now to talk about MR-guided lung SBRT.
Hello, everyone. I am Anupam Rishi from Moffitt Cancer Center, Tampa, Florida, and I'm really excited to give this talk on MR-guided lung SBRT and share some of our experience. Many people who don't know me, I am an alumni of Tata Memorial and PGI Chandigarh, and I'm really excited to give this talk in front of my teachers, friends, and colleagues. I would like to thank the entire Lung Masterclass team and Triranjan for inviting me for this talk. Since I only have 15 minutes, unfortunately, I was not able to take a deep dive into the adaptive planning process in my talk, but I've shared my email. If anyone is interested, feel free to reach out. I have no disclosures. Lung cancer is a success story of SBRT, and it has revolutionized treatment for early stage lung cancer. SBRT, as we know, is a precise delivery of ablative hyperfractionated high radiation dose, typically with BED greater than 100 Gray to the target, while limiting exposure to the surrounding normal tissues. Despite lung SBRT being very effective, there are specific challenges in treating these patients, such as critical location, that is central or ultracentral tumor, close to mediastinal structures such as esophagus, trachea, vertebral body, and chest walls. Excessive motion, that is especially with lower lobe tumor, which lead to increased target volume due to greater IGTV expansion to encompass breathing movement. Large tumor, and last but not the least, patient with pulmonary comorbidities. Let's start with a case. This is a 71-year-old gentleman that we recently treated at Moffitt, had 1.5 centimeter nodular mass adjacent to the trachea and esophagus. PET scan did not show any distant disease. EBUS was performed that showed squamous cell carcinoma. So he was staged as T1B and 0M0 or stage 1A2. He was medically inoperable. Just so that we are all on the same page, let's quickly talk about central and ultracentral lesions. So central tumor was initially described by Timmerman as 2 centimeter around the proximal bronchial tree. RTOG 0813 defined central tumor as 2 centimeter in all direction around the proximal bronchial tree or immediately adjacent to mediastinal and pericardial structures, often referred as the no-fly zone. Recently, Nordic Hylos trial defined ultracentral lung tumor as PTV overlapping trachea or main bronchi. They broke this into two definitions of Hylos A and Hylos B. Hylos A include patients who had tumor less than equal to 1 centimeter from main bronchus or trachea, and group B with patients less than 1 centimeter from other regions. So the case that I showed would fall under Hylos group A. So my question for the team, everyone who is here listening my talk, is to think, how would they typically treat this patient at their institution? Just to put things into perspective, let me describe the results of the recent Nordic Hylos phase 2 trial. They included 65 patients with ultracentral disease. 39 of them were in group A, that is less than 1 centimeter from the proximal bronchial tree, and 26 patients with group B. They treated all patients with SBRT, 7 gray times 8, to total of 56 gray, and they prescribed to 67% isodose encompassing the PTV. So the main crux of this trial that I want to highlight is the toxicity. Look at the figure on the right. So every red dot that you see here denotes a grade 5 toxicity. Just so that we are all on the same page, grade 5 toxicity means death related to the treatment. And they had 15% grade 5 toxicity, most commonly from bleeding, in their entire group, which is very unacceptable. So the main question that comes to my mind and many people's mind is, why was such high toxicity observed in the first place? So our team at Moffitt, led by Steve Rosenberg, who is the director of MRI program, looked into the Nordic Hylos trial patients and plan and wrote an editorial in the JTO. So they prescribed these patients to 6-7% isodose line. So when you calculate, this led to almost like 150% hotspot in a patient with tumor in a very critical areas. That's not good. And there were a lot of heterogeneity on the setup and margins across different centers, with margins varying across different centers from 4 to 7 millimeters in transfers to 5 to 15 millimeters longitudinally. So when you're using such liberal margins around vital organs and treating with ablative dose, we have to be very, very careful. One thing that we don't often realize that both tumor and the normal tissues shift daily with both interfraction and intrafraction treatment movement. This may not be relevant with conventional fractionation, but with SBRT, especially when we are treating close to vital structures, this shift matters, as we have seen the results of Nordic Hylos trial, which may even cost life. So this is one of our patients for MRI image on fraction 1 and fraction 2. And if you notice here, they have a significant change of the position of airway and esophagus relative to the target. So how do we navigate around this without compromising the dose to the target? One solution is adaptive replanning, or when using an MRI, there's a more fancy term for that called SMART, or stereotactic MR-guided adaptive radiation therapy. So what is adaptive planning? It is a change in radiation plan to account for physical changes of tumor or normal anatomy each day. And this gives us an opportunity to personalize treatment for each and every patient. Traditionally, it has been challenging with the use of cone beam CT due to poor visualization. Or sometimes we will even do an interim CT simulation and then replan patients altogether. But things have become much more easier and efficient with the use of MR-Linac. So there are two main types of MR-Linac commercially available. One is the Elekta with 1.5 Tesla magnet, and other is ViewRay Meridian, which uses 0.35 Tesla magnet. And this is the one that we have in Moffitt. And both of them are FDA approved. Biggest trade-off with MR adaptive radiation is the time and that it is labor intense. The first thing that we do is patients get an MRI and CT simulation the same day in treatment position. The images get fused. We do the planning and QA similar to a standard IMRT plan. Then the patient comes for treatment, gets MRI on every fraction. We look at the MRI, quickly contour the OARs and the targets, and then check whether these patients constraints are met and if there is a need for adaptive plan. Once the plan is approved and QA is done, the patient gets treated on a Cine MRI mode. So Cine MRI is nothing but a live MRI in which we can see the movement of tumor and do gating if the tumor goes beyond certain threshold because of the breathing movement. This happens every day the patient gets treated. So the biggest trade-off, as I said, with MRI adaptive planning is the time and that it is labor intense. So the entire process of patient positioning to the treatment can take up to 50 minutes every day. So the coolest feature of MRI adaptive plan is the ability to do table adaptation to detect anatomic changes and then to rapidly reshape dose delivery to accommodate the changes each day. With the use of MR-Linac, we can also do gating by detecting slight interfraction motion during the beam delivery, which is also pretty cool. So by doing those things, we can certainly reduce the margin to 3 millimeters or even lesser because we are seeing in the real time that the tumor is getting treated or not. This is a figure from Dr. Henke's paper from Washington University at St. Louis. This is an ultracentral tumor and just wanted to highlight that how actual dosimetry can differ on daily basis. So fraction 1 met all constraints. The same patient on second fraction resulted in violation of hard esophageal and tracheal constraint. So if you look at the DVH, you can see how trachea was receiving before adaptation higher dose, and the dotted line was after the adaptation. Netherlands, Dr. Fenazi's team was pioneer in MR-guided adaptive radiation therapy, and they published the initial experience in Red Journal back in 2019 of 25 patients. And out of them, 92% of the patients needed adaptation. So let me be clear here. We adapt patient during treatment only when we realize that the anatomy has changed so much that we are not able to meet the goals of the either target delivery or OAR constraints. The same group by Fenazi published their clinical outcome in 2020 in Red Journal. They had 54 patients, all central, 30 patients of them was central lung location. Some of them had previous radiation and 7 patients had interstitial lung disease. So they treated this patient with 7.5 gray times 8 in majority of patients. Some of them got an even higher dose of 11 gray times 5. And 91% of the patients get adapted. But the crux which I want to highlight here is the toxicity. Remember the Nordic Hylas trial toxicity of 15%? How much toxicity that the Fenazi group saw was 0. So coming back to our case, what we did for our case for this tumor next to the esophagus and the trachea, we treated this patient with 60 grade 8 fractions with a PTV margin of 3 millimeters. We used the 95% of the target within 3 millimeter boundary to trigger treatment. What does that mean? This means that every day when we do a treatment, we do a Cine MRI and we treat the patients only when 95% of the target are within our set goal of 3 millimeter expansion around the target. So out of 8, 7 fractions got adapted mainly because of the esophageal dose constraint. Recently, we presented our data in ASTRO. One of our star resident, Mari Sandoval, presented her paper and she was kind enough to share a slide. So we had 29 patients that were treated with SMART. Majority of them were secondary disease. All the patients had central lesions per RTOG and 86% fit the criteria of group A Hylas trial. So what we saw was that it was a great local control of 95% at 1 year. But again, what I want to highlight here is we also saw 0 grade 4 and grade 5 toxicity in contrast to 15% that was seen in Nordic Hylas trial. So just to conclude, the main advantages of MR-guided radiation is that ability to give smaller margin. We can do real-time gating and tracking, and most importantly, on-table plan adaptation to change daily anatomy. the biggest trade-off is that it is resource intense. So we have to be very careful in selecting the patients which has high risk involved with technically challenging treatment, such as patient with a central tumor location, who have significant motion, or patient with a significant pulmonary comorbidity, and some patients who have received radiation in the past. So right now we are also in collaboration with the Baptist Hospital of Miami doing a prospective trial, the Lung Star trial. We have patients with both Group A and Group B treated to 50 grain 5 fractions to 60 grain 8 fractions respectively, and it will be really interesting to see the outcome. I would like to thank our entire team at Moffitt, including the MR guided radiation therapy team, Dr. Rosenberg, Dr. Sandoval, Dr. Sim, and entire residents at Moffitt, all the team, all the physicians, physicists, and therapists, and definitely my teachers, friends, and colleagues at Tata Memorial and PGI. Last but not the least, I would also like to thank the entire team at Masterclass on Lung Cancer and Trunanjan for inviting me for this talk. Please don't hesitate to reach out to me for any question. I've shared my email address and also my Twitter profile. Thank you very much. It's been a pleasure. Have a good day.
Good lecture. Thanks, Rishi. This was recorded. Before we close this session and come to the next session, I think JP has requested to give his talk early. He has to leave a little early. I think everybody knows JP, and I'm sure JP also knows everybody who's ever there in the hall. So that's more important. So JP is going to speak as a special lecture, Flying in No-Fly Zone. And I'm sure JP will also come out of this no-flying zone in 15 minutes time.
So I'll try to finish and fly to the lunch very fast, sir. Good afternoon. It's a pleasure to be here. Thank you, Trunanjan. Thank you, everybody. I think Anupam has made my life very easy because he referred to the HILUS trial and all those stuff. Okay, and I have really no conflicts to disclose. Okay, how do we move? Yeah, that's what I'm trying to move, sir. Slide changer is different, right? Okay, we'll do it. Manually कर सकते हैं? हाँ, manually. Oh, great. We'll do it. No problem. I'm happy to do that. Okay. So we are learning about the SBRT. I think the whole purpose of doing this was we have to be very sensitive that we are giving beyond conventional doses in a very, very conformal way and in a very short period of time. And it is like in a festival, you know, if you are given only one shot, you have to be really precise. If you have given 30 shots, you can do here and there and you can make a smear out of it. So zero error technically. So that's what it is important. And the worst part is that 67% they were discussing about across the hall how much to give at the edge or the physicist perspective. It is really, really a serious business because you want to give a high dose in the center and a rapid fall off, right? So the whole HILUS trial was that, are you ready to prescribe at 67%? And are you ready to accept even a small dot of 150? Probably not allowed. So most of the time we play really safe, and we have not burnt our fingers because we were in the range of 90, around 90 or 85, 90, 93.
So that's the reason I think we were safe. Even we had a larger tumor, even if we have a little central or ultracentral tumor. And definitely it is an attractive proposition for any patient. It's like coming daily and going out, and we can give a reasonable comparison overall survival. So this is, I think we have discussed in length, how do we do at TMH? And I think at many other places, it's almost the same, barring small minor here and there. And, but as a clinician, I think onus start from the day zero you see a patient, and how best we can negotiate the patient to a good local control and ultimately for his survival. So the Timmerman was the big bull in the American way, and he really pushed the whole business of high dose per fraction against many of his chairs, right? Because at that point of time, it was not rewarding in a capitalist state with money, you know. You can't complete the treatment within few fractions. So that even that code was not made at that point of time. So he had to take really a big burn. But when it started moving, even the codes were changed. Even the insurance company were forced to change their codes, because insurance company were getting huge money out of it. Good control means in a short time, it means it was rewarding for the insurance company. The guys are going to give more money, you know. So they changed the code. So that was the whole purpose, that still many people are stuck to that 5 fraction business, you know, in US. And if it is even Astro and everybody says 5 fraction, you can't go beyond that. Even to do a 8 fraction, the code changes there. Fortunately, it is not for us. Huh? So, but irrespective of that financial background, the controls were really in the order of 90%, you know, and 3-year and 5-year control, whom they thought they are doomed, guy. And this is pre-driver mutation eras. So they were really, really very happy on that. And the whole world started taking a big note of it. But there was some downside. We were learning about it. The moment what we realized in his subsequent studies, that few patients are having excessive toxicity. And if we go through the background of the literature, it is something 10 times more. And when they did, even in such a small subject, even 70 patients, it is not a smart idea to a multivariate analysis, right? Because the outcomes are going to be very small in number and change. But still, they came out and say with a conviction that tumor location is more important, and followed by the size of the tumor. So when we started with, we will not do more than 5 centimeters, right? That was one of the things. But then they subsequently came out, no, tumor location is as well important, maybe more important, if you want to have a toxicity profile and free from toxicity. And you see the difference, you know, the toxicity differences. But in such a small study, there was no differences in overall survival. So the bottom line was how to get rid of the toxicities. Classical of American. We start with the top and then we come down, or the Britishers way. We go up from 1st to 5th floor. So probably we are British trained in our mind. So we said, okay, we will escalate the doses. Okay. So then they gave, and Seppenold in her thesis with Timmerman group, they gave a concept of something what we say PBT, or a proximal bronchial tree. Okay. And they classically said it as no-fly zone. In their, one of her nice paper she wrote that probably this is a no-fly zone. And it was nothing, very simplified way, you know, elegant way to say that you draw your peripheral bronchial tree on a contouring station, draw 2 centimeter expansion, right? And in that 2 centimeter expansion, what it will contain is till your
right and left lower lobe bronchi and some of the secondary ones. Okay. So this is depicted on this picture, but people are just not satisfied. We will start working on and understanding the biology and toxicity. So over the period, if you see every 6 years, something is changing, right? So you need to have some studies at 3 years, 5 years. And what we have realized is in RTOG, the Chang and group gave ultimately what is really a sensible no-fly zone. We understood only the proximal, probably the bronchus was a problem. Then we understood no, mediastinum was also a problem. But now we understand, and with the resources from the breast group by Dara Sarvi, that even the heart is a challenge. So we came out anything in the mediastinum structure within that 2 centimeter and realized that 2 centimeter that has been really constant. So please apply the mind, and you may come out with something much more brilliant to say that maybe 5 mm was great because Anupam did on a MR Linac, and the Hylas guy says anything which is abutting it or within the 5 mm and 7 mm. Oh, really? Halfway right, probably. Okay. So half marathon done. Okay. I'm not a marathon guy. Deepak, continue. So we were talking about any radiation oncologist. We are always worried about parallel and the serial organ. Probably what we realized, the central structures or the mediastinal structures are always almost having a problem. And that too within a short period of time. And they can be from the bronchopulmonary hemorrhage, which can be fatal, to a late effect of a stenosis, which can cause in an already compromised COPD patient a pneumonia, a sepsis, and ultimately the death, right? So your stenosis is important, stricture are important, as well as the hemorrhage is important, which may ultimately cause a terminal event. Don't forget the esophagus. All these hollow organs, even if you treat a small dose, okay, you may land up in a perforation or even a cause of a fistula, and that may lead to shortening of life. So what we understood, these are classical serial organs, and most important, most of these guys are on some concomitant medication. Blood thinners are common thing. So they land up in doing a pulmonary hemorrhage very quickly. So what we learned in IMRT right from day 0, that we need to contour everything, because if you don't contour everything, the IMRT or a VMAT deposits the dump which has not been contoured. And that was one of the reason I think that led to fatal hemorrhages. Even a small volume or a point dose is classically important. You know, if you give more fractions, it may smear it out. But if you give small fractions, it may not smear it out and may cause a grade 3 and grade 5 issues. So another thing what we learned from this was dose per fraction is very important. So when we started with 53 after the heterogeneity, 54 in 3 after heterogeneity corrections, it was 18 gray in 3. But subsequently, we came out to 10, and now in my mind, it is still 7.5 or 8 gray per fraction, okay? But many people are practicing around 10 gray. So that is fair enough. So most of them, I think the European guys are doing a risk-adapted approach. And if you see that, if you do a risk-adapted approach, your likelihood of a toxicity is not going to be there. So there were hardly any grade 3 grade toxicity. So it appears to me as one of the ideal way to move forward. And definitely on the basis of your tumor size, you are going to get a tumor control. So I think Anupam didn't mention this study RTOG 813. So this is an important study. I think Andrea Bezak has done a great thing in introducing this study. So there were different chairs for in RTOG for even for a comorbidity, there was a chair in this group. So it is such an important thing for me to understand. And it is not a classical phase 1, phase 2 study. Phase 1, phase 2, what we understand and have been read that you reach some level and then you increase the level and then you go on. So what they did was, depending upon the time which comes, they gave the doses. So the first step was taken at something like 10 gray and then subsequently, but they continued to follow. They didn't stop at that component at 10 gray, and that led to good things, and they came out with something called maximum tolerated dose. So if you are interested really in the statistics of a radiation oncology and what is the way out to juggle the late effects, this is the paper to be read. Okay, so I will not go much in detail twice, but what it showed that 12 gray is probably the maximum tolerated dose. You should not go beyond that at any point in that central tumors. So this is our unpublished data of a 50 patients, first 50 of a central tumor, and reasonably okay. So then there came up something of a concept of ultracentral tumor. What Anupam was mentioning was something like a tumor, let's say that in a simple term, either it is encroaching the central structures of esophagus, bronchus, okay, or they are abutting it or even infiltrating it. So that is in essence what it is. And definitely they could make it out between the studies that central and ultracentral definitely behaves in a different way. And we need to be very, very cautious from the safety perspective. So again, this is a Tetkali's paper. So if you don't respect the PTV in a really nice way in an ultracentral tumor, you are likely to have a death, okay, very soon within first year. And why it is important to think that we need to treat the ultracentral tumor. Sometimes, like in one of our oligomet studies or few of the studies on a recurrent case where the pneumonectomy has been done, like in this patient, there was a single deposit, right? So you have to be very sensitive. There is only one lung and you still need to contour that and treat this, okay? And there are several studies to say that how do you respect the hilar or a mediastinal node? So when they did these studies, I think the outcomes were different and they are reasonably okay in a recurrent or in the nodal studies. So bottom line is what? Good balance between the toxicity and the control. And as a radiation oncologist, we have always respected the OARs, and that is our bottom. But use the good fractionation, max fractionation. We use 5 gray in ultracentral and give to 10 fractions. You may go up to a little bit higher, but be cautious because your volumes are going to be important. So many of us has flown. Flying is a serious business. And the bottom line of any flying, if you see, there are so many checklists every time, checklist. Okay. And the basic principle there is also safety. And if you think safety is important, you have to be proactive. Okay. And how do we do a safe practice? Do protracted course, do protected course. Okay. I don't know how many knows Pet Maverick Mitchell. Can somebody tell me? Naveen, I think he knows about it. Naveen, yes, please tell me. We had a discussion, some chat 2 weeks back in our departmental meeting. Top Gun 2, okay? Be a Top Gun. Don't be adventurous that you do a crash and you repent, okay? Fly seriously, fly safely. That's the bottom line. So be a good Top Gun who flies safely, okay? Thank you. I'm ready for any questions. pulmonary rehab. Okay. Um, so many a times, Vinita, that is our first opportunity that they have gone to any pulmonologist, right? They have their habits over the years. They are coughing, but they have really not underwent and seen any, done any exercise or anything for their chest business. So for me, pulmonary rehab is simply just cleaning the tracheo area tree. That is one. Expanding the alveolus, doing those exercise, improving their basically FVC, right? And if they can improve their FVC and with training, they can improve their FVC 1 second also. So for me, that is a pulmonary rehab. And if that goes in the habit that they need to clean up the system, that continues and that will help them so that QOL is not deteriorated. Yes, dear. So, we have a different grades of ILD. So, simple, the chap who is huffing, puffing is not our business. Okay. He's going to die within a year and with a 90% chance than the tumor itself. So that is a no-no. Secondly, we treat the patients with ILD, but with a very high caution. And we are very cautious that our D2 centimeter or R50 is as narrow as possible. So sometimes we have internal discussion whether to give a CTV or not to give CT to that patient, right? So those are the small tricks what we do, but we are very reluctant to treat, or anybody is reluctant to treat with a classical bad ILD because the complication rates are again very high, acute especially. That is the reason. Honestly, we have not done it. I think there are literature, but you can have a literature on simply on a basis of ERCC1, that is the most commonly can be practiced in any path lab. Those patients who are ERCC1 are going to respond much better to SBRT like a platinum rather than not. So that is one of the tricks you can apply, but we have not applied that.
So any experience on SDRT, single dose in lung SBRT?
Experience.
Single dose SBRT.
I always tie my horses to the others. They don't. But we have done, I think, 2, Naveen. So we have done, that was metastatic. Okay. And both were, I think, one was head neck metastatic, one was, I think, the other one. But I really, I don't like that.
So we are having a case, we are thinking of doing it as SDRT. So I was thinking, what dose should we go for? 34 in single, like 19.5 or?
No, I don't go that jump. Okay. 34, I think many times people want to practice that. हम कर सकते हैं. मैंने कहा आप करो. हम अभी भी उधर ही.
Thank you, sir.
No, that's my thought. You people are smart. When you have a lesion of 1.5 centimeter, you can do that. But many times people have a 0.5 centimeter, they want to do that 34 gray. I think those guys के बीच में दिख नहीं रहा है मेरे को तो. My eyesights are weak, so I'm a bit cautious. But there are technologies available, like Schoffel said that you are not seeing things, but AI is seeing that this can cause a challenge. So something will come up, those things, then we can practice. But I think my protraction is better than the Top Guns. That's my call. That is personal opinion. Okay. And people are doing good 34-1, 32-in-1 and there is a background literature. I can't deny that.
Sir, Dr. Vinay here. Sir, do you give constraint to like bronchioles, small airways?
Yeah. So that RTOG 813 has written down that less than 3 cc. what should be the DVH for the primary bronchus as well as the trachea and the bronchus. They are given that.
Smaller airways also.
Not very small airways, but primarily the secondary bronchus they have given less than 130 BD.
So, sir, can I ask a quick question?
Dose to the Mets versus
Come
the
this side,
primary.
your number is there. Oh, no, Priyas. I think Upasna is here.
So dose to the primary versus the metastatic, do you really change it? Like here in primary, we are always
I
going
got
to.
your point. So there is a literature depending upon what Mets it is, you can change it. But at this point of time, we are keeping it same. If you are going very aggressive, we just want to ablate that, right? That is the reason, like 16, 5, or you are giving 54 in 3 or something like that. So that was the whole point, that they just want to ablate it and bunt it out. So we have not changed it, but there is a literature that in few patients you can really reduce the dose so that you had an opportunity to re-irradiate if something comes up again in that. So that was one of the thought process.
So I agree with your point, between 7 to 10 gray per fraction may be sufficient rather than going to the more dose per fraction, either across the tumor. It may be peripheral or the dose remains the same.
Yeah.
I think in the
Thank
interest
you.
of
I
time,
think
we have to close it.
Overshot?
Yeah, I mean, you're still flying in the no-fly zone.
Apologies.
Come out of that. Thank you, JP. It was very interesting. And I must say
Thank
that
you again, Trinanjan and everybody.
entire session was very interesting and very informative. Now we will be closing this session. I think Trinanjan will take it. I think one important thing, Trinanjan and JP, what you said, why you took the lecture earlier than this, because next session is going to be chaired by Sharmila. So she said, I am chairing at home, so why should I chair it here, isn't it? So interesting. So you want to say final comments?
So once again, I also want to, as a chairman for this session, thank you very much, Trinanjan, for giving me the opportunity to chair this. It was a very interesting and excellent. And once again, to reiterate what Dr. JP Agarwal said, that it is, we have to be safe. Let's not be over aggressive and let's not be over brave. And we have to learn and learn and learn. Thank you very much. It was a great learning opportunity. Thank you.
Thank you so much. Thank you to Srivastav sir and Dr. Sumit Basu. We'll move to the lung with brain med session. To chair the session, I request Dr. Sharmila Agarwal. Madam is senior radiation oncologist in Jaslok, Mumbai. And Dr. Sandeep De is a senior radiation oncologist in Apollo, Mumbai. I think he's online. And I would request the speakers to try to finish in 10 to 12 minutes so that we can have time for the panel discussion. And we all can wish JP sir a belated happy birthday. It was on 19th July.
Good afternoon, everybody. We are already running 1 hour late. So I request all my speakers to stick to the time or complete before time. And there will not be any questions allowed during the in between the two speakers. All the questions to be taken at the end during the panel discussion. I invite my first speaker, Dr. Upasna Saxena, who is a senior consultant at HCG Cancer Center, Mumbai, to deliver her talk. Next is Sunil.
Good afternoon, everyone. I begin by thanking the organizers for having me here. And as they said, I'm going to try and finish it a little sooner. So I will just begin by saying that this topic is more a food for thought for all of those who either take a blanket decision for a whole brain or a blanket decision for a stereotaxy when there are limited lesions. There is a lot more when you are deciding about what radiation modality to select for radiation in brain mets with lung cancers. So about 20% lung cancers will present with brain metastasis, and about 40 to 50% will develop it later. Of course, we all know that the rates of metastasis are much higher in small cell versus the other histologies. And also within adeno, we have a higher incidence with the EGFR positive. Now, with better systemic therapy for these, we have a longer survival with a rising incidence of brain metastasis. If you look at a one-line answer, that is a blanket thing, I would say that extensive metastasis in the body and brain would be whole brain radiation with or without boost to the gross disease. If there are few sites of deposit, either in brain or extracranial, it would be oligometastatic with stereotaxy to address all lesions. If it's a brain-limited disease with multiple lesions, a whole brain with boost to the gross disease, and a few lesions, the definition of which is evolving, then surgery, oblique stereotactic radiation. But we have to read in between lines about the expected survival, the importance of QOL and neurocognition in this increased survival, histopathology, response to therapy, available options of systemic therapy, and the possibility of immunotherapy plus stereotaxy. These have led to a paradigm shift in decision-making for brain metastasis and selection of modalities. So what are the criteria for treatment customization? It began with the RPA, which of course was the most commonly used before it evolved to the disease-specific graded prognostic assessment, which the purpose of which was to estimate the survival, individualize it to the patient, take clinical decisions about treatment based on that, and use this information for stratification for future trials. So the graded prognostic assessment involved criteria like the age, performance status, number of intracranial lesions, extent of extracranial disease, and the site of primary, that is lung, breast, melanoma, RCC, and colorectal cancers. So these are primarily the cancers where a GPA would matter, not all of the cancers. Looking at the GPA for non-small cell lung cancer, we see that a score of 0.5 and 1 is assigned to the different parameters in all of the GPAs. If the GPA score totals to about 0 to 1, the survival is about 3 months. If it totals to about 3.5 to 4, the survival is as high as 14.8 months. Now, on an average, if you would go to the older literature, we had survival as low as 3 to 7 months with brain metastasis, with a RPA 2 having a survival around 4 months and RPA 3 around 2.5 months, which is seen both in international literature and literature at Tata. But later on, it then changed with the molecular GPA coming into picture, which was published in 2017 in JAMA. This used, first of all, split the lung cancers into non-adenocarcinoma and adenocarcinoma. So a 0 to 1 score of GPA was a 3-month for lungs in total, but when split into non-adenocarcinoma in the duration of 2006 to 14 with the newer systemic therapy, it became 5.3 months. For adenocarcinoma, 6.9 months. And if you look at the 3.5 to 4 score, then it increased to 46.8 months. So that means there is a very long survival, and you have to very responsibly take all decisions of the treatment that you're offering to the patient. So the assessment score or the worksheet to generate these scores is available online, and you have to actually just feed all the details to get the GPA score. The most important factors which give a favorable outcome are a 90 to 100% KPS, absence of any extracranial metastasis, and a positive status of the EGFR or ALK mutations. So the DSGPA actually has shown few nuances which were not there before in the previous GPAs. That is, the EGFR and ALK mutations show a much superior survival. They're also associated with a higher propensity of leptomeningeal disease. Number of brain metastasis is also an important factor. And extracranial metastasis, of course, which was already known, is important. For a score more than 3, there is literature supporting that addition of whole brain radiation to stereotaxy gives survival benefit contrary to the practice to avoid whole brain radiation. Now, accurate survival hence becomes crucial to take informed decision for prognostication. We also have an updated molecular GPA, which includes the PDL1, which makes the 3.5 to 4 score patient have a median survival of 52 months. This is further a lot many more things of the same, that we have a molecular GPA for leptomeningeal disease with the current TKIs. We have a survival of as high as 17.7 months for a score of 1.5 to 2. So yes, the paradigm is significantly changing. It is also different for synchronous and metachronous malignancy, presentation of the brain mets. So if you look at a 3.5 to 4 for a metachronous brain metastasis, your median overall survival would step up to 66.5 months. Now, how do we make treatment decision? So there are different aspects. For the systemic therapy, we have treatment guidelines by the ASCO, SNO, and ASTRO, which is a combined guideline. We have recently published ASTRO guidelines, and there are certain articles which integrate these. So how have the guidelines evolved? To begin with, it's broken into two parts, that's symptomatic and asymptomatic. For symptomatic brain metastasis, of course, a poor performance status becomes BSc or a simple whole brain radiation. But if the patient continues to be symptomatic, surgery, if too symptomatic, if not, then depending on the number of lesions, we will select either a stereotaxy, definitely for a 1 to 3 up to 5, now evidence for even 4 to 10. And if it's more than 10, we prefer a whole brain radiation. The newer thing that has come in lung cancer would be asymptomatic brain metastasis. This will largely be dealt by Dr. Naveen in his talk. So I will just briefly make a mention that in the situation where you have asymptomatic brain metastasis, for histologies like non-small cell, melanoma, and breast, you need to customize and take a call. It does not straightaway remain as a symptomatic chart. What happens is that if you have a systemic therapy option in these, you have to take upfront systemic therapy or brain radiation, but that entails regular follow-up with MRIs, the treatment and availability of TKIs. So the cost and accessibility of TKIs, cost and accessibility of MRI, education and awareness to understand the same, and risk of precipitating symptoms in larger metastasis. These are the things which one has to bear in mind and has to be taken a decision as per the patient in front of you. So the ASCO guidelines say that for symptomatic brain mets, of course, immediate radiation has to be offered, either radiosurgery, radiation, or a surgical resection. But for patients who are asymptomatic, local therapy should not be deferred unless specifically recommended. One of those recommendations is for lung cancer. So they say for EGFR mutant non-small cell lung cancer, if osimertinib is available, local therapy may be delayed. It does not say it should be. Next is ALK rearrangement. Same thing. If the TKIs, the brain penetration TKIs, second, third generation are available, local therapy may be deferred. It does not say so for the arm where we are using pembrolizumab with pemetrexed and platinum. That is when we have no driver mutation. So for small cell, largely it remains the same, that we do a prophylactic cranial irradiation. There are trials going on to evaluate that subsequently when patient develops a metastasis with multiple mets, whether a stereotaxy is still something which can be opted for. And there are also trials evaluating PCI versus MRI surveillance post the initial treatment. So there's a certain article which says that for brain metastasis, for known brain metastasis in small cell lung cancer, stereotaxy is an option. But if you look at the ASCO guidelines, it still does not recommend stereotaxy. It recommends whole brain radiation. Talking about brain metastasis from non-small cell lung cancer, again, if it's a solitary brain metastasis and you need histopathological confirmation or the patient is too symptomatic, you go for surgery followed by radiation. However, if that's not the case and there is a driver mutation, you have options of a TKI followed by surveillance or TKI, which is coupled with stereotactic radiation. So there are multiple trials which have evaluated the selection of modality, that is whether you would be preferring to use a whole brain radiation with stereotaxy, consider omission of whole brain radiotherapy. And these trials have published the results. I'll just show them in the subsequent slides. They are grouped on the basis of the GPA. There are multiple other trials which also show the same. The ASTRO guidelines per se do not specifically give a histologically or a lung specific guideline. It's more about when to use stereotaxy and what are the doses, which I will just kind of quickly omit because we are a little short of time. But speaking about a single metastasis in the brain, of course, if larger, we need surgery. Otherwise, we can go for direct stereotaxy if we don't need the histopathology, patient is not symptomatic. Upfront focal RT has shown a better local control when whole brain is combined with stereotaxy, but the subsequent trials have said that it should be omitted. Now, what is coming is that when we're talking of, I will be skipping these parts since we're short of time. Now, the other part is that in patients who have undergone surgery and we do post-op radiotherapy, of course, we have a better control by combining, but there is a risk of leptomeningeal disease, which can be combated by using neoadjuvant stereotaxy. So that is another thing which is under evaluation with 16 grain a single fraction given 1 to 3 days prior to surgery, reducing the chances of leptomeningeal disease. Whole brain, we all know, has more neurotoxicity, but though it is going out of favor, but the trials which are published as per the NRG Bean N09 with improving prognosis and systemic therapy options, we can conclude that using whole brain radiation plus stereotaxy plus hippocampal avoidance could be selected for molecular GPA4, which has also been shown by Sperduto in his trials, and the same is recommended. So for polymetastatic, right now, more than 10, it is still the recommendation of a whole brain radiation. And of course, neuroprotectors now, as per the ASTRO guideline, Memantine is something which they have given a strong recommendation to use with whole brain radiation along with hippocampal avoidance, unless the tumor is located close by. And hippocampal avoidance has been shown to reduce the Hopkins verbal learning test to improve to 7% versus 30% deterioration at 4 months. And the NRG CEC001 has confirmed that whole brain radiation plus hippocampal avoidance plus Memantine significantly improves the neurocognitive decline. So I think that's primarily for poor. The last slide is that for poor performance status, of course, we will select as per the quad style, we'll go for a whole brain radiation. Thank you.
Thank you, Upasana. It was a good lecture. Thank you. We now move on to the second lecture, the role of post-op cavity, role of SRS or fractionated SRS after surgery in a brain metastasis. Dr. Pranav Chadha, who is a senior consultant at Kokilaben Dhirubhai Ambani Hospital, will be speaking. I think he will take it online.
Am I visible and audible, I presume? Hello?
Yeah, you are.
All right. So thanks to Nanjan and the organizing team for inviting me. So the outline is regarding the background and the rationale, the evidence, critique, the guidelines and the reviews, and the future studies. So the brain metastasis, a select group of patients, a survival benefit is seen with surgical resection. The whole brain radiation has been a standard of care to improve the local control. However, there has been no survival benefit and there were concerns of cognitive impact. This was in the non-hippocampal sparing era. The retrospective information post-surgery followed by the post-op cavity SRS versus post-surgery followed by whole brain radiation. Some results have been similar with respect to the control and some have been worse. But in spite of the lack of robust evidence, cavity-directed stereotactic radiosurgery has been practiced and preferred by many a neurosurgeon. 2 randomized control trials were designed to answer the utility of this post-op SRS by generating level 1 evidence. So one was with regards to Mahajan et al., in which they sort of compared surgery followed by post-op cavity radiosurgery versus observation, and the other one was by Brown et al., in which they did a post-op cavity radiosurgery versus whole brain radiation. So this is the first trial from Mahajan et al. The study objectives were primary, the endpoint was local control, the secondary was rate of distant mets, overall survival, and the need for whole brain radiation. This had to be 3 lesions, and in which at least 1 lesion had to be grossly and sort of totally resected. And then the patients were randomized with respect to the radiosurgery versus observation, and then a follow-up MRI schedule. So the inclusion criteria, again, a complete resection of at least 1 or even more. The resection cavity, they put up a constraint of diameter of 4 centimeter, and the unresected brain mets had a maximum dia of 3 centimeter. The KPS as per inclusion was 70, and an active extracranial disease was included. The exclusion criteria was that the patients who had received prior radiation and or radiographic evidence of leptomeningeal disease, and the primary tumor being small cell lung cancer, SCLC, lymphoma, leukemia, or multiple myeloma in pregnant females. The radiation technique was to the SRS to the target volume, the surgical cavity with a 1 millimeter circumferential margin. The doses, as the volume was sort of increasing, the dose was getting reduced. It was prescribed at the periphery. The remaining 2 metastases also underwent stereotaxic radiosurgery on the same day, and the dose constraints were with respect to the brainstem and the chiasm. So this was, that is what they presented in Lancet, and this was the sort of inference that it could be an alternative to whole brain radiotherapy. These were some of the details. I'll just skip the slides, and they found that there was a local recurrence, sort of a betterment with respect to freedom from local recurrence with respect to the SRS. Also, with respect to the size of the brain metastasis, so when they did a multivariable analysis, they found out that SRS was better, and the size of the brain metastasis also mattered. So size less than 2.5 centimeter, they were showing a better control. The overall survival was not statistically significant. So other subtle findings were that the 12-month freedom from local recurrence was 43% in the observation and 72%, which was shown. The cause of death was neurological in the observation group was 64% and 48% in the SRS group. 30 of the 65 patients in the observation group subsequently had whole brain radiotherapy, and even 24 of 63 patients, that is 38% of the patients in radiosurgical arm also had whole brain radiotherapy. Also, this was an interesting finding that the leptomeningeal disease, even in the observation group, was 16% compared to 28% in the SRS group. The other trial was done by Brown et al., in which they randomized patients to either post-op cavity radiosurgery versus a whole brain radiation option. The primary endpoint was cognitive deterioration-free survival. That is, they were looking at cognitive outcomes, neurocog outcomes, and overall survival. More or less the same criteria. They had increased the number of brain mets to 4, the unresected lesion being 3 centimeter. Here in this trial, there was no concept of a total resection. There were patients who had also undergone a subtotal resection. The cavity was less than 5 centimeter, and it was a gamma knife or a Linac-based sort of criteria for the radiosurgery. Exclusion criteria remaining more or less same with respect to the prior trial. Radiation technique, the SRS arms, again, as the size of the lesion increased, the dose came down. It was prescribed to the highest isodose line to the periphery with a 50 to 90% of the Dmax dose. This is what they published, and this is what they used, that SRS radiosurgery should be used. So the prior trial was could be, and this was should be. Some of the patient parameters which were well balanced along with the two arms. Now here the cognitive findings were better with respect to the SRS, that is the neurocognitive. As we can see, it was significantly better. But with respect to the local control, the surgical bed control, distant brain, LM, the leptomeningeal disease control, all were showing a finding towards the whole brain. That is, it was favoring the whole brain radiotherapy arm. So surgical bed control, they wrote it as similar. However, it was better with the whole brain arm. And this is what the reason they put up, that that there was some subtotal resection in the study. The surgical bed control was treated by the treating physician, and the higher SRS dose, probably as we sort of, first thing was that as we were going ahead with a higher surgical cavity volume, the SRS doses were going down. And even with the higher dose, they were thinking more in terms of pseudo progression, which would have sort of an imaging false positive for a recurrence. And the patient populations here also sort of differed, and they said that the lung primary was 59% in this trial versus 20% in the Mahajan et al. Trial. Other subtle findings, there was no difference in the frequency of the local salvage therapy after SRS. That is, patients had to undergo either surgery or radiosurgery. In the SRS group, 20 of the 98 patients received, that is around about 20%, received whole brain radiotherapy as a component of salvage therapy. And grade 3 was more or less similar with respect to both the arms. There was a critique of following these two trials, and a couple of them being published. So the observations and inferences were that the leptomeningeal carcinomatosis after surgery, it was a nitrogenic failure. A single fraction dose was insufficient for a local control of lesions greater than 2.5 centimeter. The control of post-op SRS was similar to SRS alone. And the hippocampal sparing, so that was also an option that was not studied. And neurological deaths were sort of put up in this flowchart, like the local control being higher for a whole brain radiotherapy arm, and the toxicity also becomes higher. So then we come to how do we sort of pragmatically sort of implement this. So one was regarding the contouring guidelines for the post-op completed resected cavity. And this was to take into account with respect to failures. So if the patient was having a preoperative dural contact, we need to take the dural picture with a 1 to 5 millimeter along the bone flap, and along the venous sinus, again, we should take a margin of 1 to 5 millimeter. The dural also with respect to 5 to 10 millimeter if there was a bone flap. So some of the findings, this they have put up the venous sinus which is involved, and therefore we need to take into account the target volume post-operatively. Similarly, for a dural contact, to put it up till the dural sort of the bone flap interface. And this is the non-dural compared in the pre-op, but in the post-op, you need to take into account the, I would say, the surgical manipulation. So you need to take the volume here. Again, the volume and timing, very important. When do we start? So both the trials were taking up the patients within 3 to 4 weeks. Now this study sort of put up two volume sizes, that is 2 centimeter sizes. So this was more than 3 centimeter, and they showed that there was a drastic reduction in the cavity size. Whereas the lesion, if it is less than 3 centimeters, the cavity size or the cavity doesn't shrink to that much. So probably with a higher cavity size, and if we want to go for a single session, we need to sort of wait for 3 to 4 weeks for that matter. But for a tumor size cavity less than maybe 3 centimeter, we can start the things a little early. And there were some sort of sarcastic comments, I won't call it, but sort of food for thought, that they said that it was mostly water inside the cavity. And therefore, they said you should also take care of the marginal region rather than the cavity itself. Again, some of the studies with respect to the dural contact, again, mentioning with regards to the control and the dose response, again, with the PTV size. So as the PTV size is increasing, you need to either increase the dose or fractionate it. So therefore, you need to give a higher dose, and especially with respect to the radio resistance. So once you are finding a brain metastasis from a radio resistant lesion, you need to increase or step up the dose, either increase the dose or do a fractionated sort of a regimen. Preoperative.
Sorry to interrupt, but
Yes.
we are short of running out of
All right.
time.
All right, ma'am. So I'll just quickly, pre-op versus post-op. Again, a study was done. Pre-op radiosurgery versus post-op whole brain doesn't make much of a difference. The current status is to fractionate, basically, with the larger lesion so that we can give a higher BED with respect to volumes. And these are the practice guidelines that you can do. You should do a post-op SRS and also do a post-op SRS with respect to neurocognitive. Rest are all level 3 evidences. You need to counsel the patient with respect to the leptomeningeal disease. The future studies are with respect to either a single fraction versus a fractionated, and also preoperative versus post-op. We're looking at either leptomeningeal disease or a composite endpoint event. That is, you're looking for more events and you're sort of adding them up statistically. All right. Thank you so much. Thank you.
Thanks, Pranav. It was
Thank
a
you.
nice talk.
Thank you.
I request Dr. Sandeep Day to call upon the next speaker.
Yeah, hi, good afternoon. Tanveer has delivered his talk in the morning session. So I would call upon Dr. Nikhil Kalyani, who is the consultant radiation oncologist at Jaslok Hospital, Mumbai, to deliver his talk on the follow-up schedule and the toxicity pattern. Nikhil.
Thank you. Good afternoon. Thank you for the invite. I will just go through quickly with my topic. I'm going to speak about the follow-up and the toxicity with the SRS for brain metastasis. SRS has been now a standard for a limited brain metastasis for 1 to 4 lesions. The use is exponentially increasing. It has shown an excellent local control and the cognitive outcome as compared to the whole brain RT. Coming to the follow-up, why we need to do the follow-up after SRS? We need to do follow-up for the response assessment, follow-up to evaluate a new lesion in the brain, which is outside the SRS treated area. Also, we need to evaluate for the radiation necrosis, which is one of the commonest of toxicity post-SRS. We need to evaluate a neurological status of the patient, serial contrast MRI with spatial sequences, and the PET scan to rule out and differentiate between the recurrence and the radiation necrosis. CT scan is usually not recommended in the follow-up for assessment, either for a new lesion or a differentiate with the radiation necrosis. MRI is the golden for imaging modality for the evaluation of brain metastasis. The common sequences are the plain post-contrast spectroscopy and the perfusion. The enhancement is in the treated area is because of the disruption of the blood-brain barrier. The common causes are the tumor recurrence, radiation necrosis, ischemia, or infection. The conventional MRI cannot distinguish between the differential diagnosis. How to differentiate between the recurrence and the radiation necrosis? The features which points to the radiation necrosis are the development of the lesion away from the primary site, the multiple lesions, the area of the atrophy, and the lesions in the contralateral hemisphere. These criteria are more useful for the primary brain neoplasm, which is localized to the one area. For coming to the brain mets, so post-treatment evaluation, we need to suspect the radiation necrosis if there is an enhancing lesion which develops in the bed of a previously treated lesion, a development of the lesion in the area of the leukoencephalopathy, a relatively little mass effect in the size of the lesion, and the lesion is the peripherally enhancing with central necrosis. So there are different patterns of enhancement like a wavefront pattern or a cheese pattern, which points towards the radiation necrosis. Also, there is associated hemosiderin and the calcification within the treated area. Coming to the spatial sequences, the MR diffusion is one of the modality which can differentiate between recurrence and the radiation necrosis, where diffusion can be either a restricted or facilitated. The ADC will give or a apparent diffusion coefficient will give an idea about the characterization of the disease process. The highly cellular tumor have a restricted diffusions like a lymphoma or the melangiomas. Coming to the perfusion, perfusion is very important for differentiating the recurrence in the radiation necrosis. In the perfusion sequence, we get an idea about the RCBB values. The highest RCB values is indicative of a recurrent tumor, whereas the low values less than 1 usually denotes a hypoperfused area and points towards the radiation necrosis. Another is the K-trans factor. Again, it gives a calculation of the tissue permeability. The high K-trans factor is associated with the recurrence of a tumor, and the low values are points towards the radiation necrosis. Last is the MR spectrosequence. The spectroscopy shows the different peaks in the chemical structure of the brain with the Na, choline, create, and the lipid lactate. We need to calculate the different ratios, and the ratios of a elevated choline Na and the choline create favors the recurrent tumor and the radiation necrosis. As vis-a-vis, Na create ratio is lower in the radiation necrosis part. The last, when there is a dilemma on the MR, when there is a different, we cannot differentiate between the recurrent tumor and the radiation necrosis, then the PET scan or a metabolic scan can help. The FDG has a less sensitivity for a brain because of the very high uptake in the normal brain tissue. So the newer tracers like a methionine or FBPA can be used to differentiate between the recurrent tumor and the radiation necrosis. Coming to the response assessment, the RANO criteria have been developed for the brain lesions. Initially, the trial used to do a response assessment based on the RECIST criteria. The main issue with the RECIST is that they consider the brain and the extracranial sites as a single compartment. So you cannot differentiate between the response in the intracranial and the extracranial part. So also there is in the last 2-3 decades, a lot of targeted therapies has been started, which has a significant brain penetration and the effect on this brain. Third thing is usually in all the trials, the symptomatic brain mets patients are excluded. So the RANO BM criteria were developed. This uses the brain as a separate compartment. It has been derived from the RANO high-grade glioma and the RECIST criteria. It uses a single measurement because the brain mets are usually spherical. A clinical status and the use of steroid is included for the response assessment, and it is useful for defining and standardizing the response in the clinical trials. It proposes the different endpoints for the early phase and the late phase trials. Also, it gives the guidelines for the trials which uses the systemic agents which have a brain penetration or effect on the CNS, like to determine the potential of the CNS activity of the drug, understanding the disease response both intra and the extracranially, and for the high-risk patients. These are the criteria for which the response assessment can be done. Coming to the toxicity, the SRS has a highly conformal and dose distribution. There is a rapid fall off. The toxicities are limited. It depends on the location, volume, and the dose of the tissue. Dose of the prescription. The acute toxicity associated are the mild headache, heaviness, nausea, and the patchy hair loss. The late toxicity, the commonest is the radiation necrosis, hemorrhage, and the cranial nerve toxicity if the location is very close to the cranial nerves. Coming to the radiation necrosis, which I will describe in a two or 3 minutes. It is a necrosis resulting from the therapeutic radiation to the whole brain, partial brain, or post SRS. It is a frequent and the well-recognized toxicity. The incidence is reported is 5 to 50%. Most of the radiation necrosis remains asymptomatic or radiological. The symptoms again will depend on the location of the tumor, like a headache, fatigue, nausea, or imbalance in the seizure. There is no single modality to differentiate between the recurrence in the radiation necrosis. A clinical course, brain biopsy, or the imaging over a follow-up gives an idea about it. The pathophysiology is the disruption of the brain blood-brain barrier and the occlusive vasculopathy, which gives rise to the radiation necrosis. There are the different literature and the studies which have given an idea about the constraint or the dose volume relationship, which points towards the higher incidence of a radiation necrosis. It is the idea for the single fractions or a fractionated SRT treatments like a 3 fraction or a 5 fraction. So different volume criteria which needs to be taken into consideration. Again, in the first lecture, Dr. Tanvir mentioned, for a single fraction specifically, if the V12 gray is more than 10 cc volume of a brain minus GTV, then it's always better to do a fractionated treatment to reduce the incidence of radiation necrosis. The other factors which has been reported are the gamma knife has a higher incidence of a radiation necrosis, the PTV margins. If you use higher PTV margin of 3 mm, which has a higher risk of necrosis as compared to 1 to 2 mm PTV margin, inhomogeneity. So the lesser of the marginal dose and the higher central dose reduces the risk of radiation necrosis. Location of the hotspot, more than 105 between the GTV and the PTV increases the risk of radiation necrosis. The systemic agents like a TKI or immune checkpoint inhibitors again are associated with a mixed results. Sometimes some studies says that it has a higher incidence of necrosis. Coming to the management, the steroids are the cornerstone. You need to start with a steroid, try to start as low dose as possible and minimum duration so as to reduce the side effects. The other things are the management are the bevacizumab. The associated toxicity needs to be considered because bevacizumab has the issue of hypertension, proteinuria, the wound healing complications. Also, if there is a hemorrhagic mets, then the bevacizumab cannot be considered. The surgical management are the reserved for the patient who are not responding to the conventional steroids and the bevacizumab. The principle remains the same. You need to remove the enhancing tumor with the surrounding area, which might be causing the edema. If patient has received the bevacizumab, then the surgery should be deferred by around 4 to 6 weeks. The last refractory cases, the hyperbaric oxygen therapy remains one of the options. Coming to some special locations where there is a high risk of some other toxicities like a cerebellum, there is a risk of having a obstructive hydrocephalus post SRS. The only factor which donates a high risk is the previous resection. Brainstem is a critical location. The SRS on the brainstem areas are associated with a toxicity of around 7 to 8%. The toxicities are a bit different with the hemorrhage and the hemiplegia or a weakness in the motor system. The factors are the high volume marginal dose in the pre-SRS, the whole brain receive. For a multiple brain mets SRS, again, it can cause a higher toxicity because the volume of the irradiation increases. Coming to the SRS and the immune checkpoint inhibitors, some studies shows that the patient who receives the immune checkpoint inhibitor prior or after SRS to the brain mets has higher toxicity as compared to the patient who have not received the immune checkpoint inhibitors. Last is the financial toxicities. So if you assess the financial toxicity for the patients who are undergoing SRS, so they have shown that almost 25% of the patients had some kind of financial distress when they were undergoing the SRS. And significantly around 60% of the patient wanted to discuss with the doctors, provided the treatment is not getting changed. Coming to the conclusion, the SRS is the integral in the management of brain metastasis. It has shown an excellent local control and cognitive outcomes. The follow-up with the neurological status and the serial MRI are needed. We need to differentiate between the recurrence and the radiation necrosis, which is sometimes challenging. The toxicities depends on the location, volume, and the dose of prescription. The symptomatic Radiation necrosis is fortunately uncommon, but can be managed with adequate treatment. A careful dose prescription in the plan evaluation can minimize the toxicities. Thank you.
Thank you. Thank you, Nikhil.
Thank you, Nikhil, for this enlightening us with the toxicity and follow-up schedule. I would like to invite the next speaker, Naveen Mumudi. He is Associate Professor, Department of Radiation Oncology at Tata Memorial Center, Mumbai. He will be speaking on de novo lung with brain metastasis. Naveen, please.
Thank you for the introduction. A very good afternoon to everyone again. So my topic today is to talk about, my role is to talk about de novo brain metastasis in lung cancer. There is going to be some amount of overlap because the last couple of talks have covered most of it, and these are my honest disclosures, so please bear with me. So the outline of my talk is this. I'm going to talk about the incidence briefly, and I'll also talk about the various treatment options that are available in patients who have de novo brain metastasis, and how do we prognosticate these patients when we are deciding on their treatment, and how do we change their treatment or tweak their treatment in the context of the therapy that they subsequently receive. And also we'll see about a few special situations. So we have heard about lung cancer having a high incidence of brain metastasis, and this is possibly because the tumor cells per se are fertile seed, and also the brain provides excellent breeding ground for these fertile seed. Generally, the location is in the gray white matter junction, and the commonest location is in the cerebral hemispheres. While NSCLC as such has high incidence of brain metastasis, the incidence is even more higher in patients with EGFR, ALK, or ROS1 metastasis. As high as 30 to 40% of these patients can have brain metastasis at presentation, and some more do develop more brain metastasis during their treatment. The cause of this high incidence is not clearly understood, but it could be because of the fact that these patients have a higher survival than your non-muted patients. So they're going to survive longer. You're going to image them much more frequently. So that's the reason you're going to pick up these metastases. Also, the conventional older agents that have been used, the systemic therapy, have traditionally known to have poor CNS penetrance. And also there might be some tropism which is poorly understood, which could lead to this high incidence. So what are the treatment options that we can give these patients? Broadly, they can either receive local therapy, or they can get systemic therapy, or best supportive care, all in combinations or in isolation. So the treatment principles, how do we guide our treatment principle when patients present with brain metastasis? Historically, what has been the thought process is that these patients who present with brain metastasis have a poor prognosis. So there has been a therapeutic nihilism saying that anyway, they're not going to do so well, because this is all based on older reports where they found that patients who receive whole brain RT or steroids don't survive for more than 3 to 6 months. However, last few decades, we have seen that we have made leaps and strides in terms of therapeutic advancements, and also the molecular profile has completely changed how we treat these patients with lung cancer. And what is also important to remember is many of these patients who present with brain metastasis have a significant symptom burden, which adversely affects their morbidity and also impacts their mortality. So it is very important that we address these brain metastases and not sweep it under the rug. So the principles that we use while we are deciding on the treatment options are that we make sure that we reduce the symptoms as much as possible. And also while we are choosing the treatment, we also try to improve the local control as much as possible by preventing local recurrences and also the intracranial failures. At the same time, we do not want to increase their toxicity, increase the treatment-related toxicity, both acute and chronic. And ultimately, we want to improve their patients' quality of life, and to a certain extent, also try to see if we can improve the survival itself. So the treatment options that are available, the first and foremost, which has been time tested, is the surgery. Surgery, the place for it right now is that we restrict to patients who have large metastasis, who have symptomatic disease because of mass effect or the location per se. If it is in the posterior fossa, we do surgery for these patients. And typically these are solitary metastases with a good general condition and controlled extracranial disease. And sometimes it also serves to provide you with a histological confirmation And in certain patients who have radio-resistant histology, the perceived radio-resistant histology, these patients could undergo surgery. So with the recent advancements in neuronavigation and guided surgeries and intraoperative monitoring, surgery is no more as morbid as it used to be. Despite good surgery, post-resection, many of these patients can develop recurrences as high as 50% at 1 to 2 years. The other commonly used modality is whole vein RT. It's one of the unique things that in patients, regardless of how many number of lesions the patient presents in the brain, we have been historically treating them with whole vein radiation, as opposed to somebody who presents the lung metastasis or the liver metastasis. We don't treat the entire organ, but here we do. And this is basically because many of these patients have significant symptom burden, and you have a poor penetration, poor prognosis, and you know that the systemic therapy is not going to penetrate as well. And also conventionally our techniques are limited. So we used to treat them with whole vein RT. But one of the advantages of doing whole vein RT is that you have micrometastasis, which can be lurking in the brain parenchyma, which you are addressing it. And also to a certain extent, whole vein RT can break down your blood-brain barrier, which can lead to better penetrance of your systemic therapy. The downside of all this is that there is neurocognitive decline and also certain acute side effects which we need to deal with. There have been recently certain advancements that we have done. We have tried to do hippocampal avoidance, whole vein RT, as the previous speakers are showing. You can also use either a simultaneous or a sequential boost so that you can increase the dose to the gross lesions as such. And also Mementin, it's an NMDA antagonist, can also reduce some of the neurocognitive decline because of whole vein RT. SRS, we have been using ever since 1990. We initially started using it only for less metastasis, but now we are treating as many as 20 metastases with SRS. And what we need to remember is the dose that we use in SRS is basically you tailor it to the number of lesions, the lesion location importantly, and also the volume of the tumor that the patient presents with. And these are some of the guidelines, the RTOG trial, which showed us a way how you could tailor your dose depending on the size of the disease. And the setting of SRS could be either in a definitive setting, or it could be post whole vein RT as a boost, or you could also do something like a SRS followed by whole vein radiation. And post-operative patients also receive SRS. The fourth and the last treatment modality is the corticosteroids, which is largely underutilized or sometimes overused. It can waver between these two. What it does is that it basically stabilizes the blood-brain barrier and thereby reducing the cerebral edema and improving symptoms. And you have various guidelines as to how you need to go about administering these corticosteroids. Generally, we prefer dexamethasone because the mineralocorticoid activity is slightly less. So the evidence that has evolved for the treatment of brain metastasis in lung cancer is that these trials have compared between various combinations and in various settings. And we have trials which have looked at whole vein RT versus best supportive care to trials which have treated more than 30 brain metastases. I am not going to bore you with this table, but what I'm trying to show here is that this is a table which shows various studies which have compared whole vein RT with local treatment and whole vein RT. And what generally they have shown is that you improve the local control by giving an additional focal therapy, and possibly you improve the overall survival in patients who have solitary metastasis. Can you do away with whole vein RT? So these are the list of trials which have looked at local treatment alone versus whole vein RT plus local treatment. And what they concluded, I mean, at least what I could infer from these trials is that they definitely improve the local control, or the local control between SRS versus whole vein plus SRS is similar, or it could be slightly more with the SRS because you're delivering a higher dose, but there is no survival benefit. And of course, because you're not treating the entire brain, your neurocognitive outcomes are much, much better. So where we have started is that we are using whole vein RT where you had patients who had limited survival. So your priority was trying to get their intracranial disease under control, but you ended up having neurocognitive decline. But now we are kind of moving away. We have moved away to concentrating on focal therapy where, because you have long-term survivors, so you want excellent local control along with neurocognitive preservation. So Dr. Upasana has again gone through this prognostication, how we go about. So the initial, the RPA classification was for, mind you, all disease, and the Sperdutos 2008 paper, the GPA was again for all diseases. So they used various factors. Let me just skip these lesions. This is the most recent. I strongly suggest the students at least to go and look at this paper. So where we have ended is that how we choose the patients is based on their physical condition and their disease burden and the biological behavior. So these three things are important while you're considering what kind of a treatment you are going to offer to these patients. And there are various decision trees which I'm not going to go and look at. But once you've chosen the right kind of patient, it is not just the patient alone whom, I mean, that's not the only factor which will make you decide what kind of a treatment, what you're going to do. It also depends on in which context are you going to offer your radiation. So if a patient is going to get systemic therapy, you know that traditionally, historically, it's not going to be a great CNS availability unless you are using certain agents like pemetrexed and carboplatin, which have a slightly better objective response rates within the brain. If not, you would definitely want to do whole brain RT or even SRS for these patients who are receiving only systemic therapy. Targeted therapy has completely changed the game. We know that the CNS penetration is progressively it is better with the higher, the newer generation molecules, both in EGFR and ALK-TKIs. And there are multiple studies which have looked at it, and what they have shown is that the objective response rates within the CNS and also the median duration of response are as high as 90% in osimertinib and lorlatinib, and also the duration is as good as 1.5 to 2 years. So that is what we need to keep in our mind as to whether these patients are going to get whole brain RT alone, or are we going to give these patients only SRS. But what you also need to remember that when you're looking at these trials, there are a lot of heterogeneities, because many of these, the way they randomized patients and recruited patients are largely variable. So what you need to also remember at the end of the day is that if the patient is going to receive only TKS, it is going to give you a good durable response, but still it's in the range of 12 months, 1 year. And many of these patients are eventually going to fail. While you have a modality like SRS or whole brain RT, which gives you excellent local controls, why not combine them whenever there is an option? So asymptomatic brain metastasis, I know you might be expecting me to give you a final word on this, but we do not have as we stand. One of the options is to give TK and early radiation. There are certain trials which are looking at it. Hopefully in the next couple of years, we'll have some idea where we are in this setting. There is some risk of increased radionecrosis, especially when you use certain agents like erlotinib along with SRS. So this is again something you need to keep at the back of the mind. So this is what we generally follow in our clinic. When patients are symptomatic, we definitely offer them local treatment along with the systemic therapy. But if they're asymptomatic and if they have a driver mutant disease, there is an option of giving them a third generation TKI and reserve RT for later, especially if the lesion is small and not causing them issues. Now, with the advent of so much of immunotherapy, we need to again see this in this context. Although CNS is regarded as an immune privileged site, it is not really so, because some of these studies have recruited patients and have shown the value of intracranial, the value of the checkpoint inhibitors, even in reducing the brain metastasis rates. As Dr. Nikhil was showing, there is a slight issue when you combine ICI and radiation, although you might think that it increases the antigenicity and the response should go up, but there is a slight risk of radionecrosis. Is even more important when you're considering certain histologies like melanoma, and if you're combining with ipilimumab, there is definitely a higher risk of necrosis. Leptomeningeal disease is something that you should remember about. Many of these patients, not a very great majority, but small percentage do present with leptomeningeal disease, slightly higher incidence with your driver mutants, and they traditionally have a poor prognosis. You do offer them chemotherapy, intrathecal methotrexate is something that has been tried, and we do not generally offer whole brain RT unless they are symptomatic or they have some focal disease which you want to address upon. So to summarize, we have kind of moved from where we were in therapeutic nihilism, where we were not doing too much, to now in a situation where we are spoiled for choice. We have so many options and it's hard to choose between these agents, but we need to be careful in how we choose these patients for what kind of a treatment, and we need to understand to a certain extent, try to understand what their tumor biology might be, and the future definitely looks optimistic. Thank you for your time.
Thank you, Navin. It was very informative.
Okay, thanks, Naveen, once again. I would like to call upon the next speaker, Sridhar ES. He is a senior consultant radiation oncologist at ACG Bangalore, and he will be speaking on the role of SRS, in multiple brain metastasis. Over to you, Sridhar.
Thank you, Dave. Good to see you. I came because that you will be coming. I didn't know that you're going to do an online. So good friend. So at the outset, I really thank Thiranjan Basu for inviting us. And I came mainly because to meet a lot of our friends. Good to see a lot of our friends. So probably 5 to 8 minutes, because everybody has already covered what is required. And now I'll be going to the more practical aspects and our experience. So there's already touched. So any patients, especially the lung cancer and triple negative breast cancer, please make sure that they are evaluated, especially for brain metastasis. Brain metastasis should not be considered as one of the detrimental as a prognostic factor. Now we are looking for 85 to 90% local control with the help of SBRTs. And definitely we should make sure that it is treated in a proper way. So incidence goes, the lung becomes the first one, like it, breast and lung and GI tumors are the most common. If you see overall, cerebral hemisphere is one of the main things what we are looking at. Isolated, like we are talking about hippocampal sparing. So there is a selection criteria for that. We have to make sure within 2 centimeters there is no metastatic lesions. Isolated hippocampal metastasis is very, very rare. Probably like I've seen only 1 or 2 cases where like the nearby, but isolated are very less. So brainstem, eloquent areas, all this has to be taken into criteria for whenever you are treating, making a decision. Symptoms versus asymptomatic, this is a very controversial. So especially nowadays, now with the newer trials coming up, this is like it's entirely depends on you how you're going to treat. MRI is the gold standard. We are aware of that, but you should be very careful. PET CT scan should be a part of your planning for like ruling out the other areas. Definitely PET-based increasing the SUVs is going to make a difference. So treatment options, radiation, surgery, supportive care with dexamethasone is another one. And targeted agents is already talked about. Asymptomatic patients wait and watch for up to 1 to 2 years, even if it is a progressive lesions. If it is asymptomatic, there is trials which says that you can continue TKIs. So treatment decision factors, we've already talked. Site and size of the size makes a lot of difference in terms of degree of mass effect and edema. Functional status, we know we are already dealt about this. So favorable prognosis and poor prognosis becomes a very, very borderline. Like in terms of decision making, everybody should go through these 2 articles, treatment for brain mets, ASCO guidelines and ASTRO guidelines. So the limited brain disease, if you see ECOG, most of the times ECOG also depends on your patient symptoms. If there's a single lesion with an eloquent area, if there is ECOG goes down, it falls into the other group. You should be very careful about that. And I definitely prefer that the patient condition and the systemic disease control is one of the things which makes me to take a further decision. If you have a good surgical approach, neurosurgeons one, if you see the size of the lesions here where they're talking about, initially it was 3 centimeters. Now we are talking about 2 to 4 centimeters. Number from 4 lesions, it has come to 5 to 10 lesions. So it is a moving target and definitely we have improved. What is important to know is proportionate of microscopic disease in the other parts of the brain is probably the one which is making a clinical decision here, and availability of the resources. Extensive brain metastasis, all the, like we have an option of stereotactic radiosurgery, fractionated stereotactic radiosurgery, whole brain, hippocampal sparing with neurocognitive functions to be taken into care. So surgical approach, yes, if it's asymptomatic, easily approachable, neurosurgeons, it has to go inside and remove as much as possible. And I feel that sometimes if you are giving same options without the surgery, you should go for the non-surgical approach. And because complications of surgery is also delays further treatment. Radiotherapy, yes, we talked about hippocampal avoidance, whole brain RT, 30 gray in 10 fractions. It is not, if it is not there, nothing to worry. 30 gray in 10 fractions becomes like a blanket treatment. But as much as possible, you can definitely increase the dose to that. For a microscopic disease, it is definitely better. For the gross disease with a different histology, it makes a difference. Probably dose escalation locally it dictates the overall survival and local control. SRS, I'm not a SRS guy. I don't practice single fraction anywhere in the body. I prefer 5 fractions, 3 or 5 fractions. Even if it is less than 2 centimeter, I've given 10 into 3, 30 gray in 3 fractions to the primary, the smaller area less than 2 centimeters single rather than a single fraction. Because there's an history, because when we are in AIIMS, we have seen like many patients coming for the follow-up whenever giving a single fractions with the central necrosis symptoms related, the patient's treatment related symptoms were more. So probably the local single fractions may increase the like central necrosis. Fractionated SRS 10 to 35 gray, 2 to 5 fractions. I'll tell you why I'm putting 2 gray as one of the boost and 5 fractions. I've given 7 into 5 also, the 35 gray depending on the histology. Like simple example, a CA lung presenting with a single lesion. So I prefer to give a 7 into 5 with a radical approach to the both the areas. Complications, we know that the edema is actually not really the one what I'm looking at. Central necrosis causing the edema is one thing which is, and all other factors we are already talked about that. There is a lot of things which is coming up to avoid these things. Probably the stereotactic, the fractionated SRS makes a lot of difference in taking care of the symptoms. The edema is less post-treatment according to me in these patients. We are already talked about memantine and the neurocognitive. For yes, when you are talking about SRS, we now move to a more than one lesion, to multiple sites SRS, especially in the brain. So now we are talking about up to 10 lesions. Like I've done only 10 lesions for SBRT, more than 10. No, I've not done FSRS. So we have the different machines. CyberNet scores over all of these things, even if it is a lung or in case of brain, because multiple sites, stereotactic radiosurgery, like fractionated, will definitely easy, or like we can tackle it in a better way. So I don't want to show this. Coming to our experience, that is where the practical, we talked about theory, everybody showed the different one. So I have reached almost around, we have reached around 5,000 patients. My contribution is almost around 4,000. Lung, it's 411 patients. And bone metastasis, around 500 patients now. And primarily the breast, the lung is second one, around 136. So lung with the different one. So we have around 192 patients. Brain metastasis is around 92. And lung metastasis from a different area is 148. How we do is like we are all know about that complete neurocognitive and brain lab is important, especially in the brain metastasis. All lung cancer should go for biopsy, IHC and genomics, because driver mutated, the mutations, the treatment is definitely entirely changing. PET-CT is absolutely important. I insist that at least for first year, once in 3 to 4 months, give a PET-CT, get a PET-CT based treatment. It definitely is going to make a difference. MRI, I told you that like as a screening, make sure that any lung patients before going to the particular treatment should get an MRI, and also the triple negative breast cancer. And MDT decision is important, follow-up is important. So what is you're seeing that the different lesions, so multiple brain metastasis, fractionated. So 1 to 5 lesions is the one what I still go for, like fractionated 5 fractions SRS. Less than 5 centimeters, everybody told it's 4 centimeters. I'm practicing since long time. 5 centimeters is the cutoff. And the more than 5 centimeter chances of microscopic disease in the other places will be more. Supra or infratentorial lesions, as nobody has told, that is, I feel that anywhere in the supra and infratentorial suppression also makes a difference. If it is one area, either supra or infra, more than 3, then you should go for, if it is less than 3 lesions, you can still go for the fractionated. 25 to 30 gray. Re-radiation setting, there's no doubt that we had to go for SRS, fractionated SRS. Post-op cavity, we're already dealt with. And especially in post-op cavity, you can, if it is a cerebellar lesion, posterior fossa, do only SBRT to the lower, the posterior fossa. And if it is a multiple lesions in the supratentorial area, we can give whole brain to that. So that's some of the things we are doing it. In case of more than 5 lesions, whole brain RT followed by boost is the one. If you don't have the SRS like stereotactic facility, at least do a simultaneous integrated boost, 40 gray in 10 fraction to the primary and whole brain 30 gray in 10 fractions, other sequentially. This is more of a practical approach. Definitely you will see a better difference. I'll take 2 minutes. So this is one of the things what we need. Immunotherapy followed by SBRT combinations we have done. Day 1 immunotherapy followed by the SBRT. Some of the cases like, and as much as possible, please treat the primary tumor in all these cases where brain mets are there. And this is one patient where lung presented with the brain metastasis. So responds very well. She's still alive and doing fine without any problem. So another whole brain followed by the big lesions more than 5 centimeters, followed by the 2 fractions of CyberKnife. And radionecrosis is one of the things. Steroids may not be a very good idea to continue for a long time. I use bevacizumab as an anti-edema for these patients if the necrosis is more and its edema is going to be. So the time duration, in case of presentation, if it is a metastasis, I prefer to give higher doses and complete this one. If there is a duration is more than 2 years, then if the numbers are less than 5, we can directly do. This is another patient who had CA lung treated in 2010. After 2 years, he developed a small brain metastasis, and there was no metastasis elsewhere, and continued. And all this, most of the times there is a metastasis occurs. If there is a recurrence, dural mets are more common rather than the isolated mets. There's a post-operative treatment. The patient presented to the neurosurgeon, operated, and I've treated the primary and the post-op cavity and the supratentorial lesions as well. And the follow-up is also doing well. Immunoradiotherapy, yes, it is the in thing. Definitely we can consider for both the areas, the primary and the metastatic disease. Is one of the cases, first cases where we are given whole brain followed by SBRT and immunotherapy combination. So fantastic responses without treatment related. So we have small presentation done and presented last ASTRO. This is 3 years back. And we've seen that SBRT alone and SBRT with ISBT. And we've seen the most of this oligometastatic trial, brain mets was a separation, like exclusion criteria. We've seen that almost there's a definite advantage of SBRT versus non-SBRT. And with immuno-SBRT, we see that 5 months survival extra, and also mean overall survival is almost around 11 months extra. And immune profiling is another thing we have to look into. So to conclude, the SBRT or SRS is effective in brain mets. Local control is at the range of 85 to 90%. Definitely, we should not say that it should be considered as a palliative treatment all the time. Hippocampal sparing should be tried as much as possible and followed by SRS. If it is not there, at least consider for simultaneous integrated boost. Post-op SRS is absolutely fine. Dose should be range of 12 to 35 gray. SBRT to the primary in any of this brain metastasis, please consider the primary SBRT in the same setting. It becomes more viable, and combination of immunotherapy is going to make a difference. Thank you, my team, and your patient hearing.
Thank you. Thank you, Dr. Sridhar. I now invite Dr. Vinita Goel for the final session of the day, panel discussion on brain metastasis.
Thank you. So I think we are all running short of patience as well as time. Some people have to catch their flights also. May I quickly invite the panelists with me, Dr. Upasana Saxena, Dr. Ajay, I think, is there as a medical oncologist. Dr. Deepak Gupta, Dr. Kanu Patro, I think, is joining online. Dr. Nikhil, Dr. Naveen, and Dr. Sridhar. Dr. Sridhar, kindly come back. So I had already shared the slides and the cases with the panelists, and I expect a very quick answer from everyone. So we'll wrap up whenever the organizers give us the indication. So for everyone's information, a 65-year-old gentleman with squamous cell carcinoma treated with radical CTRT. 1 year later, this gentleman presented with headache, vomiting, and hemiparesis. He has symptomatic metastasis. PET scan showed that there is no extracranial disease. And on MRI brain, there is a solitary cystic large size metastasis with perilesional edema. So I think Upasna is missing. Maybe Dr. Naveen can start with this. That what is the optimal MRI protocol? You know, the basics are very important. What is the optimal MRI brain protocol for a patient with brain metastasis, especially, you know, when you're seeing a solitary metastasis and you want to make sure that you want to consider whole brain RT versus SRS?
So what we do generally in our institution is that in addition to the usual diagnostic MRI that we get, we ask for additional sequences, especially the 3DFS PGR, which is generally the SRT protocol where you have zero gap. Better now?
Yeah.
Yeah, so 3DFS PGR sequence is what we get, which is with contrast even, and it has got zero gap, so that your reconstruction is also better, and you are able to see in all three axial, sagittal, and coronal sections, so that you can evaluate it properly.
So good quality MRI. Yes, Deepak.
We in some cases we also advise to do a delayed MRI contrast sequence, because this help to better delineate the GTV, as well as you can pick up more number of metastases.
Any experience of using double dose and triple dose of contrast?
Double contrast actually helps you pick up even a 3 mm metastasis, especially if you're going to do a focal RT. It's really beneficial to take thin cuts, take a double contrast, which would detect even a 3 mm mets, which you would miss and would come back later in 2 to 3 months.
So one important lesson is that it has to be a high quality MRI, contrast sequences, 3D sequences, delayed sequences, and maybe double and triple contrast if renal functions allow. Has Dr. Kanu joined us? Dr. Kanu, are you there?
Yeah, yes, ma'am. Good evening.
Hi, Kanu.
Hi, ma'am.
Hi. So is your approach to cystic metastasis any different from solid metastasis? And how would you approach this patient?
So if the cystic metastasis is there, I will see the size first. And most of the cystic metastasis have genetical abnormalities like ALK fusion. So I will see if there is a cystic met is there. I will see the any midline shape or compression. I will go for the surgery first if there is a single lesion, and I will ask for more genetical mutations before going the particular treatment.
Excuse me, can you give one more mic here to the panelist? Okay, cystic metastasis, I think, denotes that the tumor is more aggressive. Cystic metastases are usually diagnosed late in large sizes, and that is why probably this patient was also highly symptomatic. Kanu, this patient had hemiparesis when he presented. So how would you approach this patient? Would you want a surgery or straight away go with radiation?
If there is a single lesion and a good extracranial control, I will go for the decompression. Then I will plan for the cavity SRS.
My other panelists agree with this approach of decompression. So I think everyone agrees because the patient is symptomatic and there is a midline shift also.
Not decompression. We want complete surgery for that.
Yeah, complete.
Okay. Complete surgical excision. So the expectations are very high here. But so this patient also underwent tumor decompression. There was immediate relief of symptoms and there was improvement in the neurological status. And later on, we gave this patient fractionated SRT. So Dr. Sridhar, would you, if you were to treat resection cavity here, would you do a single fraction? I know you're very fond of
5 fractions.
5 fractions.
I don't. 3 to 5. Actually, we can consider for 3. There is no eloquent area there. Yeah. We can go for 3 fractions as well.
Correctly. So
I also prefer 5 fraction schedule, because 5 fraction is nothing to do with the go and treat and one day and finish. So because if you see the cavity cavity SRS, we have to take the bone chip, cavity track, the surgical tract, and the dura. So better go for 13.5 is the standard approach we have follow.
Yeah, I know. Yeah, sure.
There is also there is this article which says that there is a defined volume of a cystic cavity. If it's more than 10 cc, actually, then your outcomes of a direct radiation, even if the patient is not symptomatic, if you directly take it up for radiation, your control rate would be lesser. So they've defined a 10 cc volume for a cystic cavity as.
There is also a small concept of putting in an Omeyer reservoir to aspirate some of these lesions so that your volume of radiation decreases. So I think all these means have to be attempted. The message here is that if you're giving resection cavity SRT, it has to be fractionated because you have to add a certain amount of CTV and then you have to encompass the whole irregular volume. Well, when you're treating a metastasis, then the shape is usually spherical or pseudo-spherical, where you can get good dose distribution even with single fraction. This is one such example of a good quality MRI, which helps you pick up these small lesions. So basics are basic. You should have a good quality MRI. So with this, we'll come to the next case. 50 years old lady, non-smoker. She had adenocarcinoma lung. She was treated with surgery, lobectomy and mediastinal lymph node dissection, followed by 4 cycles of chemotherapy. That time, the mutational study was not done. And 2 years later, she had an episode of seizure, by virtue of which a single metastasis was picked up. There was no extracranial disease. And this is the only site of disease. So my first question is to Dr. Ajay. Dr. Ajay, she's a non-smoker Indian woman. Do you need tissue for molecular profiling? Or, I expect that majority radiation oncologists would be very comfortable giving radiation upfront to this patient.
Yeah, ma'am. Presently, because of the role of the TKI or targeted therapy in lung cancer, so we definitely need a tissue, preferably tissue only, because in India or whatever labs we are having for liquid biopsy, we are not happy. So we'll prefer to have a tissue.
Why can't we do it on the previous lobectomy specimen?
If it is less than a year, then it is okay. But as the duration increases, that tissue become very degraded. So there is a less chances we'll get good DNA or RNA.
So liquid biopsy, old tissue, still there is a chance of
The mutations might have changed. That is his concern. It might be still EGFR mutated, but yes, Dr. Naveen.
And also there could be some discordance between your primary and the CNS. So it is always a good idea if you're able to get some tissue from the brain, you should go for it.
So surgeon, however, did a functional MRI for this patient and found that the lesion is close to the speech and the motor area. The hand grip area was close. So he refused for surgery. So Dr. Deepak, if this patient comes to you, single fraction SRS, multi-fraction, the whole brain RT, what would you do?
Functional MRI has been done if it is close to motor cortex. So it is, in our practice, it is more feasible to do a multi-fraction. Probably 27 in 3 dose would be good enough with a BD more than 50. So.
And what is generally the acceptable brain minus GTV dose for multi-fraction SRS?
Normally, we take it volume receiving 18 gray to less than 21 cc. And now high-tech guidelines also gives 20 cc less than 20 gray. That include brain plus GTV doses. So you can follow that.
Correct. So we did treat this patient with 27 gray, 3 fractions at 9 gray per fraction. She remained controlled and fine for 3 years. Then she actually had a local failure and underwent resection. And the molecular profiling was negative on liquid biopsy and previous sample as well. So this is an important paper. I'm sure some of you must be already knowing about it. This is from Minity et al., where they have compared 9 gray into 3 fraction versus single fraction for a large brain metastasis, and they found better control rate and lesser incidence of radiation necrosis. And in this particular paper, I think this was one of the first papers which talked about volume receiving 18 gray as an important dosimetric parameter to predict the risk of radiation necrosis. I think rather than knowing that we have to control the volume receiving 18 gray, you should also know that sometimes you cannot achieve it. So if you're not achieving, then what is the likely risk of necrosis can also be found from this paper. And as Dr. Deepak mentioned, high-tech as well as UK 2022 guidelines have also now incorporated that dose to 20 cc volume for 3 fractions should be less than 20 gray. So earlier we only had this dosimetric data for single fraction in terms of V12. Now multi-fraction SRS is finding its place, and there are better dosimetric papers on this. So another patient, another scenario, 60 years old lady, she had...
In the same paper, it has been clearly reported that control rate is better, radio necrosis is almost 50% less.
Correct. So I think that has changed people like Dr. Sridhar also. Otherwise, Sridhar was always doing single fraction.
Yeah, so I always use the 5 fractions. See, don't worry about radio necrosis. As long as if you're not taking a CTV margin, if your GTV is CTV, and if you keep between 25 to 30,
then it is very clear.
So then radio necrosis, what you are talking about is a central necrosis. Most of the times it will subside. It's a treatment related necrosis which is causing the edema versus the surrounding necrosis. I think we should differentiate.
So another patient, another tricky situation. Sometimes we see this 60 years old lady. She had extensive small cell lung cancer. She was treated with chemotherapy, followed by consolidation thoracic radiation therapy as well as PCI. And before delivering PCI, contrast MRI brain was done to confirm that there were no distant metastases. And she started on maintenance therapy with immunotherapy. However, she discontinued it after 6 months, and 1 year later, she had progression in lung as well as brain. And this is what her MRI looked like. Dr. Nikhil, any scope of re-radiation? I mean, I'm sure you can't do SRS, re-whole brain RT.
Ma'am, re-whole brain RT after 1.5 years is still feasible, but the doses which we usually follow is around 25/10 or even 20/10 if the duration is low less between the previous radiation and the current radiation schedule. So yes, repeat whole brain RT can be given.
Dr. Naveen, you want to add something?
Yeah, so this is a patient who's going to do extremely poorly, very limited survival. So I'm not really worried about chronic side effects. So immediate quick relief from symptoms if RT is going to help. Some short fraction should be okay.
So I think the message that we are trying to give is that even whole brain radiation therapy is feasible as a palliative approach and should be thought of to relieve the symptoms. So another patient, 55 years old lady with adenocarcinoma lung, she was treated with NACT followed by CTRT. She had a disease-free interval of 2 years. Good 2 years, she was fine. She was investigated for her brain symptoms, and then PET and MRI confirmed that there was a metastasis in the brain, as with a lot of perilesional edema and a solitary spine metastasis. She underwent surgery for this. It was adenocarcinoma, again, no mutations detected, and she was neurologically well preserved. So the question here is whole brain radiation therapy versus resection cavity SRS. Dr. Sridhar.
Absolutely, resection cavity as SRS.
Resection cavity SRS.
3 to 5 fractions.
And she wants
See,
to
these are the patients, actually, the dural metastasis is going to come at least minimum within 2 years. Even if you do this one, they'll fail you the dural mets.
Correct.
So
she will be at a high risk of leptomeningeal metastasis. Correct. And if the patient wants to know about her prognosis, I think Dr. Upasana has already discussed that we have to use this now graded lung molecular graded prognostic assessment score to define their prognosis. For this patient, it was turning out to be around 13.7 months of survival. And then we sometimes use this nomogram also to predict the chances of distant brain failure to choose the patients optimally. Dr. Naveen, coming to you, this patient was offered resection cavity SRS. She declined it. She said, I can't afford to have another recurrence. And then the cost of MRI also bothered her, 3 monthly MRI. So I'm sure you must be practicing hippocampal avoidance whole brain radiation therapy. Are you convinced about its benefit? What are the dosimetric challenges that you face?
So when we are talking about post-operative whole brain RT with hippocampal sparing, we generally do not have too many challenges. The challenge that we have is patients who have gross disease in their brain, and we have to boost those lesions to a higher dose along with whole brain RT. Then sparing the hippocampus becomes slightly an issue, and also the location, if it is close to your hippocampus, then they become an issue while you're trying to preserve the hippocampal region and deliver a good dose to the hippocampus. Memantine is not something that we use commonly in our practice, but there is good evidence to suggest that when you're doing whole brain RT, especially hippocampal sparing, and then you give memantine, there is some benefit in terms of neurocognitive preservation in certain domains at least.
Memantine is a cheap drug.
Of course.
So what is the hesitation in using it?
It's just
You're not convinced about
it
this?
is absolutely not. So I mean, there is good enough evidence to say that it is good, but the adoption has not happened really.
Okay. So Dr. Naveen, I can understand you said that if you have to do SIB, which means you're trying to give a higher dose to a gross metastasis and at the same time create a cold area in the hippocampal area, it becomes challenging. But suppose you have to do whole brain radiation therapy per se with hippocampal sparing, do you find dosimetric challenges, and generally how many arcs are put to optimize the plan?
So we are still using VMAT. So 2 arcs is all that we still do. And with that, we are reasonably able to achieve. If there is no gross lesion which we are boosting, we are able to achieve the constraints of a max dose of 16 gray and a mean dose of 9-10 gray. We are easily able.
What is the Dmax to the brain that you accept?
For 30 gray and 10 fraction
Correct.
that we don't get more than 105% is that.
Oh, that's awesome. So I was talking to one of the radiation
We
oncologists.
had to use around 4 arcs to achieve the constraint.
See, I was speaking to somebody and he said, generally our physicists put 8 arcs to optimize. That's too much. That's heartbreaking. Yes, it is not easy. It is not an easy plan to achieve. Dr. Deepak, any comments?
We normally use 2 to 3 hours, but in our practice, normally up to 10 brain metastasis, we normally treat with the CyberKnife. So in that there is no role of
The left compartment is totally CyberKnife actually.
All the arcs she's talking. So regarding the whole brain for this particular patient, like
Yeah.
it's how the patient get convinced whole brain is superior than the.
You have to explain to the
Yeah.
patient that she has a chance of distant brain failure.
No, that's what okay.
Okay.
That requires a whole. See, whole brain does not give that magic figure of 0.
We all know that in
Yeah,
oncology
then-
there is no 0 and there is no
So
100.
even if it is if it is a local failure or a distant one, we can still go ahead and do the
There
SPR.
were financial
like
issues, social
financial
issues, and
issues.
she said she
The whole brain
can't.
also costs anyway. Like it's
Yeah.
in terms of scientific, I feel that in a post-operative complete excision like this, local treatment, even if you do whatever it is, 3D CRT local is okay for it rather than going for a whole brain.
Agreed.
I have a small question.
Yes, Kanu. we forward-
When whole brain RT with hippocampal sparing, how much max dose you prefer?
Dmax dose.
Yeah. Because the trial and it shows is a 37 gray.
So
You are-
actually, Dr. Naveen, the point is that the guidelines say that dose to 2% volume can be up to 37.5 gray. Acceptable is up to 40 gray also, which is almost 130%.
The dosimetric data for the hippocampal sparing is much higher. What is usually we accept. I always fumble in that dosimetric study. So can somebody share some ideas?
I
have not really faced this challenge. So
So like this was our patient's plan. I was quite not satisfied after looking. You can see a lot of dose inhomogeneity. This is what 110 and 120% look like. Would you accept this? Or would a physicist from Nikhil or Upasana center say that I'll put another arc, madam, and I will, make it more homogeneous, and they will go up to 8 arcs. Yeah, let him answer, please, if you can give some inputs.
But the in tomotherapy, the plan are much better as compared to
I
the
agree. I agree. I think they are also keeping quiet.
We used to do with the 3 to 4 arcs according to this one, but I don't think this much hot will not be
And if
acceptable.
Dr. Upasana says that 110 is too much, so you'll add another arc?
Yeah, we normally go for up to 108 to 109.
So I think hippocampal avoidance whole brain RT sounds good, but is dosimetrically challenging to practice. And I think before actually starting a patient's treatment, few cases have to be given to medical physicist for them also to plan and go through the process. And my another concern is that gradually we are realizing that there are areas beyond hippocampus also. So I think finally the whole brain is going to be spared. They are talking about corpus callosum. So we don't know where we are heading. We'll just finish quickly. So multiple brain metastasis. My simple question is that you like to plan with a single isocenter approach or multiple isocenter with simultaneous optimization. You leave it to them.
So that should not be an issue. But as much as possible, I think we treat in other LINAC platform. So depending on the left and right, single isocenter and non, both can be planned.
Upasana, what are
We
you comfortable
prefer
with?
monoisocentric, ma'am.
You prefer. In monoisocentric, I face one challenge. When you're taking a CBCT, then you're taking one CBCT. You cannot separately match the two separate areas.
So in between, like intra, you have to take another image. That happens, ma'am. So the imaging frequency is higher, but then
I don't think so. The systems will allow because with the system will
System
allow
does
with
not
only one isocenter and match
One
the
isocenter
only.
will allow one CBCT and one correction. So that is when sometimes I have told my physicists to create plans with 2 isocenter. For few of our patients, we try, this is a single isocentric plan. So where they keep the isocenter between 2 or 3 metastases, and this is the multiple isocenter plan. And when we compared that, actually we did not find any dosimetric difference. Anything from you, sir? The literature says that it is lesser. Dr. Naveen, anything that you want to add?
Single ISO center causes more bridging dose.
Yeah.
So that is the more problem. But yeah, then we have to do extra ORs in between two lesions so that it will decrease the dose to the bridge.
Yes, yes.
So that is a more complicated situation. And the second thing is the whole brain what is should be the dose to the whole brain minus GTV. What should be, are you going to do the differential dose to the different brain lesions?
So if there are multiple lesions, then the the V12, V10 has to be evaluated for individual plans. So yes, so if you're doing a multiple fraction, it increases, but once again, it has to be assessed individually. The value changes because that's a spill per.
That's another question.
Yeah.
So it is better to continue with multiple fractions like 13 degree 5 fraction, keeping the 12 cc volume less than 27 gray. So what I feel, keeping single fraction dose and more breach doses between the two lesions causes more chances of necrosis rather than, and you cannot achieve the brain minus GTV dose 12 cc volume.
We'll hear from Dr. Sumit now.
So usually,
Dr. Basu wants to.
Yeah, Dr. Basu.
I just want to make a point, and this is, I think, practically, I think I've realized that if you set up with a single ISO center for multiple brain lesions, and then you do based on that CBCT, you do correction, that to a 60 correction, you probably are
Correct. Yeah.
So therefore, I personally would prefer different ISO centers for different lesions.
Triranjan, you wanted to add something.
Multiple means we evaluate 18, 21, like Tanveer also highlighted.
in
This
fact,
is
the
given
recent Astro says V20 and V24. V20 for
there's
3.
124 also. And I think Ratish, we done multiple also so the highest number we did is 10, I think, as of now. For that patient was strong EGFR positive, and with all explanation, they're not keen for whole brain.
Then how do you calculate the brain minus GTV dose individually?
No,
You
all
can't-
GTV a volume. So the whole GTV volume was coming up to just, I think, 5 cc or 4 cc. One lesion was only just 1.2
So you mean
centimeter. The rest all are.
small volume, large number.
Yes, exactly so. So that's what we did. The first MRI of that patient is done also, and it's very baffling. The larger one is vanished. The smaller ones are more or less same. Of course, there are 1 or 2 new smaller ones also. Dr. Sridhar will be very happy listening to this.
No, actually, here I differ. See, if you see that there is a trial, there are around 20 cases. One person has done more than 10 numbers, 4.5 centimeter lesion versus volume of 4.5 cc equivalent. They said that the multiple brain metastasis SBRT is better, the prognosis is better. So I don't really agree. We need to understand the proportionate of microscopic disease in the other parts is the one what we are looking at here. So the tumor which is already come up requires an higher dose. So that is what I want to do it. So 30 gray in 10 fractions is a microscopic disease. The tumor requires a more, and we need to escalate the dose to that particular point. If the proportionate of microscopic disease is not going to come back for at least at least 6 months to 1 year, I prefer to do only local treatment, full radical approach. But when you give a whole brain 30 gray in 10 fractions, if you do a 6-month scan, the lesions which are which will also pops up, we are unnecessarily thinking that it is a treatment, it is a disease which has come up. Probably it may not be true.
But for usually if you're doing whole brain and if there are larger lesions, so for us it's routine practice that we do a SIB of a higher
Absolutely,
dose.
14-10 works out better. People cannot say that I don't have the facilities. SIB works out very well. Either Simon.
SIB or stereotactic boost.
No, I am talking about like
Whole
stereotactic
brain
boost
radiation therapy.
followed by boost. 10 gray 2 fractions is the one what I give it.
Stereotactic boost. you
Yes.
can say. And
So if you
she
don't have the
does SID.
facility, that's what. If you don't have the facilities, 40 gray in 10 fractions to the tumor site, whole brain 30 in 10, which is very much achievable, but hippocampal sparing may be a little bit difficult. Increase to 18 gray. 18 gray point dose can be achievable.
Other issue with the CB is the volume of the lesions also.
Correct.
So we have just currently treating a patient of adenocarcinoma lung, a girl. Mutations are awaited, but she is symptomatic, so we are treating. So there are 7 lesions, and we are planning to treat the 13, 10, and 14, 10. but we could not achieve the constraint for that because the volume were high. So we had to reduce to around 33
But
or
it's
35.
very common to see number maybe more, but whole volume is less. It is very common, and this will be more with EGFR positive and all these area. This is going to be more.
So that is why I prefer to have sometimes multi-ISO center plans, but simultaneously optimized. So one last situation I will give you. So this was a 50 years old lady. She had ALK mutated CNS metastasis, both lung and brain met was simultaneously detected. She underwent single fraction SRS for this lesion, as well as she was started on alectinib. Now, 1.5 years later, she had a recurrence here. I mean, she presented again with symptoms. We did a MRI, which showed that there was a reappearance of this contrast enhancing lesion. We kept in mind that this could be a radiation necrosis because, yeah, and MR perfusion also confirmed it. We put her on steroids. She took it irregularly. Her symptoms worsened and she underwent surgery, and surgery showed that there was only necrosis. There was no viable tumor. This is what is expected. My question is
Just go back. So these are the patients I'm telling that, like, if the steroids are not able to control, just give 100 milligram bevacizumab. It responds very well. And MRI, especially MRI, should be the MRI assessment of an stereotactic radiosurgery doses. Should actually the enhancement pattern increases more than 50% of the time. They all keep on telling that there's a progression. I think RANA criteria has to be revised for the SRS dose.
Agree. If you're giving bevacizumab, then how many cycles you will give, Sridhar? How many cycles?
Six cycles, 100 milligram once in 28 days. You will see actually with the 4 days after that itself will
Standard
start.
dose of 100 milligram or per kg body weight?
Flat dose.
Flat dose.
I would rather start the patient on steroids. I mean, I wouldn't jump and start with bevacizumab because bevacizumab for all birth, it is still an expensive steroid.
Correct.
So if you're going to
It's
give
an
it for a very long
expensive steroid.
duration, or
No, the
patient is
steroids
refract-
on steroids for 1 month afterwards, the diabetes and the hypertension is more expensive.
more than a month, then I would think of giving something.
So anyway, this lady underwent surgery and histopathologically it was only necrosis. My question is that all of us understand that ALK mutated CNS metastasis or EGFR mutated patients are likely to survive more, and even the incidence of radiation necrosis is higher in these patients. Also, is there any data on dose de-escalation for SRS doses in patients who have these mutations? That is the question. Single fraction.
The best thing is to avoid radiation in these patients, especially if you have a good agent which is going to have a
Good
CNS
penetration.
penetrance, then
Correct.
possible. And if the patient is asymptomatic, one of the options is not to treat these patients and wait for.
But if you are
progression.
giving radiation, then full dose, whatever is
I
required
think as
as per the
standard
volume.
treatment, we would do that because the lower the dose you would give, you know that your local control is not going to be good.
So thank you so much, panelists. Thank you, Kanu. Thank
Thank
so
you,
much.
ma'am.
We are winding up. Yeah. Thank you, Dr. Thirinanjan.
Thank you so much, Dr. Vinita, as well as all the panelists for a wonderful discussion. I'd like to conclude the session. I'd like to thank before that Thirinanjan as well as the organizing committee for giving this opportunity. Thank you so much. Over to the organizing committee.
Thank you to the chairpersons. I think Sharmila ma'am left. Thank you, Sandeep da. So we come to the valedictory. I would like to couple of people to thank. I would like to thank CRSF for the opportunity, whole 5th edition Lung Masterclass group, all the faculty members, the chairpersons, many of our teachers, mentors, our friends, colleagues who have flown across the country. So without wasting much time, we'll just have a quick group photo, then we can break for lunch. So please everyone come to the stage for group photo. Sir. Sumit sir. Photo please everyone quickly. ये इनको हटा दो ना. इनको हटा दो. उपासना. बाहर से बुलाओ ना थोड़ा.